Good morning, Mr. Khemka. Mr. Khemka, am I audible, sir?
Hello?
Sir, would you like to unmute yourself? Yes, I can see you now. Sir, this is Swati. I'm unable to hear you.
Hi,
Sir,
Swati. Hi, Swati. Is it okay now?
this is better, sir. It's audible. Thank you.
Thank you, Swati.
Sir, am I audible, sir?
Hello?
Sir, would you like to unmute yourself? Yes, I can see you now. Sir, this is Swati. I'm unable to hear you.
Hi, Swati. Is it okay now?
This is better, sir. It's audible. Thank you.
Thank you, sir.
So, this is Tanya. Yeah, Karan?
Very good morning, Professor Mamun. Hello.
Assalamu alaikum. Good morning. Good morning. Can you hear me?
Yes, Mr. Mamun, you're very audible. Thank you. And I've
Thank
received
you.
the presentation, sir. Thank you.
Okay. So everything is ready, right?
Very much so.
Okay, thank you.
Thanks.
Is there any presentation involved in this? Hello.
Mr. Chakrabarti?
Yeah, is there any presentation going to be given by any speaker?
Sir, Mr. Mamun would be giving a presentation and Dr. Vijay.
So that will be at the beginning.
Sir, just give me a minute. I'll call you back. 1 second.
So
A very good morning to all the distinguished panelists. So we are about to begin the session. Allow us another 2-3 minutes. Thank you.
ऐसे क्यों हो रहा है? हाँ? नहीं, मगर पीछे ये आ रहा है. I'm going to moderate your session. How are you?
Good morning, Mr. Chakravarti. This is
Hi,
Manish
how are
Katta
you?
from Nepal.
Yeah. Hi, how are you? Do you
I'm
have a
good, Mr. Chakravarti.
presentation? Do you
No,
have a presentation?
I'll speak briefly. Briefly share some of my points.
So you have any points what I should ask specifically?
Basically, I'm going to talk about how this pandemic affected the world economy, and then and how the preparation and the response from the Asian countries, especially Nepal.
Now you are going to cover which countries other than Nepal?
I'm going to talk about in general about the global responsiveness
Okay.
in Asian countries and then Nepal
Okay.
as such about the Asian countries, and then also talk about some of the investment which can be done to prevent the outbreak of such pandemics in near future.
Okay. So I understand there are two presentations, one from Professor Mamoon and from Sri Lanka. and third, I'll invite you and ask you these questions.
No
So
problem.
is that okay?
It's
So
quite
Professor, what is the duration of your presentation going to be approximately?
It's a 5-6 minutes,
Oh,
or I don't know how much. I heard it could be 10 minutes. I'm not sure. Can you
see,
guide me?
my initial plan was that I am going to ask three of you 2 rounds of questions, maybe of 5 minutes each. But now you take the first rounds as a presentation. You can even take 7 minutes, no issues. Then in the second
Okay.
round, I'll ask some specific question which will arise out of your presentation. Okay. And what I will do
Yes.
initially I will give the introductory remarks, and then I will, ask each one of you to introduce yourself, and in a 30-40 seconds, you can have a brief introduction of yours, and from there I will go one by one to first to Mr. Mamoon, and then followed by Dr. Vejamuni, and then I'll go to Mr. Manish, and then after presentation and first round question, I'll ask some questions specific to your country from where you are coming, or the topic what you are raising during your presentation. Is that okay?
that sounds okay to me.
So good morning, Dr. Vejamuni. You're mute. You're mute. You have to
Okay.
unmute.
Now okay?
Yeah, now you're
Okay.
able to.
Can
Yeah.
hear me well? Okay.
Yes,
Okay.
I can
Right.
hear you.
Okay. And what's your good name? Sorry, I must write down.
My name is Joy Chakraborty.
Okay.
So I
Right.
am going to moderate the session.
Okay. Okay. Right. So we are waiting for another two more. Is it the one
No,
more?
I think all the panelists are here. It is only a matter of time
All right.
that
Great. Okay.
will be given. So
Okay.
what you are going to cover, because you have come at the end, so I had
Yeah,
an
that's right.
initial chat.
Okay.
So what is the topic you are going to cover?
Yeah, it's basically the public health and pandemic enablers and barriers. I saw that there was a change to the topic like Asian perspective on what worked and what did
What
not.
confirmed? Huh.
Asian perspective on what worked, what did not work in tackling COVID. We basically covering the Sri Lankan scenario with special reference to Colombo and how we controlled it, and what were the enablers and the barriers that we face, and because we have a success
So
story to tell those.
you'll be covering the Sri Lanka story.
Exactly, I'll be covering the
And
Sri Lanka.
how much time it will take for your presentation?
I timed it to 8 minutes.
Take. So what
Perfect.
I'll do after your first round, like both of you have presentation and Mr. Manish is going to
Yeah,
his introductory talk,
yeah,
and then followed by I'll be asking the second round of question which may arise out of your initial talk,
right.
or the points what I feel pertinent to Sri Lanka.
Okay,
But
great.
I must compliment the kind of numbers what I have seen. You people are able to control the COVID. It is really,
Right. Okay.
very
Yeah.
nice to see.
I have sent my presentation if you want.
No,
Viewers to
that
use it freely.
presentation will be, given. I am sitting in Bombay
Ah,
and the host is in Delhi, so they will be putting up when I tell that for your
okay,
presentation,
great. That's
and
fine.
they will be operating it.
Okay, great. That's fine. So they can use it freely, no problem. They
Yeah.
feel free to let them feel free to use
Yes.
it. Okay,
Yes.
okay,
Yes.
okay, Mr. Yeah, great.
Good morning, Dr. Memoon and Dr. Vijay Muni from
Good
Nepal.
morning. Good morning to you. All right, okay, okay. Good morning to you.
A very good morning to all the distinguished panelists. Yesterday, we had some interesting deliberations on the TB campaign and on other public health issues. Today, we are starting with the deliberations from the Asian perspective. We have a very interesting panel. From India, we have Mr. Joy Chakraborty, Chief Operating Officer of Hinduja Hospital, in conversations with distinguished panelists from Bangladesh, Nepal, and Sri Lanka. Over to you, Mr. Chakraborty. Thank you.
Good morning, Swati, and a very good morning, and welcome to all the speakers for the
Make a-
session and the delegates who are participating in this India Healthcare Week organized by CII. It is a 2 days conference which is a part of this week, and a lot of interesting topics are getting discussed and deliberated in this 2 day session. And today we begin the second day with a very interesting from the point of view that how we are faring in this time of COVID and what are the things we need to learn from the Asian perspective. So the topic is that public health and pandemic, Asian perspective on what is working and what didn't in this COVID scenario. So all of us by now over the last 5 6 months have experienced, though it has started almost 8 months before in China. And what are the things as taken as a strategy? Some of the strategies are prioritizing health over economic concern, like whether you should give priority to health, start going for lockdown, start closing your business and acting on it. And it reminds me, in the month of April, our Prime Minister Sri Narendra Modi used one phrase, "Jaan hai to jahan hai," means if you have life, then only you can enjoy the world. The next is the success is going to depend on providing excellent public communication, that how you're communicating with people, getting them on board, and you're fighting in this battle. The third, according to me, is enforcing early border control. So some of the countries who have controlled their border at the right time and controlled it well, maybe some of they have not come across the major challenge. And fourthly, moderating behavioral changes. Like when you have lockdown, how strictly you are following this, what kind of widespread of use of masks and other things which can stop and prevent this infection. These are some of the strategy in a different way taken. And testing remain the focus. That more you do the test, you can get a feeling or sense of the kind of infection rate you have, facility of isolation, doing quarantine. So some of these words have gone in a long way for last few months, and we try to adopt. But interestingly, we have some places like success stories like Thailand, Vietnam, and Laos, and some of the countries in Asia, whereas in some places it has not been, successfully adopted or successfully, taken. So now, uh, I'm going to take some of the examples that where do we stand. We have participants representing countries like Bangladesh, Sri Lanka, Nepal, and I'm there from India. So if we see, as on yesterday at 11 a.m., India had a caseload of total positive case of 26 lakhs with a death of 50,000 plus with a case fatality of 1.9%, whereas Nepal had 26,000 positive cases so far, with 104 deaths, with 1.3% total deaths. Sri Lanka with only 2,893 cases, with 11 deaths, where case fatality is 0.31%. And Bangladesh with 276,549 cases, where total deaths were 3,657 with 1.3% case fatality ratio. So different countries have different stand at this point of time. So definitely certain things have worked well and certain things didn't. So we are going to hear from them, and also we are going to get some insights, what is happening globally according to them, what is the kind of suggestions, what is the kind of perspective they have in the global front. So with this, I'm going to start the session, and I want to uh, take the names of the distinguished panelists. Mr. Hodenkar Abdullah Al Mamoon is the founder, CMED Health, a preventive healthcare initiative, professor, Department of Computer Science and Engineering, founder and director, AIMS, Lab United International University, Dhaka, Bangladesh. So I request Professor to introduce himself in brief.
Very good morning. Very good morning to everyone. I think everyone hear me very clear, right?
Yes, yes, we can hear you.
Thank you. Thank you so much, CII, for inviting me to speak about this conference, India Health Week. It's like opportunity to actually share our experience and as well as do collaboration because we are passing the COVID-19. So during the COVID-19, it is very important to work collaboratively in between the countries to actually address the pandemic. So here I would like to share my presentation on like what we are doing in Bangladesh on digital health and how in 4 months ago when we COVID-19 started, how we actually try to address COVID-19 using digitalization. That's why I named my presentation is digital health and COVID-19 pandemic. So should I share my presentation from here? Okay, thank you. Can you make a full screen, please?
Request not to share the screen now. I'll request all the panelists to introduce them and then we'll go to the presentation.
Okay, 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 okay.
Our next panelist is Mr. Manish Khemka, Executive Director, BLC Holdings, Nepal. May I request him to introduce himself? Can I request to stop sharing the screen? Yeah, over to Mr. Khemka. You have to unmute yourself.
Thank you, Mr. Chakravarti, and good morning from Nepal to all the distinguished panelists and all the participants in this great event. I would also like to congratulate CII for hosting this kind of event on digital platform. It is such a massive event they are organizing on and successfully on the C platform. I'm quite impressed. So I'm executive director of BLC Holdings Limited, which is a subsidiary company of Chaudhary Group. We also run a private hospital in Nepal, 150-bedded private corporate hospital in Nepal. And today I'm going to talk about the COVID-19 impact on the world as a general and Asia in Nepal, and some of my like suggestions on what we can do in near future, how we can invest in near future to stop the occurring of such kind of events. So this will be the broader contour of what I'll discuss.
Thank you. Thank you, Mr. Manish. Now we move on to our next panelist, Dr. RLDS Vijamuni from Sri Lanka. He is the Chief Medical Officer of Health, Public Health Department, Colombo Municipal Council, Sri Lanka. So over to.
Okay, thank you, Joy. Can you all hear me? Yes?
Yes, yes.
Okay, right. So, CII for inviting me to join this very important conference. From the day one, the COVID hit Sri Lanka and Colombo. I was the team leader of the city's Colombo city COVID control team. And I would like to share how, from the Asian perspective, what worked for Colombo and Sri Lanka and what did not, and how basically we have experience to share with you all. Thank you very much.
Thank you, Doctor.
You call
So
me.
now I move on to I move on to our first presentation, I request Mr. Mamun to give his experience, thoughts, and share the presentation here. Can you share his presentation?
Thank you so much, Chakraborty, for addressing me to present. So, like last 6 months, we are actually suffering COVID-19. This is something we never experienced. So, like in Bangladesh, we are working on digital health and to create the health inclusion towards universal health coverage and SDG. So last 4 months ago, during March, when the COVID-19 started, we immediately focused on COVID-19 to actually address the pandemic. That's why today, in the Indian Health Week, our session is public health and pandemic enablers and barriers. I'm going to talk about digital health and COVID-19 pandemic. Can I go next slide, please? Okay. So here you can see like there's a two perspective. One is COVID-19 pandemic that came like 6 months ago in the world. But however, we had a health problem long ago. So in Bangladesh, as I'm a professor in the university and running an R&D center, so we are working actively on health inclusion, creating a digital health account for citizens of Bangladesh and giving their doorstep health service regularly at their doorsteps. That is why we call it last mile health service for universal health coverage. You can see in this figure that a health worker taking the smart devices and tablet and go to the doorsteps, and this 80 years Dorina Begum, she is getting the health service at the doorsteps. Next, please. So here just I would like to mention the problem in Bangladesh. So and this similar problem also in India. India, Bangladesh, or this South Asian region, we are a highly densely populated country. Our healthcare is a big problem. So we have a huge problem of non-communicable disease like diabetes, hypertension, and so on. And we don't have a referral system. And on the other hand, we have a huge growth of digitalizations. So in Bangladesh, we would like to bridge between the digitalization and the healthcare problems. So I would like to share that experience first, then I will go to the COVID issue. Next, please. Okay, so here we actually, what we're doing, we're creating a digital health account for every citizen, and we developed a platform. It's called CMed Health Platform, which uses advanced technology like IoT and artificial intelligence and cloud to create health account, do regular health monitoring, do the early risk assessment of the people, and then refer them to services. And on top of that, health education is one of the important priority. And then we are trying to build a prediction model that how can we have a early alarming or early risk assessment system that people are suffer. In Bangladesh, stroke is the one of the highest problem before COVID. So how can we do a stroke prediction as well? So next, please. So here we developed a model that actually help us to address the COVID. So at first, I would like to share you. It's a kind of Uber model. So what we are doing, we have a health worker. Health worker go to the doorsteps of in a corporate office or in a household. So they try to serve the people in their doorsteps. That's why we segmented in 3 areas. One is a workplace, another is a doorsteps, and another is a medicine shop in the community. So whenever people have a problem, they connect to them, and then based on their problem, they actually connect to the telemedicine services. They are connected to the telemedicine. They connect into telemedicine. They connect in telemedicine to get the treatment. So next, please. Can you go to the next slide, please? Okay. So here you can see that how the services happening before the COVID in different places of the different areas of the country, that using the digitalization and digital health. Next, please. So here you can see that health is one of the important things, and if we see the SDG number 3 goal is health and well-being. There we have to achieve universal health coverage, that is equitable healthcare. Using the model that I described just now, we actually covered 1100 villages where every citizen, every people have their digital health account, and they getting regular health services at their doorstep using health workers and digital technology platforms. Using that, we actually serve 1.6 million population and who are getting regular health services. And on top of that, we also created 1,000 plus jobs for that. So we have a plan to scale this service more. However, if we move to next, that actually COVID happened. So next, please. So you see that in March 2020, Bangladesh first experienced COVID-19. So during the COVID-19, we have to maintain social distancing and health hygiene and wearing the mask. So due to that, we have to utilize the platform and technology to actually address the COVID-19. Next, please. Next slide. So here, what we did immediately in March, we actually worked together with our government of Bangladesh, and we developed COVID-19 digital surveillance platforms that actually help us to actually minimize the consequence and of the pandemic COVID-19. Here, we actually developed a system that can identify the suspected cases, and then we refer them for testing, confirmation, and based on their health condition, we actually send for hospital in the intervention. And finally, we can track that how many people are dead, how many people are recovered. Next, please. So I'm going to share the experience that we had last 5 months in Bangladesh. In Bangladesh, we have all over the country around 14,000 community clinic, and we have 14,000 health worker in the community clinic. On top of that, we have nearly 15,000 plus health assistant who actually provide a service at the doorsteps. So we immediately utilize our around 30,000 health worker who actually serving all over the Bangladesh to actually go to the doorsteps with a maintaining the social distancing and give the education of the COVID-19, how to maintain the hygiene and social distancing, and try to do the triage, that is online screening of suspected cases using the digital platforms. So you can see here, so here we have a health worker who will go to the doorsteps, and also people come to the community clinic, all are them having their COVID-19 screening. If we find any suspected cases, we then connect them to our health complex, nearest health complex, and also centrally we are getting all the data. It's here. Next, please. So here you can see we have the full cycle of tracking COVID-19 patient using the digital platforms. I just give you an overview. So you see here our Bangladesh map, and then our 30,000 health workers are doing the screening at the doorsteps and in their community. So with maintaining social distance, then identify the high risk cases, then send them for the testing. And when the testing gets positive, then they have to look after by the doctor remotely. If someone need a hospitalization or isolation center, they shift to the isolation center. And after that, based on their condition, hospitalization, or they recovered and or they dead. So we track everything, so from the suspicion to the. So based on that, we actually try to minimize the transmission rate of COVID-19 in Bangladesh. Next, please.
May I request you to be a little fast?
Oh, yes, please. So I'm almost end of my presentation. Here I'm showing you that this is the Bangladesh, and during this 5 months of COVID-19, using our 30,000 health worker, we actually served 1.5 million suspected cases. Among them, we found 108,000 cases who tested for confirmation. Next, please. So here, so you can see how digital health platform actually help us in Bangladesh for addressing COVID-19 pandemic. So what we are saying here, that the experience we got to the end-to-end monitoring, a digital platform and tracking help us to actually control. However, there is a more experience to share from the India, Nepal, and Sri Lanka, so that we can learn from each other, we can improve our service, and we can have a better control of our health and health service delivery. And together, we want to achieve universal health coverage and SDG. Thank you so much.
Thank you, Professor Mamoon, and congratulations that with this digital initiative and artificial intelligence, you could cover 1.5 million people you could serve and created job. And very importantly, I could see that your Bangladesh, the case fatality and all are very much under control, but hopefully things will be much better and improved soon. So with this, I move on to Dr. Ruwan, and he is going to talk about the Colombo story and going to touch upon in macro level the Asian perspective also. So I move on to Dr. Ruwan.
Okay, thank you. Can anyone upload my this thing, or I would like to? I mean, do you want me to share from here? No, I think someone has to upload my what do you call presentation, please. Possible?
Yes, sir, we are uploading it from the back end. Allow us a minute.
Okay. So, okay. Okay, great. Thank you. Next slide, please. Yeah. So, thank you very much once again. So, I will talk a little bit about the COVID control and what really worked in Colombo and what didn't. Basically, from the very first topic of enablers and the barrier. Next slide, please. So basically, when we start, when we got this coronavirus COVID-19 pandemic in far back in March, the very first case was reported on the 11th of March 2020, and the next day we got the very first case within the city. So if you take Colombo City, we have about 1.4 million population together with the resident and the migrant population together. So from the very beginning, with the mayor of Colombo, mayoress of Colombo, and the municipal commissioner, we thought that we should have a very clear vision and a mission for in tackling this. So our main, next please, our main vision to keep the city free of COVID-19 patients. Next slide, please. And of course, our this proactive approach paid off. And if you see the statistics as per yesterday, the entire country had only 2,886 cases, and the city of Colombo had only 131 cases with 1.4 million population. And the last case was reported within the city about 123 days ago. The last active COVID case was reported 122 days ago. And if you take the entire caseload, we had only 4.5% of the total incidence of the country. And as very correctly Mr. Joy Chakrabarti mentioned, our case fatality is as low as 0.31%. And next, please. So we had a very clear vision, as I did, to keep this, the city free of COVID-19. Next slide, please. And the goal was, the most important thing was for us to intervene proactively to prevent the COVID-19 outbreak to epidemic proportions, and also to prevent its community transmission within this 1.4 million population, and also not to allow that to spill over to the other cities, like what we have experienced in the big cities like New York, London, so on and so Sao Paulo. You know, we saw that how it spilled over to the other cities, and the entire country was basically engaged with COVID-19. Next slide, please. Um, so, what were the enablers that we thought that we should have at the very beginning, as early as in March early? We wanted to have a emergency preparedness and response plan, which we had in place. Then we had one for the country and one for the city, and then we wanted to establish a proper channels or links so that we could, once we trace a patient, how we are going to do, you know, how we reach there, how we get uh, what do you call, what is the information flow that we will be getting, and who is going to go there, tackle that particular situation on ground, and how the patient is evacuated to hospital, then the contacts and so on and so forth. Then and also the enhancing technical capacities, as Professor Makun very correctly said, that we were not encountered this kind of a pandemic earlier, so it was very new. So we had to go back to the basics what we have learned in public health, and so we had to enhance the technical capacities of my medical officers of health, then the public health inspectors, and also the other categories of people, the health auxiliary workers. Then of course the stockpiling, we didn't have the PPE, all these masks. So we were able to, so emergency fund was established by the mayors of Colombo, and that was shared. It was made available to the public health brand, so we could go for emergency procurements of PPE, sanitizers, ethyl alcohol, so on and so forth. Then, of course, there is communication to the public, and the public engagement was of paramount importance, because people started panicking. So it was very, very important to give them the proper information. Then the other thing that we embarked on was the proper enforcement of very stern public health measures based on epidemiological analysis. So not just like that. So we had a very good link established between the country's epidemiological unit of the Ministry of Health, and we have our own epidemiological and statistics unit. So we were analyzing all this data that we got, and we were taking measures accordingly. Then, of course, it was very, very important for us to take individual case as an incident, and so this incident and case management at community level was very, very important. Then, of course, testing with proper PCR testing facilities establishing, that's on ground. Then the tracing people, the quarantines, then the lockdowns, and also for the very first time in Sri Lanka, it's called quarantine curfew was imposed in high risk areas, and the city of Colombo and the Colombo district and the western province was high risk, and out of that the city of Colombo was very high risk area, which was even which was the last to lift the quarantine curfew. Next one, please. So when we look at the key interventions to prevent COVID-19 outbreak that we took, I think our rigorous COVID surveillance and contact tracing was the key of our success. And it enabled us to go for early detection of COVID cases, its isolation and treatment. And also the contact tracing, first through the public health staff, through the medical officers of health and the public health inspectors. Then we gave that information to the national intelligence services. So within no time, we were able to get all the information of the contacts, where they were, I mean, where, in which Uber or the taxi that they have traveled, to which doctor they had gone, from which pharmacy they have taken the medicine. So we were able to get all these first and the second contacts self-quarantine immediately. The quarantining of all exposed, or the rather contact patients or the persons, the first and the second and even third contacts was made mandatory, and that gave tremendous results. And also the other well-known public health preventive measures such as social distancing, then the hand hygiene, sanitizing, all that was practiced, preached to the people, and then for a ringing tone, we have used the Telecom of Sri Lanka has used giving these messages to the public. Then, of course, a proper sample correction and PCR testing from the field was the other key intervention. Next slide, please. So you can see a couple of photographs how my medical, these are public health inspectors, the doctor, so going and meeting all these people at the community. Next slide, please. Yeah, so the disinfection of places, the patients, the residences of those people. Next one, please.
May I request you to be a little faster?
Yeah, that's right. Yes, I have almost finishing. Yeah, the PCR testing. Next one, please. Next one, please. Yeah. So I think our success, our success was basically based on early and compulsory hospitalization of all positive cases, irrespective of whether they were symptomatic or asymptomatic. We never asked them to be at home. Positive means hospitalization. So they were followed up throughout, and they were given symptomatic treatment, and by doing that, we were able to curtail the spread from them. Then also mandatory self and home quarantine of first and second contacts. Next slide, please. From this line graph, you can see within the city how it happened. Next slide, please. Next slide, please. Yeah. Yeah, so you can see we had the highest case load somewhere in mid-April, and we started actually here, the community transmission has virtually started. So we were very proactive, and we were able to test all the cases and surrounding places, and we were able to hammer that and curtail spreading that particular cases. We got 93 cases here altogether within just couple of 1 week. So, but after that, because we successfully completed that, we were able to achieve this. Next slide, please. So I think emergency preparedness and response with very clear vision and goal and strategies and action plan paid off, and that was the key to our success. And in conclusion, I would say we got a tremendous support from the national intelligence and from the political leadership of the country per se, and also from the mayors of Colombo and the municipal commissioner, and of course the health authorities, the Ministry of Health, the Minister of Health, and also from the epidemiological unit of the Ministry of Health, and also from the general public. So that's why we were able to, last slide please, and that's why we were able to curtail it to such what you call low numbers of 2,893 cases for a 21 million population country. Thank you very much. Thank you, Joy.
Thank you, Dr. Ruan, and congratulations for this outstanding success and retaining the number within these 2000 marks. And I think it will be a model for many countries and many cities. And I'm sure that many places, many states have tried to do that hospitalization of all positive all positive, whether symptomatic or asymptomatic, but sheer because of the lack of infrastructure beds, it may not have been possible. But you people have done an excellent job, and more than 120 days, not a single case has been reported. I think it is a music to the ears, and very nice to hear that. So with this, I move on to Mr. Manish Khemka, and he is from Nepal, but he's going to share Asian global perspective, that what is working, what is not working, and some of the success. He doesn't have a presentation, but he's going to take us through the flow of his, data, information, and facts. And I'm sure it will be quite thought provoking. So over to Mr. Manish.
Thank you, Mr. Chakravarti. It was quite interesting to read the story of Bangladesh from Mr. Mamoon and the way they have used the digital technology and AI to transform and control the COVID. I mean, it's very interesting. And the Sri Lankan story is really, really exciting. I mean, like in the South Asia, I think Sri Lanka is one country which is doing phenomenal job. Am I audible?
You're audible.
Yeah. So which is doing exceptional job. So if I start with like Nepal, so in the Nepal, the first case of January 2020, when a 31 years old student came from China, from the city of Wuhan, and but since we didn't have the testing facilities then with us, we sent the testing to Hong Kong, and on 17th of January it has been confirmed that the patient was with the COVID symptoms. So this was the first case which was reported to us, but by the time 17th January the world started seeing the spread of COVID. I mean, started from the city of Wuhan and started spreading, and then by the end of January at the beginning of February it has reached to almost most part of Europe, America, Australia, Asia, and some part of the Africa. So so this is like, and since Nepal as geographically located between two countries, India and China, and then they were the two major hotspots in the COVID. So we've always concerned that what will happen to us and how we'll be able to prepare. In general, the health system in Nepal is not that efficient. So it was really concern for us that how things will evolve, be able to cope up with the situations. So the second case in Nepal has been reported only by 23rd of the March, when India has announced lockdown. So following India, we felt that it's a time for us to seize the boundaries as well. And we also went for the severe lockdown in a country, and we restricted travels. All international flights have been closed. Then we also started working on like asking people to do voluntary self distancing, and then we also maintain like a lot of things like testing, and then like contact tracing, and I started building up a critical care unit, isolation, and all these things. So this was going on so far, and as the like economic curve also got flattened with the lockdown, we had to open up our economy, and the cases have increased afterwards, but still it's a manageable, and it is happening. But if I like to talk about how things have moved in Asia, we see that the responses are quite mixed. Some of country have really done well, and some of country have failed miserably. China is the country which is the first in, first out. Started with the China, and then the China is one country which almost control the spread of this coronavirus. But then the other countries like India, which is seeing the cases like over 60,000 per day, and then death mortality of over 500 and 600 per day. So it's a really serious in like a country like Asia, in India. But there are the countries like Vietnam, there are countries like Singapore, there are countries like South Korea. They have done a fantastic job in curbing the spread of the COVID-19. They could do it because of like, if I study how they could do it, they could be able to do it because they had a prior exposure with the SARS and F1 and N1 virus. So they had some sort of preparedness with them. But for the rest of the countries, I mean, like it was something very new for them, and that's why they found themselves very confused when it started. So if you see like the like Singapore and then Vietnam and then South Korea, they could really create, and then Sri Lanka for this matter. I mean, they could really see some marvelous like a case study for the world to see and follow. But one important factor here I would like to like mention that though these outbreaks were not new. I mean, like this has happened in the past, but then the world didn't focus enough on working on to something which can control and curb the occurring of such kind of outbreaks. When these situations were there, like Ebola, MERS, they were excited, they wanted to do something. Soon these cases started subsiding. I mean, like it lost the interest and attention of the world community. Like even the WHO was quite misleading, and they couldn't do much into it. And then what happens when we don't look and when we don't learn the lesson from such incidents, it creates a kind of a cycle level, like panic neglect kind of cycle we enter into. And then the consequences and the losses are always bigger than what we always anticipate. So it is very much important. It is very much important for the countries not just developed nations and the developing. It is important for all in the world that we should form some mechanism. We should form some mechanism whereby we can continuously invest into this kind of building up the facilities, building up the vaccines, building up and doing the research and development on these kind of pandemics, whereby like we can always prevent. Because if you see the outcome of the current pandemic which is going on, we have more than 22 million affected people reportedly, and the loss of over 770,000 lives, which is really big number, which is really number. And then if we talk about economic losses, there's estimate that it would cause a loss of over $9 trillion to $30 trillion, which is very huge. And a report of a McKinsey says that if countries spend around say $70 billion to $120 billion per year for the next 2 years, and then $20 billion to $40 billion every year afterwards, there would a likely chance to control this kind of pandemic not to happen in the future. Because this is believe me, this is not the last pandemic we are living with it. This may be a test run of the other kind of pandemics. So it is very much important for the countries not to look for immediate returns, and investors not to look for immediate returns and dividends, and should invest into something which can be of long run interest of the overall society and human civilizations. So if I talk about some factors that work, and some factors which didn't work here, I would like to highlight few points on the factors that work. Are like strong political will and leadership. Where the countries have shown strong political will and leadership, we see that the cases are better managed and better controlled. Then the quick responses, like in Vietnam, they acted fast. Sri Lanka, they acted very fast. So there we see also better responses. Transparency, like Singapore, they have all better communications. They always been a proper communications, and they've shared the news. Because in some of the countries in South Asia and other part of the world, they have sit on the numbers. They feel that if we share the numbers, it will make them lose their political power. It will make them lose their government. So that also created mistrust among the general public, and also let the coronavirus spread. Other factor which worked, like which is prior exposure to epidemics, like in the Southeast Asian countries, where they have exposure with the MERS, SARS, and then H1N1 kind of thing. And of course, one factor which really helped most is the leveraging technology. We see that some of the countries like Bangladesh and other South Korea and Singapore, they've really done a fantastic job with the leveraging of technology in terms of AI, and then the tele things, which has done really phenomenal job in controlling and curbing the spread of the pandemics. Some factors which I feel, which I have observed that didn't help the country to control. One of them is the confused and overlapping role of government agency. Even if we talk about India or Nepal for these examples, the government agencies were confused among themselves. What to be done? One state is talking about something else, other state is talking about something else. So there was no proper coordinations between the government agency, a lot of overlapping, which has actually created a lot of confusion at the execution level and actually helped coronavirus in spreading. Then the other factor which was quite challenging in this aspect was continuous and changing guidelines by the WHO. The WHO, like every time, like they sometimes they say that the masks are good, sometimes they say masks are not good, some say they use respirators, sometimes they say don't use respirators. Every time WHO was shifting the post, and it was creating further and further confusion in the preparedness in all the economies. Then the other challenge I have found in Asian countries and in some part of the world, that there was no proper confidence building exercise has been done with the private sector. Government sector cannot handle this problem alone, especially in the Asian countries where the larger portion of the health sector is been taken care by the private sector. It was very much important for government
Mr.
to have
Manish, try to be little brief.
yeah, sure. So it was very important, very much important for the government to take private sector into confidence. Then, of course, corruption was major problem I have seen in some of the economies, and the rent-seeking behavior in some of the economy, where even the cases have been reported in India and Nepal, where the government and then some part of them were some corruption activities have been reported. So that actually derailed the effort, and unstable government and hidden political agendas like in Thailand, Philippines. So these kind of like factors were kind of a challenge. So basically, what I try to make my last here is that there's a say that distress situation needs distress measurements. So this is a situation which is quite challenging, and it is very much important for all the countries to work together in a collaborative and proper coordinations. So instead of showing the cognitive generosity, the countries are fighting to win the race basically. So who can be the first in the race? So this is really creating a lot of hurdles in coming out with the vaccine and other proper mechanism. So I urge with all the government and with this platform that it is a time where we all have to collaborate, we have to share our knowledge and have to done our best to navigate through this situation of a COVID. Thank you so much, Chakra. This is my piece. Thank you.
Thank you very much, Mr. Manish, for sharing some of the very practical and some of the very strategic, some of the very burning issues which have not been touched upon so far. That it is not the only government what they can do. It is not the private bodies they can do. They need to work together. All the bodies which needs to which are working, they need to work together very importantly. And as all of us are calling it as a novel coronavirus, so it is also something very new for all of us to handle and manage the virus in a very scientific way. As you have correctly told, when to wear mask, whether not to wear mask, whom to do the test, where to keep that identified positive patient, those have evolved over a period of time. So some of the countries have done extremely well, like Sri Lanka, Thailand, and others, and some of them have learned in a very hard way, and some have burned their fingers in a very bad condition. So I have heard from three of you some of the very good practices, some of the learning experiences for many. So for example, Bangladesh, the way AI based model has reached out to significant amount of population and doing the testing and ensuring that people they get detected and they are managed. On the other hand, the Colombo has taught a lesson that how early intervention, segregation of them, isolation, admission can give them a good result. And what best you can expect when somebody tells, in my city of 14 million, I don't have a case for last 122 days. And then I come to Mr. Manish, you come from a country, population size is very less, and you have sandwiched between two big caseloads country like China and India, and still you have managed to do well. Your caseload is considerably much lesser, and your fatality rate is also very less, what I have noticed. And you have given a very fantastic idea about who all have seen the success and who are all not. So thank you very much for contributing in this, and thanks on behalf of CII and on my personal behalf. I'm sure this is going to go in a long way for the audience, for the delegates. They will take a lot of take-home messages for them, and it will be a good learning session. Thank you very much. Over to CII. I formally conclude this session, and I thanks all the panelists for joining, and thanks to CII for giving us this opportunity. Thank you very much.
Thank you. Thank you. Thank you so much, Mr. Chakravarti.
Thank you, Mr. Chakraborty, and all the panelists for such amazing presentations. So, we have another 5 minutes, and in case you would like to, you know, do a short summary of the program, it will be very helpful for all the viewers. So, Mr. Chakraborty, request you to kindly come and serve.
Maybe we can have a discussion about bilateral collaborations that could help to learn each other initiatives.
Thank you, Mr. Mamoon. I think we shall share the session recordings with all the panelists, and we will take it forward from there. Thank you so much, sir. Thanks.
Thank you.
We are very much interested about Professor Mamoom, what you all have done. I mean, if you can really, share your digital platform, what you have done, it was, I think, marvelous, and especially creating jobs, in a scenario like this. I'm sure that Colombo has something to learn from you, right? So let's see the time to come. So we'll see how best we can do that.
Thank you so much. Actually, I was like really amazed about their your contact tracing and hospitalizing every positive cases, which is I think unique example in the world. So maybe we need to talk to learn each other to exchange our experiences so that we can do better in the future as well. So love to continue our discussion, and we can do a collaborative jobs in the future.
Me too.
and also Monish. I'm not sure he is not here. Is not. Yeah. So like if I get your information, then we share and we can discuss.
Seems session is over. I think we can quit, I suppose.
Okay. Thank you. Thank you.
Okay.
We'll catch up later.
Yeah, sure, Professor Mamu. It was great pleasure to meet you, and
Thank you.
definitely we'll catch up. Okay,
Thank
right,
you.
my dear. Okay,
Thank
bye
you.
bye.
Bye bye.
Bye bye.
Yes, Dr. Joseph, can you hear me?
You can hear me, Anugrah?
Yeah, Dr. Joseph, I can hear you very well.
Okay, can I just share my slide as well once? Just to
Yeah,
just
please.
yeah.
Please.
I had shared my presentation with you. Did you receive it?
No, ma'am, I have not received it. You can share it from your share screen, ma'am, not an issue.
Actually, I had shared. Just check and tell me if you have not received. Just 5 minutes back, I had shared. Just in case.
Yeah, Dr. Joseph, I can hear
You have received. Okay, just a minute. I'll just put in mine.
Yeah, please.
Okay. You're able to see?
Yes. Yes. We can
Perfect.
clearly see, please.
Ah, that's perfect. Thank you. Thank you so much. So I will, yeah.
Thank you, Dr. Joseph.
You are done.
Sir?
Said you are done, huh?
Yeah, I am done. I tried it that day, but that was without downloading the app. Today I downloaded the app also. This is program.
Okay.
I finished my recording also. So you will get it by today.
Okay.
Yeah.
So Nijaji, you are there. Can we share the screen and see?
Hi, Dr. Agarwal. Yes, please, you can share your screen. We can check.
How do I share? That is.
Share content, sir. Third icon on your screen from the left.
It says open system preferences.
So you click on that, sir.
Open system.
Karan, are you there on the call, please?
Yeah, I'm there.
Can you help Dr. Agarwal with the presentation?
Yes, sir. If you can move to your bottom screen, there are certain icons over there.
Yes.
Third icon from your left, click on it.
Yeah, the third icon is not activated. What it says is open system preferences.
Change from the left, so your left, from left, third icon. After video one.
Yes, first is mute, second is stop my video, third is open system preferences, fourth is
after that
close participation, chat, more options, speaker, microphone, camera. So the third one has open system preferences, and if I click on that, then it brings me to general firewall privacy, Cisco WebEx events. Let me, okay. You can choose to quit Cisco even now or do it on your own later. I said later. And where are we now?
Sir, can you share the presentation with us? We'll upload the presentation. from our end.
Yes, but then you will have to only run it, na?
Yeah, I will run it. No worries. You only just say when you're over with the slide, you just say next, please. We'll change the slide.
Yeah, but then there are a lot of those unnecessary clicks, there will not be a good experience. I think we need to do something.
Are you using Windows laptop or Mac?
Mac,
Okay.
MacBook Pro. Mm,
So just give me 5 minutes. I'm just gonna get back to you on this.
okay, all right.
Sir, just wait for 2 minutes, please.
Yeah.
Your iron box is behind, sir.
Hmm?
Your iron box is behind.
Okay. Iron box.
Anugrah, hello.
Yes, ma'am.
Yeah, can you contact Dr. Sanjeev? I think what he's done is he has joined as a registered participant, not as a panelist. So if you can call him now,
Yeah, okay, I'll call him.
yeah,
I'll call him
you can
again.
call him now.
Okay. Okay.
Dr. Agarwal?
Yes.
Yeah. Sir, I believe I also joined in with the Mac. We over here it's showing share content. So if you can please move and click on the third icon.
Which is the open system preferences. Can you hear me?
Yes, sir, it's just alongside the mic and the video option. So
I know that, but the icon is open system preferences. It says it is not that share content. What does your thing show? Third one.
Sir, it shows me 3, 4, 5, 6, 7, 8 icons, and out of the left from third from left, it shows me the share content icon, sir.
Share shot.
Yeah. Sir, what best we can do, you can just forward me a PPT. And
Yeah, my PPT is with Akankshita. I have already forwarded it.
Okay, I'll just call her and ask her to share us. Thank you.
Yeah, and in my case, there are 7 icons, not 8. So why?
There are 7 icons. The third one is share content.
Madam, no, in my case, the third one is open system preferences.
What is the first one?
First one is mute.
Oh, okay. Okay, mine is third one is share content. Yeah, so they probably have to enable your content to be shared.
Yes.
Administrator has to enable your content share.
Exactly. That's what has to happen.
Hi, Dr. Shabnam ma'am. Thank you so much for joining. We are just waiting for Dr. Sadullah to join. Rest all the panelists are here, please.
Okay, thank you. Thank you.
Thank you, ma'am.
Thank you.
Is it, this is Sanjeev. Is it possible to give the privilege to share, and can I see whether it works?
Do you have a presentation, Sanjeev, that you'd like to?
Yeah.
Anurag, could you just do a trial run, please?
Yes, ma'am. Thank you.
Thank you. Thank you, Bita.
Perfect.
Dr. Singh, can you share your screen? There is a third icon.
Yeah, I can.
Yes.
So is the
We
slide
can
visible?
see. Yes, we can see, and you can do
see
the
it.
full screen. Yeah, yeah.
Okay.
Thank you, sir.
Thank you. And how do you share? Stop share. Perfect.
Hi, Dr. Sadullah. Thank you for joining us.
Good afternoon, Shabnam ma'am. Lalu here.
Good afternoon. How are you?
Good, ma'am. Doing good. How about you?
Good, good. Chugging along like everybody else. Huh? Never a dull moment. So it's quite amazing, how things move and then suddenly everybody is, hello, Vijay. You're going along this and then suddenly right, left, right, left. I just don't understand. I mean, I wish, like everybody else in the world, we had some kind of a, doorbeen to see.
Yeah. It's not seen anymore. Yeah. Scary.
I think, and we as it's a funny kind of thing. Everybody says, "Oh, healthcare workers, warriors, etc." But we were never trained to be warriors. The mindset of a warrior is very different. It's just, I think, just too challenging. How is it in Vellore, Lalu?
We have 1,000 patients. You can imagine then how it is. We've dedicated 1,000 beds for. And now the sad part is earlier it was a lot of level 1 cases. Now it is predominantly level 2 and level 3. All of them requiring, ventilation, non-invasive, some oxygen support. So that's even more strain now. Yeah. We cater to 4 districts.
See, that's the challenges are just it's not getting better with time, irrespective of whatever anybody might say.
Good afternoon, madam. I'm Sanjeev from Amrita. How are you doing? How are you, Lalu?
Yes, sir.
I think one thing is for certain, we've all become experts at Zoom calls.
Yes.
One more competency.
Somehow because of this availability has become almost 100%.
You can't say no also. Sorry, I'm traveling.
And you can't say, sorry, I was late in traffic either. At best, you can say internet connection was wobbly. But you have to be there.
Yeah. So life has become easy, less travel, but it has become 100% availability. Everybody expects that, yes, just log in, and then log in and log out has become a norm now.
I think, I don't know if you all have found it, but I find with patients, they can skip an appointment, but you can't. There might be a no-show from their side.
I'm the first speaker.
Correct.
But you can't have that no-show tag for you.
Absolutely. It's so difficult.
Good afternoon, Saidullah sir.
Good morning. Good afternoon.
Good
Yes.
afternoon. Good afternoon,
Hi,
sir.
Sanjeev.
Good afternoon, Dr. Sadullah.
Yeah, Shabnam, yeah, good afternoon. Yeah, I'm Dr. Sadullah. We met, we have met. Yeah.
Of course, we met, sir.
Yeah,
In the
that's
big,
no problem. Yeah.
especially we were starting the Health Sector Skill Council at that point in time.
Yeah, that's correct. Yeah.
So how are things in Kerala, sir?
Kerala is, the Kerala model is not working. The Kerala model was, initially was very good, but now we have about 1,500 per day. And Trivandrum, where I am, is more than 500, about 500. And the community spread has started, and we expect even a higher count. Fortunately, the death rate is low, and category 1 and 2 are mostly the cases. And so we hope, but lockdown now it is a Onam, the Onam festival is coming.
Correct.
Yesterday was Chingam first. And so the festival is very, very dear to the people of Kerala. And so they are all on the street, not badly grouping together and all, but certainly not in the desirable assemblies. And so we expect that cases may go up more.
So what was the reason for this? Was it just the migrant workers who came in and that kind of upset the entire story?
Partly, yeah, it is partly because of the state people who came. And but more than that, it's all political. If I say that, more than that is the GCC, the Gulf countries, NRI who have come back from various parts of the GCC, and they are many numbers, and at least about a good percentage are tested positive.
And
so that's the fresh inflow.
Yeah, it's fresh inflow because it was done pretty well when they were brought in under this Vande Bharat. Then I don't know what happened because the contact tracing was appropriate, quarantining was all in place, but somehow they got about 40 to 50%. 40 to 50% of them were positive, and it just then exponentially started rising.
Correct. Actually, it's like having a bolus of a whole lot of people come in, and you can't put a time.
Correct. So somehow everybody, health minister, chief minister, were all doing perfectly fine, but I think some complacency would have led to that.
I remember doing a webinar with they're putting up these healthcare parks in Trivandrum, and so they reached out to CII that they wanted to expand their reach and get people in, and they were very, very confident of the great job that was done, which was right also.
At that point in time.
Yeah, this was about a month back, more than a month back.
Yes. The health minister was called from the United Nations to deliver that talk. How did she manage this so well? So till 1 month, they were top notch. Now maybe Arvind Kejriwal will be called.
Slide Okay.
That's it. It's like a revolving chair, revolving to one.
Yeah, it's been a musical chair.
But it's never leaving Tamil Nadu. That's the sad part.
They're too good with them.
Dr. Shabnam, we can begin the session now. All the panelists are in.
Okay.
Thank you.
So just give me a thumbs up. Should I start, Bita?
Yes, ma'am.
Okay. So good afternoon and a very, very warm welcome to our panelists, friends, colleagues, all who have logged into this session. I think we've had, yesterday we had a very good inaugural session, some very interesting plenary sessions. And as you clearly, our focus in this entire endeavor is towards public health. Though the focus is public health, today public health cannot be spoken of in isolation. It's clearly in the current COVID situation, and even before that, the presence and the service delivery of the private sector is well entrenched in our country. As in when things move, the investment in the industry is more than what it is currently. Things may change, but I think for a good 10 to 15 years, this marriage between the public and the private sector is pretty much here to stay. One of the arms that moved rapidly in the early days of the private sector coming into, lack of a better word, corporatization, if you call it an industry, whichever way you look at it, was the concept of patient safety. Patient safety, the implementation, the rolling out of patient safety across the system has been spotty to a large extent. And I'd like to clarify my statement. Spotty in the sense that the uptake to make things happen, both in the public and the private sector, has not been to that desired effect. But the concept of patient safety, the need for patient safety, I would say undeniably, is very well understood and recognized. So everybody knows that patient safety is paramount. It is critical. But is it actually being implemented on the operational floor is the question. The second bit is, all across the world, and even in India, the economic impact of instituting patient safety in care areas, again, is now well captured and well established. The recent COVID crisis, as well as, unfortunately, in our country in the last couple of years, the narrative has started shifting. And there is a new kid on the block as far as safety is concerned. So perhaps the time has come now, in the current context, to look at safety from against patient safety. So given that, I would like to introduce our esteemed panelists who have a lot of experience in this field to be able to elaborate on this concept, as well as to see what are the challenges. Are the challenges in resource constraints? Are the challenges in system issues? Are the challenges from a medical culture perspective? With that, I would like to share with you that we have Dr. Saadullah, Chairman and Managing Director, KIMS Healthcare Group of Institutions with us. Dr. Vijay Agarwal, President, Consortium of Accredited Healthcare Organizations. Dr. Sanjeev Singh, Chief Medical Superintendent, AIMS Kochi, and Lead Project and Operations, AIMS Faridabad. And Dr. Lalu Joseph, Associate General Superintendent and Quality Manager at CMC Vellore. A very, very warm welcome to all of you. So, Dr. Saadullah, if I may start with you, would request your thoughts, your comments on this concept of presence of safety in healthcare. Over to you, sir.
Yeah. In general, I have some slides. Can I put it on now, or you want me to speak?
No, sir.
Yeah. Okay.
You can continue speaking while they're uploading it, sir.
Yeah. In general, what points you brought out are very important. And first of all, good afternoon to Dr. Shabnam and as well as all the attendees and my fellow speakers. The three aspects, one thing is certainly the byproduct of this crisis is that we are focusing on patient safety more than ever in the past. We all have agreed and concurred that we certainly need to have the patient safety in our hospitals and all in our healthcare delivery. Second thing, whether we are ready as a nation, as well as the as individual hospitals, is a question which we need to address separately. And the third thing is that whether the public is ready, as well as there's a change of mindset and is required among the doctors also. So I'm going to touch upon just what is the basics. We talk about patient safety and what corrective approaches we can have it in general, and then what the central depository efforts, the repository efforts can it give a dividend, and some digitalization, can it work? And those are the things which I'm going to talk about and give some insight into it, how we can go forward. In fact, we have made tremendous progress in this area. Dr. Shabnam, we need the shared permission of the slides, I think. That's what I have been told.
Swati, can we just share that, please? Anurag?
Yes, ma'am. Karan, can you share the preferences to Dr. Saadullah?
Generally, in healthcare, always we say that primum non nocere and do no harm, and all of us accept that, and all healthcare providers focus on that. But what are the processes involved in this, and how the hospital, the errors cause damage to us is a question we have to really look into. For example, medication errors are the third leading cause of death in the US. Some of the bewildering statistics. Wrong side surgery. We have only two sides, two organs, and the two genders. But even then, we make a lot of mistakes over there. And CDC says between 5 to 7.5 lakhs of SSI occur in each year in the US, and approximately 27.6% of the, yeah, I got the slides, thank you. Yeah, approximately 27.6% of the adverse events occurring in hospitals are attributable to some amount of oversight or negligence. And in our practice, I'm an internist and still practicing medicine. This happens almost every day. So international patient safety goals, what are they? Just going to the basics a little bit. And identity of the patient, improve effective effective communication. Communication is the one of the main problem where we can make mistakes. Improve the safety of high alert medications, medication errors. Surgical safety, I don't have to say, most of you will be knowing it. Correct site, correct procedure, and even now, mistakes do happen in spite of all the safeguards we have taken. Reduce the risk of healthcare, especially infections, and we should try to reduce the risk of patient harm resulting from fall. And in some of our hospitals, still a problem, and even those are to be looked up. I added a few more points. That is the new hygiene system. All of us were talking about, and I'm sure more and more people will talk about it. So I'm not going to touch upon that. And that is in connection with COVID-19. The documentation remains a lot to be improved in India in general. Let it be hard copy or let it be electronic medical records. Credential and privileging is a favorite topic, and we often graduate and accept corporate hospitals and some of the universities and all. Most of the doctors in the rural area and other institutions just join as consultant after a degree of MS or MD, and that is without much of a training and experience in a structured way. And that's where the credential and privileging come in, whether we can give privilege for these people to really do procedures and do surgeries or other investigations even. And iatrogenic harm is not at all uncommon, especially when we talk about teaching postgraduate institutions and medical schools. And that today we have got enough labs and simulation labs, and training can be done. But still, and even if it is done on patients, we can definitely do it in a very structured way. There need not be any harm to the patient. But that's an area we probably do not pay enough attention. And lastly, what I want to touch upon really in a general level, what we can do is the central repository. I just say about communication, I don't have to emphasize on that. And there is enough evidence that communication errors are, causing a lot of patient safety issues and errors. Sentinel events, Joint Commission says that 70% of the sentinel events, there is a communication gap. And again, communication when we do in our medical schools, whether it is really taught as a subject, and probably with the new educational policy which is coming up and all, some of these values should come up: honesty, truthfulness, integrity, confidentiality, and empathy. And these features medical students should imbibe, and doctors should continue to impart when we communication. And of course, there are more literature available. I do not want to go into, but just say that standardized communication tools are available, and we have several methods, perhaps each one of you. The only thing, there are certain areas where definite mistakes do happen, and that is handing over during shifts. And one of the things which I have found very useful is medical boards before major procedures have been multidisciplinary. All the people come and they sit together, and surgical timeout is, of course, is useful. Still, many of our surgeons are reluctant to comply with it 100%. I will come straight to the central repository part of it. And central repository, I would like to say the electronic health record, which is the three types, perhaps one is the electronic health record. And this one, it can be by, state or even federal, but many countries have failed in making it across the multiple states. They cannot be connected. Even the US, they have failed. So it's mostly state-driven repository of electronic health record. And multiple institutions can connect in the state. And in Kerala, there we have started a Kerala medical mission. And recently, in August 15, the historic, declaration of digital national health mission will bring in real changes in the country and in this area. A lot of digitalization is going to be coming in by this project. And the PM has declared on August 15th, sorry. And so this is many institutions come together and provide the clinical data of an individual, and the individual can certainly share that even with a patient portal. And so this will be more individualized. And when we come to patient registry, it's a national observational data, and given by hospitals, and even doctors also can do it. But it has just patient demography, no individual identity is there. And I can say that the experience with 1,000 patients of diabetes, and so that kind of information will be available. And we are one step going further. Many countries are really trying out with the public reporting. And public reporting is either by the state or, or on a national level, or by general organizations, quality-based organizations, which take up the matter. And the data is available for a broader audience very easily. And this is given by many hospitals and many healthcare providers in institutions. And for example, how one particular hospital has dealing with pneumonia and what is their outcome, or cardiac myocardial infarction and related matters, and what is the outcome. So that general information will be available for the public, and public can even look at it and go forward. So this is about the electronic health record, and all of you know that. It is certainly real-time data, and clinicians can retrieve it easily for a single patient. And through patient portal, we can communicate with the patient, and root cause and corrective action can be taken in some of the events. And patient registry, just to say, to understand the variations in treatment and outcome, to examine the factors that influence prognosis, and to measure quality of care. So in general terms, the registry will be useful. And we can track patients with a device, for example, it processes defibrillators, pacemakers, and we are going to do an MRI. We can just look at it and make sure that is an MRI-friendly processes. And public health reporting, and collect information about diabetes, as I mentioned. So these all will come in patient registry. Public reporting is a step, much more general and much more that daring, trusted information. Public reporting, we are exposing to public, and so does public reporting result in improvements? Yes, it is seen that it reduces mortality. And does public reporting lead to change in healthcare structure and process? We have found that hospitals in the US public reporting did improve quality of care. Changes in policy and increased focus on clinical care, and a clinician and provider more careful in a competitive environment, especially when the insurance market, insurance plays important in the market. So my last question is India ready for such challenges? I think we are. As it was mentioned earlier by Dr. Shanam, certainly we are ready, and we have accepted that it is a value we have to inculcate in our practice. But it's needed change in culture and mindset. Certainly that is required, that is coming in. Probably we are compelled to do that because of this crisis and the aftermath of it. Effective documentation have to come. Medico-legally, people are getting very alert. And when I say that is India ready, we also should ask two aspects to it. Are the doctors and the professionals are ready, or the people are ready? Because people can misinterpret in different ways. So education of the people are also important. So there will be growing pain. There will be certainly people will have, institutions will have some setbacks when we start doing it, but nevertheless, I think we should go into it, plunge into it. And electronic medical records, we should have a system by which we do it very properly. And mandatory standardized reporting structure should be there. I mentioned about Digital India Health Mission, a historic declaration by Honorable Prime Minister on August 15. And that's setting the goals for all these we are talking about. And laxity on the government healthcare sector, and that's why the public-private participation can come in, and we can definitely collaborate, and a certain improvement is required in this area. And we should not hesitate to call a spade a spade. And data sharing forums, as I mentioned, and national quality benchmarking organizations should come up. And in fact, CAHO, we were talking about that. CAHO is setting some examples and how we can have patient registry, data collection, and even public reporting is possible, so that if it is started by a central website, or other methodologies, digitalization is very easy now, and then we can go forward. So these are my thoughts, and so what Dr. Kalam, our president, the previous president, said, you cannot change your future, but you can change your habits, and surely your habits will change your future. And I think that the cultural change and the mindset change for the professionals as well as the public is required when we enter into these patient safety aspects as a general discussion for the sake of the community and healthcare delivery. Thank you. Those are my thoughts on that repository and basics of patient safety. Thank you.
Thank you very much, Dr. Sadullah, for laying it out so well. And I think your last two slides, where you are emphasizing on the facts that it has to be a cultural and a mindset change. And I think the medical fraternity is no better, no worse than anybody else when it comes to behavioral change. And therein, I think, would lie the challenge for us and the industry. So we have a challenge of digital literacy also, especially in smaller hospitals, etc. And the other thing is that human beings, if they are incentivized to do something, there is a marginal feel that yes, they will do it. So the National Digital Health Mission, in the way it is presented, is a purely voluntary piece. So one can only hope people understand from a cultural and a patient perspective that it's very critical to voluntarily come on board. literally like the baby steps of NABH. So one can only hope and pray that that mind shift takes place. And also, I think we have another challenge in our country, that a majority of our population is, the level of literacy is limited. Though they're very conscious of health, healthcare rights, etc., but digital literacy perhaps will push them back a bit. Having said that, now I'd like to change gears a bit and ask Dr. Vijay Agarwal, who's the president of CAHO, that are we actually doing enough to push the needle on patient safety? So Dr. Sahadullah has enunciated very well, but are we from the hospital providers, from doctors, are we doing enough? Over to you, Vijay.
Thank you, first of all, CII, for having us on this platform, very prestigious platform, and to my very esteemed friend and colleague, Dr. Shabnam Singh, for moderating this session and having us to share our. So can I also share my content onto this?
Most,
yeah,
Can you the link, Anurag? Yeah, perfect. Thank you.
Because now you see, earlier I was not getting the share content. Now I can, if I do it, then I can run my own slides. Can you do that, or all right? So I think this question is really very interesting and very timely, that are we doing enough for patient safety? I bring you greetings from the Consortium of Accredited Healthcare Organizations, CAHO. So the next slide, please. See, patient safety has been high on the national agenda now for almost more than a decade, and on the international agenda for many decades, I think. And considerable efforts have been made to improve patient safety. And it is natural to ask the impact of these efforts. Have they made any efforts, or the efforts well directed or not? So the important question is, are patients any safer? Please press on to this thing so you'll get that. Next slide, please. Answering this is that some aspects of safety are difficult to measure for technical reasons as to what is preventable and what is not preventable, what is therefore will fall into the thing of patient safety or not. But I think overall main problem is that the measurements and evaluation have not been on the high agenda of anybody. Next slide. The absence of solid measurement of safety and indeed quality is a worldwide problem. And measuring safety in healthcare is much more difficult as compared to measuring safety in many other domains where the mistakes are and injuries are fewer, less varied, and can be more clearly defined. Next. Now, if you look at the global perspective, just keep pressing so that you'll get all the countries otherwise. Just keep pressing, please. Yeah. So you'll see in this slide that all over the world, whether it is Australia, US, Germany, United Kingdom, Canada, in various years, there have been some estimates which are kind of tell us about the annual deaths from medical errors. And they are, as you can see, they are huge. Let's see the next one. However, I would say that the start of the patient safety movement, even in a country like United States, which had, I think, more than 100 years of the accreditation history, it really started with this landmark publication in 1999, which came from the Institute of Medicine, which highlighted that there were 98,000 deaths in United States alone due to medical errors. And thereby computing that they had $50 billion in total costs, which were attributed to this. Lot of other things, 7% patients suffer from a medication error, etc., etc. The important thing is that most of these were preventable. Now, this particular study, to my mind, was like a watershed moment in the history of prevention of, or let's say, going towards the patient safety. So next slide. So in 2 decades, the report came in 1999. And so I would say globally, what steps were taken to make healthcare highly reliable? There were a lot of steps which were advocated and taken. So let's see what those steps were. Next. So there was a multi-pronged approach to bring in the culture of safety. Next. Yeah, go ahead. So you can see that the multi-pronged approach included changes in our thinking of leadership, accreditation and statutory compliance, guidelines and protocols, technology, curriculum, and patient experience. All this was like to make a contribution to culture of safety. And if I just look at one by one, next. Next. Just click it, please. So you see that leadership, what it did, no, please go back to the, so the leadership established a non-punitive approach to tackle or address the issues of medical errors. It also showed commitment, involvement, and resource allocation, faster resolution of issues, improved environment of care, and created transparency and openness. This is what all can come if the leadership is aligned to this whole concept of patient safety. Next. Then we came to accreditation and statutory compliance. And what the accreditation and statutory compliances did was to improve public trust, ensure a safe environment that reduces risk, offered quantifiable benchmarks, improved outcomes and patient experience, enhanced efficiency, reduced cost through standardized care. Next. Then it also was to talk about guidelines and protocols. What it did was to establish clear processes, standardized care, eliminated variation, established predictive outcomes, peer pressure improved performance, benchmarking, focused on special population for better care. Next. More guidelines and protocols, I think this. So what it did was that those protocols, we also instituted root cause analysis, failure mode effect analysis. Next. Next thing. And then I would say use of technology, which helped in eliminating illegible handwriting, automated drug dispensing, again, benchmarking, many things that technology can bring in. Next slide. And then even the curriculum. So the introduction of patient safety, communication, and teamwork as curriculum in the medical and nursing schools were to bring about huge amount of benefits. Just click it, please. Yeah, so the benefits were improved collaboration, enhanced communication, and establishing patient safety as everyone's responsibility and not just the physician. Next. And then the patient experience, just click more. Instituting patient-centered care and instituting patient advocacy groups, improved patient outcomes. I think like Dr. Sadullah already had kind of. Next. Now, these were the kind of steps which have been in the last 20 years have been taken globally in different kind of degrees in different countries. So what has been the impact? So I was trying to find that, and I could stumble upon this study which was done from NHS. Data was used to assess this change, and this was done by Charles Vincent et al. To find out what has happened. So their focus was, of course, to measure outcome data in the sense of definable events that happen like infections, morbidity, mortality on key processes. Next. So what they found was that the hospital standardized mortality ratios show that in-hospital mortality has fallen significantly over the past 11 years. The ratio is adjusted, and in this fact that a lot of people debated whether the mortality that you're showing has fallen. Is it because the different kind of patients were admitted, or different gender and all that. So the ratio is adjusted over several factors, including age, sex, diagnosis, and whether the admission is planned or unplanned, socioeconomic deprivation, comorbidity, and season. All those things were taken into consideration, and they did conclude that there has been a significant decline in the mortality of the in-hospital patients. Now, overall picture, although difficult to interpret, they say, their conclusion was, it suggests that the care is at least as safe and maybe improving. Next slide. The Society of Cardiothoracic Surgeons has collected data for over 20 years, and there is evidence of improved outcomes in the cardiac surgery, with a reduction in mortality in the north of England from 2.4% in 1997-98 to 1.8% even in 2004 and 5, and has gone further down. And similarly, the Scottish audit of the surgical mortality, they have tried to separate, in fact, unavoidable deaths from those in which the adverse events have contributed to the death. That kind of an effort has been going on. Next slide. The issue is this, that even with all that, with all kind of things that I'm trying to say, that all right, what has improved? However, even today, medical error would be the third leading killer in the United States every year. Even today, the hospital services have been now bracketed as one of the most dangerous places, most of the most dangerous services to be there. It is, in fact, as or more, I would say, dangerous than the bungee jumping. So this kind of a tag, even after 20 years of all these kind of efforts and everything, this is what is the status today. Next slide. In fact, this organization agree that why this is remaining extremely harmful. Now, this is for the more for the Western things, but definitely. I mean, according to this, the missed and the delayed diagnosis, mental health across, maternal health across continuum, early recognition of behavioral health needs, responding to device problems and learning from them, device cleaning, disinfection and sterilization, standardizing safety, patient matching in the hospital electronic record, antimicrobial stewardship, overrides fragmentation across care setting. And now you will find that a lot of it, I mean, things like early recognition of behavioral needs, or I would say that overriding of automated dispensing cabinets and patient matching in the hospital electronic record are not going to be much more very, very relevant for our country, at least at the moment. But what we have to see is that now this is a whether our efforts probably may not be going exactly to meet these requirements, which are the top 10 risks. Next. Next. So the conclusion from the international studies have been there has been a lot of learnings on the epidemiology of safety, and several effective interventions have been developed. But even the never events such as wrong patient, wrong site surgery still continue to occur in hospitals. That is even, I am saying, at the international level. The transformation of healthcare for future is depending on big data, predictive analysis, and artificial intelligence. Again, I'm saying this is the Western viewpoint. Go next. Next, please. So the principal approach, previous slide. The principal approach, previous one. The principal approach is to establish local and national reporting systems. And these systems, we will talk a little more when I talk about India. However, these reporting systems do not effectively detect adverse events. Even in the most recent comparison, reporting systems detected only about 6% of the adverse events found by the systematic review of records. Next. So the picture globally, that even before this pandemic began, globally there were more than 13,150 people every day were dying in hospitals. And if we had made safety of our health system for both caregivers and patients our number one priority, probably many lives would have been saved. There is no single villain to blame. It's the systems that have been set up ineffectively and the lack of transparency in delivering care. Now, this, please understand, is even the international perspective. You can imagine to what level you can multiply all these learnings, maybe 10 times, 20 times for our country. Next. So in India, are we doing enough? And my big emphatic this thing is no. And let's understand where are we in terms of whether we are doing enough to promote patient safety in our country. Less than 5% hospitals are accredited. You understand that we talked about many things, and definitely accreditation was one method to promote patient safety. And let me also make one thing very clear, that accreditation, unfortunately, is taken as if the hospital has achieved quality, while the hospital must understand that when I get accreditation, it is the beginning of my journey to start quality and patient safety. And that's the unfortunate part, that even that is not only even 5% of the hospitals in this country have been accredited. And I don't think that there are many kind of, I would say, communications which are trying to teach hospitals things about patient safety. So it's only at the statutory compliances and the accreditation, and that's the small number. So I said focus is more on getting accreditation than implementing quality. And that's where, I mean, I can definitely say that, yes, CAHO as an organization, we are trying to do a bit of our role to just try to address this issue in trying to tell hospitals how to implement quality, to make people sensitive about it, that the accreditation will add value when you start really implementing the standards and objective elements. Third is that the reimbursement by the government schemes, to my mind, is suffocating quality in this country. Hospitals are cutting corners. There is a kind of, you are trying to treat the giving of medical care almost like a commodity. So you're asking for an L1 kind of a thing as to who can do appendectomy at what rate, without trying to even consider whether that hospital has the infrastructure. You have no idea whether a hospital, a 100-bed hospital, is he employing 25 nurses or 50 nurses or 150 nurses. So I feel that this is one area where if the government has to become sensitive, that if you want to promote patient safety, then the reimbursements by the government schemes will have to become at least more reasonable. Can errors be discussed openly? I think unless there is a huge change of mindset needed by the media as well as by the community, that every death does not mean that there was negligence. Today, every death, every unfavorable outcome is kind of taken as that then you are searching for something wrong that has happened. And you will never learn from the errors unless we can discuss them, unless I can come into the root cause analysis, and then of course there is a poor infrastructure all over. I mean, including a person cannot even reach the hospital even in a stipulated time. Either the road is bad, or the road is congested, or the ambulance is not there. Maybe the pandemic should change some of that, because I think we have gotten at least some national attention on this issue. So I think that the infrastructure, at least in the public sector and consequently even in the private sector, should improve. Changes in the curriculum, we have been talking for a long time. I think that we require those changes on a very massive scale. We do not require cosmetic changes. It requires people to understand that we are not making doctors and nurses who are even job ready. And move from, our training has been that's true for my doctor colleagues, to understand that healthcare has now shifted from being an individual doctor-patient thing to a team-centric thing. And therefore, he has to become the captain of the team, and we have to move from individual to team excellence. And I will say that while there are many, many things that you can focus on, I feel that to start with, can we focus on at least never events, first of all, because maybe we have to graduate. We cannot try to, I would say, imitate entirely by the journey of our Western counterparts. They have had a long journey. We have to also understand how the preparedness of our community that was very eloquently brought about by Dr. Sadullah. I think all that is necessary for us to make a dent in this, I would say, whole issue of patient safety. I think that should be my last slide.
Thank you, Vijay.
Thank you so much.
Thank you. So I think both Dr. Sadullah as well as yourself are bringing about a continuing narrative of changing culture, changing behavior. So I think the interesting point you brought out that even if you have accreditation, it does not necessarily translate into patient being safe or the environment being safe. Contextualization, I totally agree with you, will have to be done. The 10 points that you showed in your ICRI slide may not happen. If it does not happen in the West, it's certainly not going to happen anytime soon. As there needs to be a tweaking of the system to be able to contextualize it to the here and now that we are facing. The point that you raised on sensitization in resource-constrained environments, financially weak systems, media trial, I think all of that definitely needs to be looked at, and perhaps a rejig of this entire piece may be warranted to be done in the future. So we certainly take it as a learning from back to the drawing board at CII. With that, I would like now to move to our next panelist, Dr. Sanjeev Singh, Chief Medical Superintendent, AIIMS Kochi, and Lead Project Operations, AIIMS Faridabad. We would love to hear your insights, Sanjeev, on the current environment. So media trial is one thing, but we certainly, while we are called warriors, we certainly in the medical fraternity are soft targets. Over to you, Sanjeev.
Thank you so much, Dr. Shabnam. It's always a pleasure to listen to you. Thank you, Dr. Shadullah and Dr. Vijay Agarwal for that explicit, lucid presentation. CII is organizing a fantastic 4-day program. So the topic which was given to me was hospital and healthcare workers are soft targets, and indeed they are. So this is one of the case study which where the patient was brought in almost a moribund state. And what we see is doctor post that incident, something like this. And when a 3D printing was done, and this is the damage which is done to a medical professional who was there to take care of the patient and to see that he goes in well. So what exactly had taken place? So 4:30 p.m. This was in NRS Medical College. A 75-year-old was brought with stroke and diarrhea, vomiting. He was severely dehydrated in a semi-conscious condition. And the team of doctor in the medicine ward did counsel the patient bystanders that he is serious, and if they want, this patient could be taken to some other hospital, but the prognosis is poor. And close to 5:05, the patient passed away. And then there is where the series of events started. 5:45 p.m., the bystanders were not ready to accept what happened to the 74-year-old relative of theirs. They assaulted the 2 female interns and a male intern in the medicine ward. And these are very hardworking people who are doing their duty to complete their medical graduation, and unfortunately, that they all are soft targets, and the bystanders, the attendants have not understood. 6:10. So where does this doctor whom you see in the picture comes in? 6:10, this doctor demanded an apology because he saw what happened to his colleagues, and while bystanders were leaving, they assaulted two more doctors. And this is where this doctor, Dr. Mukhopadhyay and Dr. Tekmani, came in from NRS Medical College, Department of Internal Medicine, and they were badly injured. And this gentleman wanted to follow his career, wanted to become a neurologist or a neurosurgeon, and there was a deep injury in the parietal lobe, and maybe the skills which is required, the hand-eye coordination or hand-hand coordination, may not be as he intended to be. 10:45 p.m. The story did not end. There were 200 more men who came in from the village, and they thrashed four more students, soft targets. They have nothing to do with this patient who got admitted. And the explanation what was given by the bystander is their father-in-law stopped breathing after one injection was given by the doctor. So complete misunderstanding or non-comprehension of this of the act of saving which goes on when the patient is generally brought in. Dr. Shadullah and Dr. Vijay Agarwal quoted Institute of Medicine report. They quoted it from the patient's perspective, but the report in 2004 also brings in a link of work environment with patient safety. And I'll explain that more in detail when we go in the further slides. But it is this transformation of the environment which is the key, and where patient is definitely coming first, no doubt about it, and then every doctor takes that oath, but then there needs to be a protection to themselves to make the environment safe. So the common causes of all this being soft target and workplace violence is because of communication and so many other things. So there are data which shows that there are homicides, there are assaults, and there are unusual, unnatural incidents which takes place. And that did take place in our country, in city of Mumbai, where Aruna Shanbag, a very young nurse who succumbed to a workplace violence. Unfortunately, we see her as a champion for passive euthanasia or active euthanasia, but then there was a workplace violence which happened, which led her to all this. And we really feel sorry for all the healthcare personnel who suffer this while delivering care. So is the definition very well defined? So NIOSH as a national institute defines it, but the explicit definition comes from World Health Organization, where they say the staff, whatever kind of abuse there is, threatening or an assault. But what is important is also to understand that it is just not within the workplace, but it is commuting to and from the work. So they have expanded this definition, which is also very key because ultimately they are coming in, going back after serving the community, involving in a challenge of patient safety and their well-being. So there is a systematic review and a meta-analysis which was performed by a university in Bonjuan, which was published in BMJ Occupational and Environmental Medicine. And they looked at 245 studies which was done of a workplace violence in healthcare. And they reported that in all of these incidents, 61.9, there is a workplace violence, 42.5, there is a non-physical violence, 24.4% there is a physical violence, and that happened that would be continuing. 57.6, the most common of it is verbal abuse, and that definitely decreases the morale of the people who are serving. 32 point, they have threats, and then there is a sexual harassment which does take place. Within the systematic review, they also said most of it happens in Asia and North American countries. The target is nurses and physicians, and the location is psychiatry and emergency medicine. So it's a very, very in-depth study which this group had done. But it does not end at the violence which takes place at that particular juncture. There was another systematic review which was performed. What happens, the aftermath of the violence, which is also important because the patient, the healthcare worker comes prepared to make patients safe. But post-violence, there is a damage, there is a moral injury which happens to this group of people who right now in COVID times are called as warriors. So there are physical, psychological, emotional, relationship issues, social, financial, all of this are the aftermath of the violence. So we need to be completely wary of the fact that we need to protect these people who wants to make society healthy. So it's a psychological and emotional consequences of the workplace, which is extremely important. Now, the WHO quoted this that physician heal thyself, and it is moving towards physicians protect thyself. And I think that is again the change which has happened, which was not reflected earlier. So if the staff are constantly worried about their own physical safety and then the co-workers and the patient, how are they expected to concentrate in an 8-hour shift or a shift out, 12-hour shift? It's going to be very, very difficult. And that is what I think is important for everybody to realize this. Now, the fact is, if you see, there are injuries which are happening, which is a high number, but there is a difference between healthcare worker and other industry. In healthcare worker, it is 9.1 cases per thousand full-time employees, whereas in other industry, which could be retail, which could be manufacturing, which could be construction, or which could be airline, hospitality, it is just 2 cases per 10,000. So we are vulnerable. And I think that vulnerability should be exposed, should be talked about, should be discussed, and should basically lead to some good solution. Now, OSHA also said that people engaged in action whose primary intent is to enhance health. So why should there be a violence for those group of people who are enhancing health? So International Labour Organization said that most of the occurrence for healthcare is happening at waiting rooms, emergency rooms, psychiatry patients, geriatric wards, and in the parking lot. So if this is the most vulnerable place within the healthcare organization, I think as healthcare managers and healthcare champions, we should take care of that. Now, this is a very, very important slide where in the Journal of Postgraduate Medicine, it says what are the risk factors, and the risk factors are patient related, which is understandable because there is an unexpected cost, satisfaction, there are legal cases, but deaths. But what is very important is the doctor related issues because they're experiencing low self-esteem, neuroticism, low agreeableness, and then there are pure communication. So these are the risk factors which we should also not shove every incident under the carpet saying that yes, they are not understanding. But there are a few things which as a healthcare we should also improve. Organizationally, there are poor administration because there must be a lack of resource, overcrowding, long waiting time, so inadequate skill mix, which could lead to workplace violence, poor safety culture. So we need to also pull up our socks and improve our workplace. And then there are societal issues, which is definitely very gross and which will take years. But these two are within our limit, and we should be cognizant of the fact that they need to be taken care of. Now, there is an upward trend, and that is a disaster because from 2011 onwards, this is the US Bureau of Labor Statistics. It has 2018, there is increased trend. Now, this is the difference. So this brown portion is a healthcare worker and the blue portion is other industry. And if we as a healthcare champions don't come together and resolve this issue, which is 5 times more vulnerable as a workplace, it's going to be a big, big disaster. A patient is definitely a source of all this issues because they came for some healing and possibly the care was not up to their expectation. What happens in India? Are we just talking about US statistics and US data? So this is a study which got published from a hospital, tertiary care hospital in South Delhi. So the violence is because there are long waiting times, there are delay in medical care, there is violation in visiting hours, there is patient dissatisfaction, psychological problems, delay in nursing care and denial. So there are multiple issues. I think definitely the community should gear up and say that yes, we are champions. We need to be we are healers. But then there are some issues which needs to be also administered at the right time. So government did take care of that. So what they did, they came up with ordinance which to amend Epidemic Disease Act 1897, where any violence against healthcare worker was cognizable and non-bailable. So it's for 30 days and then 1 year. So fantastic. I think we should appreciate what happened on 22nd of April 2020. But my issue is something else. Now this is limited to epidemics. It is limited to pandemic. Possibly in COVID we are protected, but what after that? So, is there a special law? So, we should not end our lobbying or a collaborative work here. Where is the special law in non-epidemic situation? And where is the amendment which is happening of various penal codes where healthcare worker is protected? There is a Clinical Establishment Act. Why it only talks about more governance control? Why it doesn't talk about workplace safety? And then if OSHA has a working code, why India doesn't have up till now? So I think that is where it's a fantastic step that the government took. There are more action to be taken. How do we prevent it? There needs to be a zero tolerance. There needs to be a more commitment from the management employees. We need to identify those hazards and prevent it. But I would still bet on training in communication and prognostication is also key. As soon as we see a patient, we need to be communicating it properly and give that rather than always giving a hope or delaying it would be a disaster. I would also urge to put in some engineering practices to alarms and improve better lighting. But under the hierarchy of control, it comes in the midway. So it may not be everything. So, but then engineering controls did take place. I'll end my slide with changing behavior. I think that's what Dr. Shubham Singh has been urging since the start, that there needs to be a cultural change. Creating a buddy system, and fortunately this comes up in the Ministry of Healthcare guidelines as well, restricting movements, not working alone, but importance is counseling and open communication, because that if you can create that transparency and keep counseling. So this was this gentleman who was a doctor of Safdarjung Hospital. I think I'll end there that we are there to treat people and to heal society and not be subjugated to workplace violence. Thank you very much, and over to you, Dr. Shubham.
Thank you, Sanjeev. So it's further reiterating that perhaps we need to look at this lens of patient safety to be one of the subparts of presence of safety in healthcare. So maybe the narrative now needs to move into, especially when you look at your third last slide of yours, of the risk one, patient safety is not only about this patient. There's much more to it. And the much more part needs to be a continuous process. As you said, it just cannot be limited to this. And also, I believe what you've brought out is managing expectations. I think we, from the medical community, have this concept of sab theek ho jayega, everything will be well. So the expectation with which an individual comes into the system is already benchmarked. So I think all these narratives need to be worked into, and that collective working, thinking to solve perhaps would be a step move forward. I think from CII, we will most certainly look at it. So with that, I move on to the last panelist. I don't want to be between the session and lunch for anybody. So Dr. Lalu Joseph is Associate General Med Superintendent and Quality Manager, CMC Vellore. The designation does not do justice to all the things that Lalu does, which we all know is much, much more than just this. So if you were to look at it from, as I said, from the healthcare worker perspective, as we all know, if you don't look after a healthcare worker, take COVID for instance, that person falls sick, the ripple effect down the line is intense. And if you were to translate it into hardcore, whether it's economics or safety, I'm sure it's huge. Huge. Over to you, Ladu. You're on mute. Could you unmute yourself, please? You're still muted. Thank you.
Yeah. Thank you very much, ma'am, and CII for this wonderful opportunity given to me. It's very difficult to be the last speaker after Dr. Sagdullah, Dr. Vijay Agarwal, and Dr. Sanjeev Singh. But I have a responsibility here to present healthcare workers' safety, which I feel is very, very neglected in India. Now, I want to begin with a small excerpt from Dr. Aida Skada, the founder of Christian Medical College, the graduation day address in 1922, to her very first batch of 14 medical students, all of whom were women. And she said, this is what she said: "You will not only be curing diseases, but will also be battling with epidemics, plagues, pestilences, and preventing them. You must learn to be cool, collected, and quiet, to have presence of mind, rapid thought, and action in the most trying circumstances. You must learn to have wise judgment in moments of great peril. Practice and experience will train you to have firmness and courage. Do not always look for gratitude, for sometimes when you are most deserving, you will get the least." And I think that's something that's happening. There will be care, anxieties, failures, which are very common to a professional life. These are the valleys into which you descend, but stand up bravely, be true, and keep on climbing. I particularly like this excerpt from what she said. And this picture, I thought, relates very much to me. My husband lives in the hospital and takes rounds at home. Not now, but at least when he was a PG and as a junior consultant. So typically, healthcare professionals, most of them are like this. Working in the hospital is like living in the hospital. Now, typically, what is happening? Are we really paying attention to the safety of the healthcare worker? Is it neglected? Is there any way out? Most people, particularly the ones who are not working in hospitals, think that hospitals are safe places where they go to get well. So they don't see hazards in hospitals and assume that hospitals are low risk to employees. They feel that working in a radiation, in a nuclear facility or working in a factory is more hazardous. And lack of awareness about hazards in hospital setting, which I think the fraternity in hospitals themselves are totally not aware of. Lack of scientific knowledge, priority to very specific hazards. We don't really focus on a broad-based hazards that are in our setup. And the lack of support, even if we know, we don't want to accept the kind of hazards that we are seeing. Hazards in healthcare, as per the OSHA's definition, all the hazards that they have put down are predominantly in place in healthcare. Whether it is physical hazards, dust, occupational dermatitis, radiation, noise, temperature, chemicals, including anesthetic gases, biological hazards, too many, ergonomical issues, and psychosocial hazards, including workplace stress and workplace violence, which Dr. Sanjeev attributed to. Are we at risk? I think we are at very high risk. Our focus has been completely on patient safety. This particular picture, healthcare is hazardous, talks about the hazards to patients. It talks about, getting into a hospital is like bungee jumping. That is the level to which the patient safety is being focused upon. However, if you look at it, the healthcare worker safety is probably even worse than that. So I think it's time to also shift gears and start thinking about the healthcare worker safety. Healthcare worker, who is at risk? Is it only the doctors, the nurses? No, I think it is the entire group, starting from the security, your housekeeping staff, your technologists, your administrative group, everybody is at risk, some risk or the other. Now, what are the various risk, and what about the awareness about hazards in hospitals? This particular study, Perception and Prevalence of Work-Related Health Hazards, that was conducted in one of the hospitals in South India, they said that only 39% did not recognize work-related health hazards at all. And biological hazards, 81.5% reported exposure to biological hazards. I think there we are more strong. Reported needle stick injury, and 70.5% had at least one in the previous 3 months. Psychological hazards are more to do with negative feeling, verbal or physical abuse during work. Occupational health knowledge is very poor for us. Look at this. Nursing personnel had more awareness and knowledge about biological hazards, about 50% of them, whereas less knowledge about physical and psychosocial hazards, and more knowledge about bloodborne infections, workplace stress, and least about musculoskeletal injury and equipment-related injury. Biological hazard. This is a study that was conducted in CMC. And the annual rate of tuberculosis infection, ARTI, was estimated as 7.8% among trainee nurses. And this was significantly higher than the national average of 1.5%. So look at the risk that we are putting our healthcare workers into. And risk factors for tuberculosis among healthcare workers in South India. This clearly brings out that doctors and nurses are at extreme risk when it comes to TB. And ergonomical hazards, nurses have the highest rate of back pain with an annual prevalence of 40 to 50% and a lifetime prevalence of about 35 to 80%. Every year, approximately 40,000 nurses report illnesses from back pain. This is particularly pertaining to patient transport, transfer, repositioning, etc. And the financial implications, this has not been studied in India, but it's about $16 billion annually in the US. Psychosocial hazards, it is really too much at the moment, particularly as Dr. Sanjeev said, pertaining to workplace violence and violence from patients, relatives. It is a huge issue now in our healthcare industry. Nurses' occupational stresses were poor. They were predominantly the attitude of the doctors that stressed them the most. Posting in busy departments, inadequate pay, too much work, and these were the reasons quoted by some of the nurses. And prevalence of moderate to severe stress level was 40% among doctors working in critical care areas. Now, I just wanted to bring about some studies just to bring out various aspects of hazards in the hospitals. And the current scenario is not very bright. It is often therapeutic help that is provided to the healthcare workers. And again, we all know it is loss of work hours, and particularly with regards to COVID, one person becomes sick. It is almost not having that doctor, nurse, or healthcare worker for more than a month. And we realize that there are a lot of costs associated if we don't take care of them properly, not just then, but for a prolonged period of time. And it's a huge burden on the health system, and which leaves a very bad residual effect as well. So we need to now start focusing very specifically on workplace safety and occupational health issues in our hospitals. Healthier employees are more focused and they are aware, improves the staff morale all around. Happy employees stay longer at the job and less turnover of staff, very less absenteeism, reduced healthcare expenditure, higher levels of self-confidence in themselves, and which inspires confidence in others around them. Today, I think it's a total burnout that we are seeing. It's not just with COVID, but even, pandemics, epidemics. It's not just that, but even with the healthcare workers working in the hospitals on a normal routine, it is a lot of stress that we see in hospitals. Physician burnout has an impact on patient outcomes in terms of patient satisfaction and time taken to recover post-discharge from hospital. This is not from what I am saying. This is all proven from studies abroad. So we need to be extremely careful. So we tend to put a tag with everything that we do in our hospitals. Even if you have to provide a lead apron, you look at the quantity, the amount that we need to spend in buying the lead apron. Often we ignore that, this is something that we need to really provide to take care of our healthcare workers. It does cost money, but pays off within no time. And poor staff health can be extremely expensive. Happy staff will have happy customers, and it's a moral responsibility of the hospitals to take care of their employees. Particularly in times of COVID now, we are seeing that the awareness is becoming more. Initially, there were compromises on the personal protective equipment, the way things were structured for the staff who were working in the COVID areas. As time passed, more and more healthcare workers started getting affected. So today we spend a lot of time and resources on taking care of our healthcare workers. But this is not something that we need to focus on only during the pandemic. It's extremely important once this pandemic is over that we take a wholesome approach towards healthcare worker safety. And CAHO has launched a competition nationally and now it's become international as well on workplace safety during COVID times. And we've got excellent response from the hospitals towards the initiatives that they have taken in providing safety during COVID times to their workers. So as we all say, healthcare workers today definitely are warriors. But whatever we do, we need to really thank them for what they are facing amidst all the safety concerns in front of them. So I think I should take this opportunity to thank the healthcare workers, irrespective, of whether it's doctors, nurses, but it's all the workers who are working in the hospitals. Thank you so much for everything you do, both in facing this pandemic and before it. You have taken care of families at every step from birth to death. You are now walking right into the fire, ignoring your own personal safety to help humanity get through these tough times. And I feel this presentation is dedicated to the strength, resilience, and care of our healthcare workers. Thank you very much, Madam and CII, for this opportunity.
Thank you, Lalu. And I think your closing slide was truly wonderful. Healthcare professionals were never trained for war. So this new tag of warriors is certainly new. A lot of work has to be done, and I think brought out very well by all the panelists. Thank you ever so much for your inputs. In the interest of time, can't take any Q&As, but do email us and we'll take it up with the specific panelists. Thank you all very, very much for a wonderful session.
Thank you.
Thank you.
Thank you so much.
Sir,
National insurance introduced coverage policy nationally against expenses of patient or home care due to COVID-19 and post-hospital includes IU's treatment. Short-term policy period can be chosen. Rupees 51 health check. Policy national order for the office. National insurance declared since 19. Fine. Landmarks. Of Indian industry. Engineering is seamlessly of Indian in 75. Looked for external 1982. Industry for addressing tire manufacturing. In 19 CII meet the demands of organization and company. Here in 1995, it grew stronger. Aspiring. Was across I consolidation. This is across India. In competitiveness, CII enhances capabilities and competitiveness of enterprises through training, consulting, advice, and it conducts research for industry and centers of excellence in sustainability and to opportunities. Building engagement with the community. CII job fairs and the contribution. Air pollution since 1895. Partnership and pioneering as for 100 as India's journey. Global can be needed for a robust, accessible, primary healthcare. The private sector plus digital. North and East India. You can get moreover, you're continually increasing access to basic health. efficiency of services. Into COVID-19. Hygiene and social. Significantly, healthy India are going to reach 100 million year 2020. As ambitious as it is, we believe that all this investment, our partners, training. Three and post hospitalization. For 3 hours. Yes, 5 available on disease. For detailed website on health. National Institute since 1900. Five engineering companies to 4 billion and iron trade. Social growth. Indian industry. And independence. Time for in 1975, looked for Institute Association is the first ever airing tree to the world in 1977. Connecting for in 1990, CII merged effectiveness as CII Healthcare development in industry to achieve excellence in engagement and for doing things industry emerge. CII opens through its processes and competitive enterprises through training, advice, and leadership. CII next level business under international for small across the world. Air pollution and since 1895 worked with innovation, partnership, and daring. It has 8.6 countries with access to proper healthcare for a country underscores the need for a robust primary health system that is complex, aware, partnership with out of pocket. All the 5 states, 5-7 less symptoms with action taken as per the guidelines. the government sector, and capacity building. Absolutely. Wish. Streets. This is the speak towards our wish. For joining us. 7 and beyond. If we work towards it. Its expenses on hospitalization, expenses post-hospitalization, short of the piece. Yes, discount for it. For details, please visit our website, CII office. Insurance. Five companies came together, formed the engine, joining the base. Association crossed multiple milestones as it went on to India as the Confederation of Industry in 19. India were ruled of this small companies formed the Association of India. The association further helped India emerge stronger after independence. Therefore, in a landmark move, the two engineers merged seamlessly. Industry to settle. When India facing the industry 77. The first overseas entered into AM to build in New Delhi, 1986. The Confederation of India for addressing the entire manufacturing sector. In 1990, as the Confederation of Indian Industry, Indian industry, CII 1995. With society. Since then, CII has has inspired fostering a confusion. Analytical. What through its offices and processes to contribute to development. In competitiveness, CII of enterprises through training, consulting, advice. CII through its network of sustainability. CII's building their technology for the next under international organizations, 130 countries. Since 1895. Guidelines of the Government of India. In addition, we are partnering with governments to support its principles and social distancing practice. In the past, techno-managers, 3 and private investment, leveraging innovation. We aim of a healthy by 2020. Policy benefits of the piece of no people entry 5% policy is available on easy external website audience trusted since 1906. Five 1895. It was really 1974. In 1975, when India looked for external first ever seven, India to the world. Initiated its first since then, CII quality, free skill development, social responsibility. CII is a reach for efforts. It's engagement. Enhances the end users. Sustainability is building technology capabilities the next level of business. About organizations in over 100 business missions across the world. Engagement with the community. Relief and rehabilitation. Water conservation. Alex, 5.7 million people so far.
Hello, Dr. Nalini. Hi. I think you'll have to unmute. Hello. Good afternoon, Dr. Mohan. Good to see you.
See me and hear me, no?
Yes, we can hear you and we can see you.
Okay. So I'm okay. Right. Hi, Nalini. Nalini is an old friend.
Nalini, I think you'll have to unmute, please.
Yeah, she's unmute, Nalini.
Okay.
Yes, you're.
There you are.
I think we've lost you again. You'll have to unmute.
Okay.
Yes,
Yeah.
we can hear
How are
you.
you, Nalini? Long time.
Yes, how are you?
Fine, thank you.
Good.
We haven't met after your paper got published in the
I
journal.
know.
Because Ranjini is in touch and yeah.
Right. Akshita, how have the sessions been?
Sorry, Nalini, I couldn't catch you on that.
How have the sessions been going? I said.
Yeah, fantastic. Yesterday, I think the inaugural had over 1,500 viewers while it was happening. And the minister, the health minister, the MOS, Dr. Randeep Guleria, he's chairing our public health council. Dr. Paul, they were all there. So, because this was the inaugural of the public health conference and also the CII Healthcare Week, I think it was a fantastic lineup of all the important experts in this area of public health. So it's been going well, and even from today morning, what we've made a note of, we've got over 400 people viewing.
Awesome.
So we are hosting on Hive, and we are also live streaming to YouTube. So so the participation has been very good.
Okay. Hey, I have some slides. Do you think I should send it to you? I don't know if we'll have time. I wasn't sure. I didn't hear back from Vivek.
So, Dr. Nalini, just check on your screen the third icon, because you're supposed to be able to share from your side. We can enable that.
Yes, just enable that and I'll see, because
We'll
it's
do
right
that.
across me.
We'll do that.
That would be the simplest. Then it's in my control. Don't have to worry.
Yeah. Hi. Good afternoon, Dr. Sood.
Good afternoon, Akashinta. How are you?
We're well. Welcome, welcome.
Thank you very much. I have sent you the slide
Yeah,
deck.
we've received your presentation.
Thank you. Thank you.
We'll just have that. Or do you want us to give you the presenting rights as well, Dr. Sood? Do you want to share it from your end?
Or you can, I'll just say move, you can just move. That's fine. As long as.
Okay, just give us a minute.
Yeah.
Akanshita, shall I send you mine?
You can.
Okay. I'll just do that so that we don't have to fuss.
Sure. Hi, good afternoon, Bhakiran. Good to see you.
Akashinta, can you hear clearly? The sound is fine?
Yes, Dr. Bulbul, you are visible and audible.
Okay, great.
So good afternoon, everyone. I'm Prabhakaran. Can you hear me?
Yes, Dr. Prabhakaran, you're audible.
Yeah. So good afternoon to Dr. Mohan, Nalini.
Good afternoon.
Good afternoon, this is Soumya.
Hi, Samuel.
Hi, good afternoon. How are you?
Good afternoon. How are you? Good. Good to see you.
Pleasure. Thank you.
Dr. Sood, what a pleasure to meet you again.
Hi,
Nalini.
Sanjay. How are you?
Good.
Good. How's COVID-19 teaching all?
Right. Okay. I'm looking for my slides so that I can send it to our Kanshita and I don't have to worry about it.
Yeah.
Give me 1 second.
So things are.
Kanshita, I sent it to you and Anugrah. Just let me know when you get it, okay?
It's nice to see Mr. Modi. You're all dressed up.
Yeah, after a long time, maybe I could say. Otherwise, it's usually office calls, so it's pretty okay.
I know. I know. It's always good to, yeah. But I don't know how long this is going to last, but we have reopened our offices. So
Yeah, even
Orissa and all the states, Delhi also. So we work twice a week. We are going to offices and we are trying to keep, 1/3 staff all the time, social distancing and all the usual stuff.
correct. No, even we've changed. We've opened up our offices, and people have been going to office now. So we've started. Some go once a week, some twice a week. So we've at least started that way. I'm just trying to change the background, but somehow it is not allowing me to change the background. On very easy to change the background. Here, I think it's creating a little, but I think should be done.
Sir, in Zoom, it is easy
You
to
have
change
a-
your background, but in text possible.
Yeah, it is saying it's giving an option, but it's not allowing to change.
It's okay. Your background is looking good. Don't worry.
No, I'm just trying. Let's see.
You want to make it a mountain or something?
No, whatever. At least better than seeing. Okay, this may not work for today's meeting. Yeah, this is okay. This looks fine. Okay.
Oh yeah, so that's a great one.
I think next to yeah, if you click on your icon next to your photograph, there will be 3 dots. On those dots, you can go and change the background if you want.
Okay. I think I'll just take the time.
No, if the background is
So
changing,
it is,
then I can move to a slightly more comfortable position to sit.
Yeah. We 3, correct?
Yes. That's what
Yes,
the
please.
agenda says.
Are they coming on time?
So Modi, you are where? In Mumbai?
Yeah, based out of Mumbai.
Yes. How are things in Mumbai?
See, if you go out, doesn't look so bad because it's like, except for the local trains, everything seems to be business as usual. And last at least 40 for 30 days or so, cases have been around 1,000 mark in Mumbai. So some days it is 750, some days it is 1100. So by and large, it looks okay. I mean, but it's anyone's guess. Someday they report 1,400 cases, so you never know. Good
Pune
part is, I don't know how. Sorry, yeah.
surveillance is saying Pune 50% population is already has the
Yeah.
bodies. So I guess the same would be in Mumbai also.
Should be, because I think there was another report which says in Delhi also it was more than 25%, 25 or 33%,
Yeah,
something
so
like that.
last survey showed it
Yeah,
was before. So now
4.
I think they are right now currently doing, so the result should be out. And it's ultimately is going to be, people will develop antibodies and
Correct, correct.
have to move on. But,
I think this is not going anywhere, right? It's going to stay here at least for
yeah,
another 8 months to a year. And the earlier we get used to and start working, it's something like that, because the impact is pretty bad across. So.
that's true.
But mostly now, except for very elderly patients above 75, 80, who have some comorbidity, balance, most of the people are
Coverage.
quarantining themselves at home or symptomatic. They would take an antibiotic here and there, some paracetamol, and it's okay in 14 days, sort of a thing. Yeah.
I think earlier people, since one was learning, about this disease, as gradually, so management also was hit and trial kind of a thing. Now people know
Correct.
exactly what to do or what not to do also, because
What
earlier
not to do as well.
also too much of oxygenation was bad for the body, also for the lungs. So
True.
now I think they are able to at least uh, find out a way by which they can reduce the morbidities and at the same time we keep them on. Well, the data is, the mortality is low, so that's a very
Mortality is low. Yeah, that's a good thing at least. And
2%.
it's at 8% now. I think I was reading somewhere now the infection rate is at 8% of the. It's like stabilized at 8% for the population, something like that. So that way it's okay as of now. Let's see. The issue being that within a country we are so many countries, though every state is peaking at a different
Yeah.
time, whereas in other countries it's done and dusted. For that country it's over, then nothing comes up. Even if it comes up, it's very less numbers, but in our case every state is peaking at a different time. So we have our own set of challenges there.
There's also how much testing you are doing. So
Correct.
testing where you are doing more testing, you have more diagnostics and numbers.
Yes.
So like
Yes.
BR is still very low when it comes to testing. But
Okay.
yeah, I think the rate in Delhi they say is the highest for the population wise, and then I think comes Maharashtra.
Maharashtra. Yeah, in fact, Mumbai and Pune were always ahead, but later on, then the cases in Delhi started rising. So Delhi city has more cases than Mumbai at any point of time now. So that was a bit
You're also getting about 1,000 almost a day. Kind of.
1,000 a day. Yeah, so
Yeah,
that's almost same. Even here, some days it is 750 in Mumbai proper, some day it is 1,100. So it ranges between cases only. Pune's bad. Pune's been getting around 2,000, 2,500 cases, which is pretty high for Pune.
So who else is joining? I was told
I
we are
think
5
there were
of us.
5. Yeah, I think
He's there and you are there.
Mr. Prabhakaran has also joined, and I think Dr.
I saw Dr. Mohan earlier.
Yeah, Dr. Mohan is also there.
Good evening, Dr. Jha. Tuning in.
Hi, good afternoon.
I think we're left with 2 minutes, but all our panelists have already joined. So are we can start if you feel in the session.
So whenever you ask,
Hello, Dr.
you
Jha,
can
how
start.
are you?
Hi,
Mohan.
very good.
Hi.
Are you suggesting we start?
I believe we can start, Dr. Jha.
All right. So, good afternoon, everybody. Welcome to this plenary session on non-communicable diseases. My name is Vivekananda Jha. I am the Executive Director of the George Institute for Global Health, which is a not-for-profit research organization working mostly in the space of non-communicable diseases. I'm going to be moderating this panel, which is first rate. And I will introduce our panelists in a moment. But it's fair to say that in India, we are already encountering big epidemic of non-communicable diseases, which is largely due to external forces and to some extent also due to personal decision making. But I think the value of social determinants in determining what happens to individuals as a result of their encounter with non-communicable diseases is being increasingly recognized. Internal factors which are difficult to control. There are a number of external factors as well, which include climate change, increase in pollution, change in food habits, especially consumption of fast food, and to some extent also the price for the technological advances that we are making. Our reliance more and more on vehicles, which is reducing the amount around.
Dr. Jha, we can't hear you. Your voice is breaking.
Consumer non-work time. Is that true for everybody? You're not able to hear me?
Your voice is breaking. Maybe the bandwidth is not that good. You can see, but when you're speaking, it's breaking.
Okay, I'll switch off my video. So, non-communicable diseases are rising.
It's better now.
Yeah. So we as the healthcare community, as well as all the other stakeholders, have recognized this looming pandemic. It's kind of strange to talk about another pandemic since we are in the middle of a real one. But because has created a roadmap, and that roadmap has specific targets and indicators which are aligned to the Sustainable Development Goals. The current government of India target is to bring down the burden of non-communicable disease mortality by 25% in the next 5 years. Will we be able to achieve that? What are the challenges that we need to be mindful of? How can the different sections of the healthcare stakeholder community respond to this challenge? It's what we would really expect our panelists to shed some lights on. The organizers of this meeting have very helpfully set down a few questions, and I would just read these questions to set the stage. And those questions are: what are the challenges which are preventing India, or which could prevent India going forward from achieving this 25 by 25 target? The second question is, how can we specifically use data integration and creation of large social, environmental, and clinical data sets to help achieve this particular goal? The third question, which is extremely relevant, is how can the civil society converge to help achieve India's target? And then finally, something which is a very important part of our healthcare system, role of the private sector. How can it engage and get involved in making their workplaces healthy? So to discuss these questions, we have really, as I said, an eminent panel. You can already see the panelists on your screen. I would introduce them very briefly and then invite them to make their comments for about 5 to 7 minutes, and then we can have an open panel discussion. Starting from the left of my screen, we have Dr. V. Mohan, who is the chairman and chief of diabetology of the Dr. Mohan's Diabetes Specialty Center. He's one of the most preeminent diabetes researchers and setters of standard in diabetes care in the country. Then we have Dr. Nalini Saligram, who is the founder and CEO of Arogya World, which is a global not-for-profit which is committed to changing the course of chronic diseases. She is also an Ashoka Fellow. And next we have Professor D. Prabhakaran, who is extremely well known around the world as a top-level researcher. He is currently the executive director of the Center for Chronic Disease Control, and is also the vice president of the Public Health Foundation of India. And finally, we are joined by Mr. Saumil Modi, who is the oncology general manager of Novartis. So maybe I can start off by requesting Dr. Mohan to please share his thoughts about the upcoming challenges that India faces in its battle against non-communicable diseases, and his advice on how can we adopt a sustainable strategy to reach that goal. Dr. Mohan.
Dr. Mohan, may I request you to please unmute yourself?
Okay, now?
Yes, please.
Thank you. Thank you, Dr. Jha, for the kind introduction and for setting the scene for today's discussion. I'd also like to thank CII and the organizers for arranging this particular panel discussion. I think it's, as you mentioned, it's very relevant to have this discussion because, and just yesterday, day before yesterday, I had a article in the open page of the Hindu, and the title was, "Are NCDs Sidelined by COVID?" And so I made a plea that, COVID is very important, but COVID will come and COVID will go, but NCDs will stay forever. It looks like that. And so with India set to become the diabetes capital of the world, already probably the heart attack capital of the world, the kidney disease capital of the world, and every other NCD that you can think of, I think it's very important not to lose our focus on non-communicable diseases when we have a pandemic like this. Now, answering the question, I'll stick to diabetes because I have Dr. Prabhakar going to talk about the heart, and we have others also on the panel. If you look at diabetes in India, today it's estimated that almost 80 million people are affected with diabetes. The majority, of course, being type 2 diabetes, but we also have other forms of diabetes. And there is, what is more worrisome is that there are an equal number, almost 80 million people with pre-diabetes. This is a stage before diabetes. And these are the people who will convert to diabetes such that in the next 10 to 20 years, this number of 80 million can increase to 130, 140 million or more if we are not careful. But to me, that also gives a huge window of opportunity because if we focus on these high-risk groups and those with pre-diabetes, for example, we can actually revert them back to normal instead of allowing them to progress to diabetes. As Dr. Jha mentioned in his introduction, lifestyle is key for most non-communicable diseases. In fact, there's a common thread which goes through these lifestyle factors. For example, physical inactivity not only makes you more prone to obesity, diabetes, but also to heart disease, hypertension, and even certain forms of cancer. If you take smoking, it not only produces cancer, but can also produce heart disease and can also produce diabetes. Unhealthy diet is a kind of a link between all of these. Of course, stress and depression, which we should talk about in these COVID times, is something which can trigger almost all the non-communicable diseases because we know that there is a link between, for example, depression and diabetes. And depression also comes under non-communicable disease. In fact, I'm pleased to say that this evening, at about 8:30 Indian time, our big paper will be published in JAMA, where we are showing that if you don't treat each disease in a silo, but if you treat in a collaborative sense, you can actually, what we did was we looked for screened and treated depression in a diabetes clinic, 4 diabetes clinics actually, All India Institute, Delhi, ours, Dr. Mohan Center in Chennai, and a center in Bangalore, and another one in Vizag. And we were able to show that using care coordinators who just took a history of depression using a standardized PHQ-9 questionnaire, and then providing motivational interviewing and counseling to these people, we're able to not only improve the depression, but also the diabetes and control the blood pressure as well as the lipids. So this kind of a holistic approach is needed for NCDs. And to start with, I think some of the issues which they were raised, how can the private sector do that? How can civil societies converge? One of the last things which was asked is how can the private sector engage and involve making workplaces healthy? Not only private sector, everywhere the workplace can be made healthy. To start with our canteens, we have so many corporates in India, we have so many government organizations, we have so many private sector agencies. If we make our canteen healthy, if we reduce the amount of carbs that we take and the unhealthy fats, promote the intake of more protein and the healthier, complex carbohydrates and the healthy fats like the monounsaturated fat or the polyunsaturated fat, that would be a great step forward. In every organization, if you're able to encourage weight loss in those who are overweight, I know that there are some organizations who actually reward people who lose weight, but definitely at least increase the physical activity by giving them breaks, by providing gym facilities at the place of work. We have it in our own hospital. We have it not only for patients, but also for our staff. We have Zumba classes, we have dancing classes, we have physical activity gyms which are run with private trainers. All this is offered free of cost to the staff. So these are ways in which, and many of our staff have actually lost their weight. We had competitions as to how many weight loss would occur, how much fat loss would occur. And this has really helped to make our own staff members much healthier. We also introduce yoga. Once you introduce yoga and pranayama, then the stress, depression, anxiety comes down, which is very much needed during COVID. So even by using simple measures like diet, exercise, weight loss, and stress reduction, a lot can be done to prevent diabetes and so on. We have shown in our study, the DCLIP study, for example, that almost 35% of people with pre-diabetes can be prevented from developing diabetes and actually revert back to the normal glucose tolerance stage. This is by using some structured education on diet and exercise. 16 classes were given, very large sample size of people, the randomized clinical trial. We're able to show that it can actually prevent diabetes. The evidence is already there. We don't need to look for more and more evidence. The evidence is already there. Now the time has come for action, making a role. I think the leaders of these places should also be role models. And if we set the scene, a lot can be done with relatively low cost. They're actually low-hanging fruit. And I think using diabetes as a model for prevention and for assessment of NCDs and for prevention of NCDs, it's a great model to adopt. So I'll stop there. Thank you.
Thank you, Dr. Mohan, for that wonderful summary of the importance of most important metabolic condition and what it can do to our overall health and how can we work together to address this challenge. Before I move on to our next panelist, I have to admit to an omission. I forgot to introduce our last panelist, who is Dr. Bulbul Sood. She is the India Country Director of the JPIGO organization, and we'll be really very pleased to hear from her later on during this program as well. So now can I move on and invite Dr. Nalini Saligram of Arogya World to share her views?
Great. Thank you very much, Dr. Jha, and CII, thank you for including me on this panel. I have some slides, if you could please share those. I want to, next slide, tell you that, something that Dr. Mohan already referred to, and that is, he said 80 million, so I need to correct that slide. 80 million people live with diabetes. And that's something we at Arogya World can't live with. And I'm sure everyone attending this panel also can't live with this. We can't allow so many people to live with the disease, especially because we know type 2 diabetes isn't inevitable. It is preventable. So next slide, please. I wanted to just address one question, if I could, that was posed to this panel. How can civil society help India meet its 25 by 25 commitment? So India wants to reduce the burden of NCDs. You can, yes, please build that slide. You can just keep clicking on it. It's an animated slide. It'll come up. Yes. So India wants to reduce its burden of NCDs by 25% by year 2025. Well, I wanted to tell you the story of Arogya World and tell you how, using just that story, tell you a little bit about how civil society can actually play a big role. So this is our doorstep health model. This is Arogya World's approach to prevention. As we know, prevention, these diseases, NCDs, are largely preventable with lifestyle change. 80% of heart disease, 80% of type 2 diabetes, and 40% of cancers can be prevented with 3 lifestyle changes. You eat right, you exercise, and you avoid tobacco. So this prevention is at the core of all our work, and we are taking it to the community, to people right where they live and learn and work. We have a schools program. We have a very active healthy workplace program, and we also are taking these messages deep into the community. We have reached 5 million people to date with this model, Doorstep Health. Next slide, please. So we work all over India. Next slide. And we are backed by many, many groups. We are really grateful for these partnerships that we have developed with so many companies and foundations and NGOs and even individual donors. we have able to make progress. Next slide. Yeah, next slide. Our programs are thoughtfully designed. Just the previous one, please. Our schools program, for instance, teaches 11 and 12-year-old school children in the school setting about healthy living. We teach them about making good health choices, and we are trying to shape the behaviors, health behaviors of these kids. And we're getting really good results. We're getting about 15% impact, improvement in awareness, improvement in behaviors. And these children are so excited about learning new things and we make the games very, very age appropriate and compelling. So through the games and through a bit of reading, we know we are influencing how the health trajectory of those kids will develop. So we're very excited about the schools program. We're in partnership or in conversations with Ayushman Bharat also. We're aligned with the National School Health Program as well. We have a tool called My Thali, which is based on the NIN guidelines, but is also based on the US Department of Agriculture's approach, the My Plate approach. So this picture of My Thali empowers women about what to eat and in what quantities at each meal. It also talks about what men should eat, what the children should eat. It also tells you how much sugar and how much salt and how much oil in the whole day. It's a really great tool, and we are promoting it aggressively to through social media and to working people in urban India. We've also developed a picture of My Thali for rural adolescent girls, and we're really hopeful we can, if we all work together, change the way India eats. Next slide, please. We have a massive text message program, an health program called M-Diabetes, where we have shown 20% impact. Multiple health behaviors have improved. We worked with Nokia to do the program in 1 million people. And we have also now expanded to another 700,000 with support from WRIST and Hans Foundation. We took this to Aravind Eye Hospitals, people in Aravind Eye Hospitals, and we just completed 300,000 people receiving these messages. So we are deploying our content at the population level, just like prevention should be. Prevention is effective at the population level. So we are attempting that. Next slide, please. And then our healthy workplace program. I want to say that this is our largest program. We have 134 companies that have become healthy workplaces so far. We have a set of benchmarking criteria through which we lead you. We get you from one level, bronze, silver to gold. We have a platinum. We invite all the companies listening to this call and all members of CII and everybody here to please join us. We're inviting you, join us, become a healthy workplace, and then we will help you with additional programs and services to actually improve the health and track and measure how much of the employee health has improved. So this is again something we're very proud of. It's pioneering work for us in India, and we are developing mentally healthy workplace criteria now in partnership with Harvard experts. So really, we are inviting you to join us. Next slide, please. So, how can civil society help India? Well, as I have demonstrated, we can implement programs, public health programs. We can take the programs to the last mile. We can reach urban, rural, and semi-urban communities. We can change the way India eats. We can leverage digital school health programs, and we can send NCD prevention messages to millions. So we can help implement public health programs. We have excellent behavior change content, and we'd like you very much, go back please to one slide,
Saligram, could you please wrap up, please?
Yes. And we are good partners, and in civil society, we can be used as good trainers. So just one last point, we are passionate, we are mission driven, we are restless in NGOs. And so please use NGOs to complete the loop with the last mile and help implement. Thank you. Thank you very much to CII for including NGOs in this panel.
Thank you, Dr. Saligram. Your passion was definitely showing through. Thank you for doing everything that you do. Can I now move on and request Professor Prabhakaran to share his views? And while he does that, if I might request him to make some specific mention of what are the challenges that the COVID pandemic has presented to the care of non-communicable diseases in the current context. Professor Prabhakaran, please.
Thank you, for that very kind introduction, very generous, and thanks to CII for inviting me in this panel. I think the first question is an important question. What are the challenges preventing India from achieving 25 by 25 goals? I think the biggest challenge is in terms of policy interventions, because as we know that across the world, within one generation, there has been a 50% decline in cardiovascular disease mortality, and that has largely come from non-personal policy interventions. India has done somewhat well in terms of tobacco control, although there are several areas where implementation is an issue, and there are some new issues that need to be catered to. But in terms of others like diet and physical activity, we are really far away. In terms of diet, as far as the surveillance program is concerned, because we need to keep account on how things are progressing, how things are moving, we are somewhat okay in terms of getting our prevalence studies, getting disease burden estimates, and so on. But in terms of behavioral risk factors such as diet and physical activity, or even the newly added risk factor air pollution, we are somewhat way behind. Second is, I think we need to define our biomarkers, define our markers exactly to suit our context. Because, for example, if you use cholesterol cutoff of 200, that may be a little high for Indians, and we need to actually get it down or use our own cutoffs. And for that, we need our own studies, such as large cohorts, to get that kind of data. And that is underway, and it may take a few years more for us to get that kind of data. So I think in terms of the diet, we need to focus on 2 or 3 important things: trans fats, sodium, particularly for people with hypertension, and look at some of the cultural practices that influence people's diet and physical activity. When it comes to physical activity, we think that providing messages to people, providing information to people actually can change behavior. But I think behavior change has got 3 components. We need to provide information to people so that they say that I can, but we need to empower them and we provide information so that they say I know, but we need to empower them to say that so that they can, and make them advocates for change so that they ask for that change. And for that, we need to provide an enabling environment. And as we can see, most of the cities, it's very difficult to walk, and there are so many other issues. And the policies need to be changed so that it can facilitate walking or exercising as a routine. The other reasons for inability to achieve 25 by 25 goals could be a weak primary care. And I think we require to strengthen primary care, particularly the workforce, particularly in the capacity building of primary care physicians and lower level which are working very closely with Dr. Mohan's group in identifying those issues. And even Dr. Jha's group has also done a lot of work in terms of using ML technologies. So those needs to be scaled up, implemented, and creating a program in a sustainable manner is required. The last point I wanted to make is on universal health coverage, particularly in terms of the challenges. While the Ayushman Bharat program caters to the lowest 40% of the population, it leaves out a large number of people for coverage. But the fact is, it covers only acute care. But what about chronic diseases, which requires lifelong care? For a poor person, even an anti-diabetic treatment for 1 year or anti-hypertensive treatment for 1 year is going to be extremely difficult. So we need ways and means of getting those drugs for the poorest of the poor, so that people with disease have better outcomes. So these are some of the challenges that we face. Dr. Jha specifically asked me a question on what is happening in the COVID era in terms of people with NCDs or chronic diseases. The WHO did a survey in March, actually in the very early phase of the epidemic, and in several countries, India was one of them, and found that almost a third to half the population were not receiving the usual care. It impacted cardiac rehabilitation, it impacted screening for risk factors, it impacted people coming for routine management of hypertension, diabetes. They were not unable to come to the hospitals. It also prevented people from getting back to, if they had an acute illness like acute myocardial infarction or stroke, reaching the hospital at the earliest given the lockdown. In fact, the Cardiology Society of India is just embarked and is almost completing a big survey to look at what were the patterns of admissions in 2019 during the same period as compared to now. And that data will reveal very important and interesting findings in terms of what has happened to people. Are we getting more sicker people? People are not coming into the clinics because of these issues. So these are some of the issues that need to be addressed. I won't get into the civil society issue because Dr. Saligram has answered that extremely well, but I just wanted to make a point on worksite wellness. And we did one of the first studies in worksite wellness, which was published in the Journal of American College of Cardiology around 10 years back. And we estimated that it is a very, very cost-effective measure in terms of improving risk factors. And in fact, the Institute of Medicine, Washington, and the World Economic Forum had said that that's one of the uh, best best practices to be replicated across the world. And we have embarked along with Dr. Mohan on another project where we are looking at preventing the incidence of diabetes by peer-to-peer training. I think we require innovations, we require patient engagement, people engagement, like in the UK where the nice decisions are taken by people. So I think we require some innovations like that. I'll stop here. I'll be happy to answer any questions later on. Thank you.
Indeed. Thank you, Professor Prabhakaran, for making the point about the value of innovation, value of constantly trying to think outside the box and finding new ways to address the challenges of communicable diseases in resource limited settings. Can I now pass on to Mr. Saumil Modi, who is from Novartis, to present his views specifically around how the private sector can engage in this battle and work together with all the other stakeholders, which includes not only government, but also non-government organizations, civil society, and the patient community in general to take the fight to for 25 by 25 further.
Yeah.
Mr. Mukherjee, please.
Yeah, thank you, Dr. Jha, and thank you, CII, for today's invitation to be on this panel. And as the earlier panelists also spoke, and I truly echo with what Doctor said earlier in terms of, pandemics will come and pandemics will go, but NCDs are here to stay. And let me give you a very specific view in terms of what can be done and what are the things that we do at Novartis in terms of building trusted partnerships and contribute towards the society. And as we look at this whole thing, given the breadth of our country, given the diversity that we have in our country, challenges are always bound to be there. And how do we look at creating a complete ecosystem around the NCDs is something that's very important. And when I say creating a complete ecosystem, it starts right from identifying the problem. So, I mean, we worked very closely with CII, and a very breast cancer specific example, we've created a complete white paper with CII trying to identify. So it's very important that whichever NCD we're talking about, try and identify what the root cause problem is and which are the areas where there are specific issues that we're talking about. And once we diagnose what the problem is, whether it's related to awareness, whether it's related to screening, then how do we build the on-ground capacity? And this is an area where a lot of companies from the private sector could definitely come in, because at some point of time in their healthcare transaction model, I think this is an area they're always working on. Either they're working on increasing awareness, either they're working on increasing diagnosis. And we work very closely currently with Japaigo, and the next speaker would also be talking about it, in terms of a very specific project in Orissa where we're looking at, increasing the awareness and diagnosis as far as breast cancer is concerned as a project. So that's something. How do we really increase the on-ground capabilities, maybe through ASHA workers, which the government provides, or through n number of means, and increase that awareness about either cell screening or increase the awareness about diagnosis. So I think that's a very important part in terms of the entire ecosystem. And the next point that one could also look at is the capability development. And when I say capability development, one of the important element that comes in here in capability development is that there are a lot of NGOs who work, there are a lot of other bodies who work in terms of helping these patients, in terms of identifying, in terms of screening. But what is more important is it's not about only screening, it's also about providing them the right treatment from time to time, ensuring that we create the right access, and also helping them with funds for treatment as well. While the government has done a lot of work in terms of, through Ayushman Bharat, earlier cancer treatments were not available to patients, but now almost 40 to 50% of the population has an access to cancer treatment across the centers, which is a very good step by the government of India. What the private sector can come in and do here is how can we really play a role in capability development? And when I say that, it's important that all the healthcare workers who are there, whether they are NGOs or whether they are other specific bodies, can we empower them? We've started a program with SP Gen where, we've picked up people who working in patient advocacy. We're working very closely with NGOs, and we're taking them through a complete course on organizational development, on leadership development, at the same time succession planning. And this really helps them to think through their footprint as to how they want to contribute, how they create a complete system within their organization. So it's more sustainable over a period of time, and it's not a 1 or 2 or 3 year initiatives that they are looking at. So these are certain areas where the private sector could definitely come in. And over a period of time, one thing which many companies have been doing is, because as my earlier speaker also said that, with Ayushman Bharat, we catering to the below poverty line population, the affluent population in the country can almost afford the moon. But then there's a significant part of the population, the upper middle, and the lower middle class. And what are the specific access programs the private companies can create so that even this population can have an access to healthcare? So I think there are roles which are cut out for each and every person in this ecosystem. With someone being the pivot, being the center point, a lot of things can be done, right from diagnosis, help the patient connect to the right center, increase the awareness, at the same time provide care. And the last point I would like to make is how do we really leverage technology in this? And I think AI can play a very important role, especially when we talk of diagnosis. AI is the way to go, and the way a lot of companies are working today, I think whether it comes to cardiac, whether it comes to ophthalmology, AI is going to play a very big role as we move ahead in this journey towards the 2025 goal. So maybe Dr. Jha, I'll stop here, and if there are any further questions, we can take it up a little later.
Thank you, Mr. Modi. That's wonderful. May I now invite our last panelist, Dr. Bulbul Sood, who represents JPIGO, which is a global health organization which really is focusing on the welfare of women and also families. And Dr. Bulbul Sood will maybe share with her what her organization does and what does she think and the organization thinks about the way forward to achieve the 25 by 25 goals. Dr. Sood, please.
Thank you very much, Dr. Shah, for the introduction. And I must thank the CII for giving this opportunity to share what we are doing and how we can all work together. My previous speakers have already shared some of the challenges that India faces, and what is happening currently and how with the Aishman Bharat program, again at the Health and Wellness Center plus PMJY, there are this, we have an opportunity that we can work together and, make sure that the projection that we are talking about does not happen and we are able to control the pandemic of NCDs. I'll just quickly take you through in Jipaigo, we are an international organization and we're affiliated to Johns Hopkins University. So we try to bring in solutions, we know what, but how to do it. Because the challenge is here, how do we address some of these issues? And I'll try and using the systems approach and working both with the public sector and the private sector. So some of the initiatives that Jipaigo has been working in close partnership with the government, and as I said, both with the public sector and private sector, is one is a breast health initiative, which we work in Maharashtra. We have another program which is streamlining the coordinated and continuous care for breast health. This is a program which we are implementing in Odisha with Novartis. Prarambh is called, is the beginning. And then we have another program we are working in having an integrated ANC care model for gestational diabetes mellitus. As you all know, GDM is actually mother of all NCDs. And you know how we do the screening and management, and which is again being implemented in Madhya Pradesh. And then we are another new program which we have started working on scaling up of implementation of the primary HPV screening by self-sampling in Sikkim. And the idea is that, we work, as I said, in close collaboration with several partners, and we demonstrate how it can be scaled up, and then there's the government which takes it forward in many states, and so I'll just quickly take you briefly about, next slide, please. So if you look at the breast health care initiative, we looked at that things were happening. It's not that things were not happening in India, but they're happening piecemeal. And how do we come out with a comprehensive primary, comprehensive program where we can actually operationalize the entire breast health care services from the primary health care to the tertiary health care. And as you know, there are certain things which one has to do at the community level. You have to create increase awareness and make sure that people know that they need to be, screened for. And I'm talking about breast health, but this applies to all the other, NCDs also. Then, of course, screening. Can you go back, please? Screening of which leads to early diagnosis and management, timely and accurate diagnosis, and then the cancer treatment. So actually, and this is a 360 kind of approach that we are using, because if you have a blockage at one level, then you will not find the optimum utilization of the services that we are talking about. Next. So in fact, in 2 states, and we worked in almost 1 district each in Uttar Pradesh and Jharkhand, we found that when we were, there were, and these were all women who were healthy women, about the age of 30 years, when about 108,000 women were, were identified, and then they were, asked by ASHAs to go for their breast health, what we call as clinical breast examination. And again, you see that every time there's a dip, so almost only 48% women went for the clinical breast examination. Of these, when we found that, women were around 2,000 were positive for CB, then when we asked them to refer again, there is a drop. So what I'm trying to say is that we have to work at, to ensure, and this is where the awareness is important. Nalini talked about creating awareness. But awareness leading to change in attitude and also in the practices is very important. And this is what we need to all come together and work. So again, by doing this, you can see that a lot of women who can be diagnosed in the early stage of cancer, and then they can be managed, appropriately. Next. So in our learning was that, if you train even the community-based workers, nicely, then, there is a improved concordance of clinical breast examination between the frontline health workers and the specialists, which was around 63%. Again, average time was reduced from 8 days to 5 days when women then went to the higher facilities, and similarly reduction in the average time for confirmed CB cases to complete a diagnostic evaluation. So earlier when we started at the baseline, we found that it used to take 22 days for women to go through all the tests. But having one stop kind of place where you could have all these things done, we could reduce it to 2 days, and then because of this we were able to downsize the clients, so they were detected early for the breast cancer, and also the size of the lump was reduced. So what I'm trying to say is that it's very important to come up with a solution where you work in a way where you look at everything and ensure that things are, it's a 360 that you have to look at. Next. This is the program that Mr. Modi was mentioning, and we have initiated this in one district in Odisha. Again, idea is to have a comprehensive program and coordinated program for continuous care for breast health. And this involves community mobilization, capacity building of the frontline health worker plus doctors and other specialists, developing protocols and guidelines which are simple to use and easy to for the different category of workers to understand, client tracking and linkages. And I think today in the time of COVID, one thing has definitely come out that India is ready for digital frog leap, and we can have. So we have been also coming up with referral cards for cancer patients and having a unique ID, and then having a follow up these clients, and of course access to diagnosis and treatment, which is decentralized, because currently if you find most of the facilities where the diagnosis and treatment are the tertiary care hospitals. So can we bring it down to the FRUs or CSCs, something that we are working on. Next. This is another program which we started way back about 6 years back in Hoshangabad, and this was for, as I said, again, diabetes is a big challenge. We heard 8 million people in India are suffering from diabetes. Now, gestational diabetes, and the guidelines says that all universal screening, all women during the antenatal period need to be screened for diabetes, gestation diabetes. But we find that, again, simple test is not being done. So we started this, as I said, in implementation district in Hoshangabad in Madhya Pradesh, and we demonstrated that it can be done by training the ANMs, the ASHAs for certain things, and also strengthening the entire ecosystem around the GDM, and which started, of course, as I said, with one district, but today is being scaled up in the entire state. And so we are trying to ensure that how we can ensure that all women get their gestation diabetes mellitus tested and then managed. Next. So this was when we started, we found that in one district there were about 30,000 women pregnant, and we were able to, again, using not too many extra staff but the government system staff, we could test almost 24,000 women, and 9% of them were found to be GDM positive. But the good news was that 99% of these women could be managed by just the medical nutrition therapy, and only 1% women required to be put on insulin. And then, of course, we were also saying that these women then needs to be tested post-delivery and the newborn also. There we were finding challenges that only 1/3 were tested, and rest we were not able to. Next. So again, because of the learnings from there, as I said, the program has been scaled up in Madhya Pradesh, but also other states, and we're working closely with the government to ensure that it is scaled up. We revised the guidelines. In fact, earlier, before, it used to be insulin for the management, and then we said metformin, which is easy to administer, can be given to the clients. And as per the Government of India, plan is that by 2023, all the districts, whether they are in the EAG states or non-EAG states, should be having this program. Next. This is my last slide where we are talking about HPV screening by self-sample in Sikkim. And I think most of you would know that HPV testing is considered the most effective screening method for real-time, and it can, it is something which we are working on, and the objective is to evaluate the feasibility of home-based self-collection of HPV tests in a population setting. So we are working in one district of Sikkim, and this is being done with ICMR and NICPR, and our objective is to find out whether we will be able to estimate the screening participation of rate by the self collection. What are some of the barriers, and how to establish the linkages, and how it is accepted by the women and for the home-based self-sampling method. So thank you very much, and it will be a pleasure to work with other CII partners. And as I said, alone nobody can do it, but together we can do a lot. Thank you very much.
Thank you, Dr. Sood, for sharing your organization's work, which is fantastic. So you and your team on achieving all of this, which is what we all need to learn from. We have about 15 minutes or so, and I thought we could just go around the panel and ask everyone to share their views. Now that we have heard about what are the possible challenges, how the different groups are trying to address it, which includes both civil society, research groups, private organizations, pharmaceutical companies, and so on and so forth, how we can bring it all together. I think as the United Nations and Sustainable Development Goals talk about taking a whole of society approach to addressing the upcoming health challenges. So how do we bring it all together? I think a few common themes that came through in all the presentations was really around health systems strengthening. That we need to strengthen our health systems if we are going to be in a position at all to meet the challenge. So if you could share your views about how we can do this by bringing it all together. And maybe I can once again start with Dr. Mohan.
Thank you, Dr. Jap. So I think we've had fantastic presentations from many different people. As you rightly alluded to, a lot of the works are being done in silos. So if organizations can work together, for example, with Arogya World, we've been working with Dr. Prabhakaran, and we'd love to work with others as well. If JH Pego would like to work with us, it would be. So if we can develop models which work and then scale it up, and then there's always scope for a public-private partnership. And when I say private, NGOs are also included. So the government, of course, has very long arms and deep pockets. But then there are situations where excellent private partners as well as NGOs can join together. In the prevention of NCDs, unfortunately, we need multi-sectoral collaboration. For example, we talk about physical activity. But if there are no parks, or if there are no sidewalks for people to walk and so on, it's going to be difficult. So we have to have a holistic approach with multiple partners, the health, the food, the agriculture, the Ministry of Transport, Sports and Youth Affairs, all have to come together. And only then the program can really reach the entire population, right from schools to colleges to workplaces to the community. And it looks like a big problem, but if you break it down, and then if each one does their job, I think a lot can be done. The solution is quite simple, but how to reach it to people and have sustainability is the problem.
Indeed, thank you. I think you have hit upon the nub of the issue. The solutions are known, but how to deliver those solutions to the people who need them is the major challenge that we face. So, Dr. Saligram, if I can now pass on to you and ask, how can the civil society and organizations like yours, which works with a number of private organizations, really play the role of an advocacy sort of accelerator and take this message to all the places where it's needed? For example, Dr. Mohan talked about the need to improve our built environment, the need to, to address other social determinants of health. So how can an organization like Arogya World help in that mission?
Right. No, thank you. Thank you. I wanted to make one point, and that is in COVID times, this has become even more important that NCD people with underlying NCDs are at risk for more negative outcomes from COVID. So, if that is true, then the need for prevention of NCDs is even more urgent than ever before. So, I do want to make a plug for prevention. You cannot treat your way out of this NCD crisis. No one can. It's too big a problem. So, the solution is prevention. And as you said, it is the holy grail of all our work. How do you know what to do, you have to make healthy choices, but how do you get everybody to make it? It's a very, very a big problem that keeps all of us up at night. I did want to address your question directly, Dr. Jha, and that is, we think very deeply about how Arogya can contribute to improve the world we live in, to improve the health of Indians. We don't want India to lose its competitive advantage. We want the workforce to be healthy in the future. We really believe we're making headway there. The one way that we're thinking about is engaging more with government. So, for instance, if we are able to do something like a sister city program between, say, Bangalore and San Francisco, where we get both cities to, become conscious about their health and work together to solve some of the problems both cities have. And we're starting that conversation now. Arogya cities, we want to call this. And we want to do it in 2022. This is when India becomes 75. So this is a very, very good way for an NGO, as you said, to be a collab, bring groups together that normally don't talk, collect consensus, get everybody on the same page. We are good at that. NGOs are good at that. You know that, Dr. Jha. We are very good at building consensus. So I would love very much to see how groups like Arogya can play a role beyond implementation in actually shaping the way India thinks. In the case of healthy workplaces, I do want to say that we have I would like all India's companies to become healthy workplaces, number one. Number two, to start tracking data. So if you have data, you can improve on it next year. So tracking health data, and we can help with that as well.
Thank you very much. You did speak about sister cities, but we have to remember that more than 2/3 of India lives in villages. So we have to really focus our attention there as well, where most of the disadvantaged communities lie. Can I now, and with your rich experience of working as a frontline researcher, global frontline researcher, how do you think we can generate the kind of evidence that is needed to persuade the policymaker? What will it take for us to persuade the policymaker to put in place sustainable policies that improve the health of the population?
So I think to persuade the policymakers, we have to think in 4 lines of research. Number 1 is the biomedical research that we all do to generate evidence. Number 2 is involve social scientists, research amongst the people if we are going to change in practice. Number 3, for policymakers, it is very important in terms of economics. So health economics, cost effectiveness, and costing research needs to be done. And last is health system readiness. Is the health system ready to adapt to the changes? So we need to work on that. And for all this, as you rightly pointed out, as Dr. Mohan pointed out, we require a multidisciplinary group of people, and it cannot be left with doctors alone, because you require to attack this from multiple dimensions. One of the things which is largely neglected in all our discussions is the social determinants aspects, and you rightly pointed out the rural component, because nearly 40% of the people do not have adequate, I don't say no access, but do not have adequate access. And one of the things that we need to do is to improve access. And a lot of work is going on in that direction. So ultimately, what really needs is translating that evidence to practice. The second thing is there are two complementary approaches that we need to follow. One is at the population level in terms of risk factors for non-communicable diseases. We need to bring the population distribution, create a leftward shift so that the mean of all the risk factors come down. But for people with the highest risk who are in the tail of the normal distribution curve, we need to provide care immediately, and that is what is required. The last point I want to make is that there are several emerging problems such as air pollution, even environment within health institutions. For the health sector produces almost 5% of the greenhouse gases, and simple measures within the health systems can make change. Simple procurement, sustainable procurement policies can make a change. And I think we need to educate the health system with regard to that. I'll stop there.
Answer. We have 5 more minutes to go. So in that time, can I come to you, Mr. Modi, and ask from you, is there for example, a pharmaceutical organization? What is it thinking as one of the most important stakeholders in healthcare delivery around the world, but also in disadvantaged societies? How does it think it will provide support healthcare provision to the disadvantaged populations in the next 10 years?
Yeah, thank you, Dr. Jha. I think that's a very important point. And at the end of the day, it's not only about the medicines that a company would provide, right? And in a country like ours, where, as you rightly mentioned, most of the people are in villages, how do we really create that partnership in terms of which brings a lot of meaning, whether it is diagnosis, whether it is early screening? Those are the things which companies are looking as we move ahead in our journey in the entire value chain. And although health is always a state subject, but our experience over the years has been that when you go with a proposal to the government, they're pretty forthcoming. Whether it is a state government, they're pretty forthcoming in proposals like screening of the entire community. They come ahead and tell us that you tell us what is the type of support that you would require the government to come forward. And then you would always have the NGOs, the patient advocates, and everyone to support in such initiatives. So I think that's one area where we are clearly looking at as we move forward, because the early we diagnose, the lesser is the burden on the government and the healthcare providers as well. So that's an outlook maybe from an industry perspective as to how we can create those interventions at a very early stage. And at the same time, if we've created those interventions, create sustainable interventions which can be scaled up over a period of time. So you don't want to do it in a small area, but how you can replicate and you can make it more and more scalable when we talk of other states as we move ahead in our journey.
Thank you, Mr. Modi. That's great. Last but not the least, Dr. Sood, your organization works in the space of providing special support to women and to families. So if I can just request you to, in the last minute or so, talk a little bit about the issue of equity. How do we ensure equity in healthcare delivery so far as NCD management is concerned? Dr. Sood, you're muted.
Yeah, sorry. So what I would say today, we are in a situation where, because of the health and wellness centers, we have an up to the smile. Now, Japago is working actually in 14 states on strengthening the health and wellness component. And what we find that this is the time where we can look at how we can partner with a larger group of players, especially we have in the industry, the CSR funding is there. Now, to my mind, it's important to develop a comprehensive district level planning for NCD. And I would put it in two buckets. One is in the area of prevention, and the second is in the area of early diagnosis management. Now, in area of the promotion, the wellness component within the health and wellness can play an important role. And already NCDs is one of the buckets of activities which have to be implemented to the health and wellness center. The other area which can play a very important role again is through the school health program, and Government of India has also launched this school health program under Ayushman Bharat, where each school will have two ambassadors, who are going to be the ones who would be talking about health. And again, in this case, it is nutrition is very important. So what I see that this is an opportunity how we can link with existing platform which are there in the system and look at coming out with a plan which is a comprehensive plan with intersectoral coordination, with a way by which we can then measure it also. Because today, we are going to digital India. A national digital health mission has been launched. So if you have, a situation where you can track, healthy people, how many then, develop early diagnosis, manage it, and link up with a system. I feel that we have an opportunity to take
Thank
care
you.
of it.
Thank you. Thank you, Dr. Sood. I'm sorry to cut you off, but we have run right out of time.
Yeah, no problem.
But I'm sure everyone will agree that we had a wonderful discussion. And all that remains for me to do is to thank all our panelists, Dr. Mohan, Dr. Saligram, Professor Prabhakaran, Mr. Modi, and Dr. Sood for their wonderful experience which they have shared. And in the end, to CII for providing this platform for this discussion. Thank you very much. Let's hope that we are well on our way to achieving the 25 by 25 target. Thank you very much.
Thank you, everyone. Thanks.
Thank you.
Thank you. Thank you so much, Dr. Jha. Thank you to the panelists.
oversight of distributing PPE kits and proper hygiene. 5 years, state wish has reached million beneficiaries. The significant leap towards our wish for India at 80. Results by the year 2027. As ambitious, we believe that standard can be achieved with dignity. As we thank all our partners. Our dream can indeed become reality. Nationally, free and hospitalization and treatment. It can be chosen for 3.5 months, 6.5 months, or 9.5 months. It's no treatment is required. Entry age 18 years to 65 years, 5% discount policy national is available. Easy exclude. For detailed information, please visit our website, nearest NIC office. National Insurance, effective since 1996. Five came together in 1895 to form the Engineering and Trades Association. Big landmarks. Built India. The first in 1940, company formed the Fusion of India. Seamlessly to become the Fusion of Indian engineering industry to settle. In 1975, when India looked for external, Restructured Association organized the first ever engineering trade fair. CII opened its office in Soviet Union, connecting India. When the first overseas company entered the auto sector in 1982, AI system for a new industry. In 1986, in 1992, CII emerged as the Confederate worked in partnership with the created its centenary year in 1995. It grew stronger. Missions for excellence, forging deeper bonds with society. Since then, CII has pioneered new movements such as quality, green building, skill development, social responsibility. CII has inspired industry to achieve excellence and reach for ever inwards. Its engagement in fostering a conducive climate, doing business across multiple sectors, 4 pillars: CII, analytical perspective across all sectors, with the union and state governments through its offices across the industry. In competitiveness, CII enhances competitiveness of enterprises through training, consulting, advice. We and the government, CII, through its network of engages across efficiency and leadership. CII and digital capability. Under international CII works with counterpart organizations in over 130 countries to take industry to new business missions, open up to opportunities for efforts, and it engages with leaders and governments, building a strong CII in skill development, job fairs, career development, disaster relief and rehab, to conservation, air pollution, partnership, and initiatives from daring entrepreneurs. For 100 years, as Indian industry it is estimated in local with access to proper healthcare. This underscores the need for a robust and affordable for every day. Since has been on a mission demonstrating and replicable models systems in plus is across North and having a population healthcare services, work of clinics, and by enhancing them services. During the ongoing pandemic, as integral role, 90% states, having 5.57 million people so far, 0.59 million people with influenza-like illness were diagnosed, taken as per the guidance of the government of India. In addition, we are government sector training, capacity building, new rooms to support since in the past 5 years, to state 21 million beneficiaries, significantly are going to reach 2027. for joining us. By 2020, against expenses of hospitalization or home care due to COVID-19. Also includes expenses against pre and post hospitalization and includes IU treatment. It is a short period can be chosen for 3.5 months. Some insurance of rupees 50,000 rupees. No policy health checkup required. Entry age is to 65. For health workers is available on his portal. For details, please visit our website on nearest LIC office. Or else, trusted since 1906. Five companies came together. Forming joining the nascent industry such as tissue trust 1912 was renamed in 1940. Smaller companies formed the Engineering Association of India. The association further emerged stronger after in 1974. In the two engineering associations seamlessly to become to set a new paradigm for growth through the resurgence. CII its first overseas in Soviet and there in 1982. Mercury initiated its first office in 1986. All the AI transfer of engineering for addressing the manufacturing sector. In 1992, CII emerged. For excellence and it is estimated that about 8 in low and middle for a country like India. Has been on its healthcare system in partnership with international entities, which today manages 650 plus nation of approximately 140 million. Moreover, we continually increase healthcare services with clinics and policy of with the help of unique apps, Tele ECG, and that reduce the impact on This approach especially in the COVID-19 5 states from 0.5 with influence on IQ. Communities says WISH has reached 21.2 million beneficiaries. India at 80. Our goal by the end 27. Can be achieved by leveraging innovation. We thank all our partners for joining us in our journey. Our dream guaranteed if we work
Good evening, Mr. Tambe.
Good evening. How are you?
Very well, sir. How are you?
Good, good. I'm glad you can hear me well.
Absolutely. Thanks. Good evening, Mr. Sani. Mr. Sani, am I audible?
Hello, how are you?
Hello, I'm Milin.
Hi. So where are you right now?
I'm in Gurgaon.
Okay.
What about you?
I'm in Boston now. I was
Oh,
supposed to be in Bangalore, but kind of stuck.
So
Yeah,
do we
especially.
the panelists? I can see Neerja and the CII team is on board, but I don't see any of the other panelists yet.
Morning, Milind.
Good morning. Good morning. How are you?
Wonderful. How are you?
Good.
Hello.
Maybe a year ago.
That's right. That's right.
Wonderful. And I think Anandan was saying that you and he were in touch recently.
Yes, yes. We have been in touch. We've been working together. We've written papers together and we'll write more together. So yeah, it's been good.
Hello.
Yeah, hi,
Yeah.
Pankaj.
Milind, your voice just disappeared for about 30, 40 seconds.
Oh no.
Can you
And-
hear me, Mr. Wadhwani?
Yes, perfectly.
Great. Personally, I'm not a big fan of the Cisco platform, but see.
But you know, they all have issues. Microsoft Teams, Zoom, WebEx, all of them.
Yeah. Yeah.
I haven't been able to hear too many of the sessions, but how is the conference going so far?
Absolutely no idea. I haven't been able to log into a single session, so it's just been a bit of madness on our end.
Hi, Pankaj. Hello,
Hi, Akanshita.
Wadhwani. Hi, Dr. Tambe.
Hello.
I'm well. This is Akanshita from CII. We're just trying to connect up. There we have Dr. Jeremy. Hi. Good evening, Dr. Jeremy.
Hi, good
So we're
evening.
just trying to connect up with Professor Ramanan, and I think Pankaj, we are good to start at 5:30 as scheduled.
Okay, is Dr. Professor Ramanan joining?
Yeah, we're just touching base with him. Just give us a minute.
Okay. Hi, Jeremy. How are you?
Hello, Pankaj. It has been a while, and I hope you have been keeping well.
Yes, well as can be expected in these times. I have been through and survived COVID for now, so far so I'm
far, so good. Take care, my friend.
so far so good. I'm celebrating my antibodies, so that's the situation.
Wow. Well, congratulations. Great relief.
Hi, Professor Ramanan. Can you hear us?
Hi, Pankaj. Hi, Pankaj. How are you?
I'm very good. How are you?
Good, good.
So which part of the world are you in?
I'm actually in Delhi as it happens.
Okay, good. So we have, I think, Boston, Singapore, Delhi, and Mr. Wadhwani, you are calling in from Pittsburgh, is it?
Oh, that's right.
Right. So, Pankaj, we have the quorum.
Okay.
Before I hand it over to you, I would like to make an announcement for all our visitors and audience. Please feel free to tap into the top right-hand side of your chat box and feed in questions so that our panelists can take them at the end of the sessions.
So Akanksha, will you be moderating
I'll
the
be
Q&A or?
No, so Pankaj, you may take over the discussions now, and whatever questions come in, I will share that with you on the panel chat.
Okay. I'm not sure I can see the panel chat, so I don't know where that is.
Or I'll message them to you.
Yeah. Okay. Great. Yeah. So when are we good to start, Akanksha?
We may begin now, Pankaj.
Okay. Okay, thank you everybody, and welcome to this session on India Health Week on artificial intelligence for social good. We have a eminent panel coming to you from across the world, actually, all the way from Singapore through Delhi to Pittsburgh and Boston in the United States. So I think we're covering pretty much every time zone that is there in the world. So thank you everybody for making the time at whatever time of day or night it is in your part of the world. I'll very quickly introduce the panel. We have Mr. Sunil Wadhwani. He's an entrepreneur, investor, philanthropist, former chairman and CEO of iGate Corporation, and currently a very active angel investor. Mr. Wadhwani has established the Wish Foundation, which is a non-profit in 2014 in India. And the goal of this foundation is to look at transforming primary health systems in low-income areas. Importantly for this discussion, he also launched the Wadhwani Institute for Artificial Intelligence with the goal of accelerating social development in India's vulnerable communities. Mr. Wadhwani, thank you for joining us.
My pleasure. Thank you.
Also from the United States, joining us from Boston is Mr. Milind Tambe. He is a professor of computer science and a director of research in computation and society at the Harvard School of Public Health. And he is also the director of AI for Social Good at Google Research India. Professor Tambe, thank you for being with us, and good morning to both of you gentlemen from the United States. Joining us from Singapore a little later in the evening for him is Dr. Jeremy. Dr. Jeremy is joining us from Singapore, but an old friend and very well experienced with India, has spent a lot of time here working, doing consulting work, etc. He is the director for global health in the school and leads work on initiatives in health systems, strengthening universal health coverage, and has worked with the Ministry of Health in Singapore, as well as the World Bank and the World Health Organization. He is also currently the CEO of AMILI, which is the first dedicated gut microbiome full service company in Southeast Asia. Would love to understand a little bit more about that. And lastly, but definitely not least, Professor Ramanan Lakshminarayanan is the founder and director for the Center for Disease and Dynamic Economic and Policy, and a senior research scholar at Princeton University in the United States. And Professor Ramanan has been fairly active and involved with a lot of the work, analytics and information and insights going on with the current COVID pandemic in India. So Professor Ramanan, thank you as well for joining us. I'd like to start actually first going to Professor Tambe and asking you, since you are leading the AI for Social Good at Google Research, what really is AI for social good? What does it mean?
Generally means that we are trying to apply AI towards problems in communities that have not benefited from AI. Typically, these are problems in low resource communities, in marginalized communities, vulnerable populations. This could also be endangered wildlife. These are generally problems that don't fall in the defense sector or not necessarily for profit sector. So they have to be in these non-profit sectors, which have traditionally not received attention from the AI community or investments. Concrete examples would be work in areas like public health, conservation, education, public safety. I can give you concrete examples of past work that we have done just as examples. In the United States, for example, we've worked with the homeless youth in Los Angeles, a challenge being how to spread information about HIV prevention amongst these youth, given that the rates of HIV are 10 times the rates of normal house populations. And we can show that our AI algorithms are far more effective in finding key influencers to spread HIV information. And in concrete tests in these communities, with a recent study completed with 700 youth, we have shown that HIV risk behaviors have significantly reduced. Or in wildlife conservation, how to predict where poachers will attack animals by setting snares. And in work we've done in Africa and Cambodia, for example, we've shown that AI algorithms can be far more effective in predicting where poachers set traps or snares and remove them by hundreds or thousands. So these are concrete examples of AI being applied for societal benefit. And so there isn't necessarily a hard boundary that this is where AI for social good and where there is not, but hopefully that gives you a sense of what we mean by AI for social good.
Thank you. Mr. Wadhwani, you have spent a lot of time working in the nonprofit space in India, trying to focus in on helping the underprivileged communities, the vulnerable communities. You know, Professor Tambe gave us a couple of examples. Do you see this really playing out in India? Do we really see artificial intelligence actually helping those most vulnerable, or is this something just for, you know, CII discussions and presentations?
Pankaj, that's a wonderful question, and I think it's very appropriate. But India, as we know, a very large country, we have a number of challenges, right, in the healthcare system, especially when you talk about providing healthcare to low-income communities, whether it's in urban settings or rural settings. So whether it's a shortage of, healthcare personnel in these low-income areas, whether it's lack of proper training, whether it's managing supply chains of medicines and equipment and so on, whether it's doing population health things like, disease prediction, disease surveillance, and so on. These are all areas where we've been challenged, as I said, by lack of personnel and so on. Artificial intelligence and data sciences provides really a game-changing way to address many of these issues. So for example, AI, artificial intelligence, can be used to speed up diagnoses of a whole range of medical conditions, from cancer to blindness to other issues. So we can use AI in diagnostics. It can be used in treatment and therapeutics by physicians, et cetera, by helping them to narrow down exactly what treatments would help a specific patient. It can be used in training and in a whole variety of other areas. If you take an example, the institute that my brother and I launched 2.5 years back, the Wadhwani Institute for Artificial Intelligence, we have teams over there, for example, applying AI in the area of tuberculosis. How do we detect TB much earlier than is currently being done so we can take action? We are applying AI to better treatment of tuberculosis so that we can take care of cases much earlier than they are. We have teams applying AI in the areas of maternal and child health. So for example, high-risk pregnancies, how do you detect them earlier? How do you make it safer for those mothers to deliver their babies? We're applying AI in the area of low birth weight babies, which is a huge, huge problem in India. We're applying AI in the area of agriculture. How do we improve farmers' crop yields so that their incomes can increase dramatically? So that we reduce farmer suicides and so on. So there are a range of areas where AI can be truly game-changing. And here's the good news. The good news is that the government of India recognizes the game-changing potential of data sciences and artificial intelligence. Both the health ministry as well as the National Health Authority, which administers the Ayushman Bharat program, both of them are looking strongly at how AI can be used to help them be more effective. And our AI Institute, the Vadhwani AI Institute, is working closely with both of them. In fact, I have to tell you, Pankaj, when we launched Vadhwani AI 2.5 years ago, we were honored that Prime Minister Modi himself came to inaugurate the institute, and he delivered the keynote address. And he gave one of the best speeches on artificial intelligence that I've heard anywhere in the world. And the summary of what he said was the following: that although India may be behind other countries like US and China in the commercial applications of AI, we have a good chance, and India should strive to become the global leader in applying AI for social good. How to develop AI-based solutions in areas like healthcare, education, financial inclusion, agriculture, and so on. And he's absolutely right. By moving quickly but thoughtfully, making sure we have protections for privacy, confidentiality, and so on, AI and data sciences really can be a game changer for Indian healthcare over the next 10 years.
So, Mr. Wadhwani, thank you for that, and I agree that there is a lot of potential for AI to come in and be a catalyst for social good. But let me come to Professor Ramanan. We have seen, especially with the pandemic that we have right now with COVID, but even earlier, we spent a lot of time looking at public health, a lot of challenges. I know you've spent a lot of time working in public health space in India. Is this really something that we see on the ground? Are we able to scale it? I mean, there are significant challenges with access to data. I understand what Mr. Wadhwani is saying about TB diagnosis, but it seems to me a lot of this stuff is really dependent on getting access to good, correct information. And then not only that, but once the AI algorithm actually throws out, say a solution, actually being able to go and implement that solution on the ground. So when it comes to healthcare, you fundamentally still need somebody to be able to deliver the care. A computer is not actually going to do that. A computer is going to help with decision making, maybe. How do you see this playing out? Is this really hitting the ground? Is this really happening? Do we see real change?
So that's a great question, Pankaj. There's, as you know, the difference between narrow AI and very broad AI. Narrow AI is where a computer is capable of performing a very specific pattern recognition task, whether it be to be able to read an ECG and do it as well as a decent cardiologist would, to be able to look at a chest X-ray and be able to read whether the person has TB or not. So that sort of training of narrow AI is exploding, and in TB particularly, it's grown to be quite high, and it's certainly true for other areas as well. Now, that doesn't necessarily translate into broad AI. Broad AI is really what we need, where there's a person who shows up. We don't know what diagnostics test they may need. They are a patient with a set of symptoms, and that set of symptoms then needs to be translated into a set of diagnostic tests and then into some recommendation for triage. What do? Do they show up at a hospital? Are they fine where they are and wait for care? That's the part we have not managed to really achieve yet, because the fundamental problem there is the lack of data at scale to be able to inform the broad AI type processes. We can do the narrow AI with gold standards. We can have cardiologists read ECGs and do that bit. But broad AI takes a lot more data to train algorithms. And as we all know, most of AI is really the data. The algorithms are really just that's the easier part. Gathering the kinds of data that we need has been hampered by the fact that we don't have an electronic health record system of particular scale. We don't really take advantage of the fact that India could be a place which is able to populate and inform AI at the scale that, say, China is doing, for instance. Now, China, in ways that might not be palatable to us, gathers data at such a mass scale that it pinpoints everything going on with every single individual. In the way that they controlled COVID, they did it using tools which are very hard for us to replicate because it would be seen as an infringement on individual privacy. And we have those concerns, of course, in India as well. The question is how to take advantage of this can take advantage of the population without falling into the trap of stepping on people's privacy. And that's really a challenge that we have not quite figured out how to bridge. And in the absence of the large scale data to do this, our number one problem is really that we simply don't have the numbers of doctors, of trained medical providers, for instance, in this country. The ratios, as you know, are one doctor for every 10,000 patients once you get out of the cities. And you can use AI to solve these problems if we're able to get data at a scale, but we don't have that yet. The second stage is, of course, what you mentioned, which is once you have the triaging, do we have the provision of care at a scale that can then follow up? And here I have to say that one of the positives of COVID, if there's, I think, a move towards telemedicine being an acceptable form of consulting a doctor, which was not the case in the pre-COVID. Comfortable with this, and a lot of people are comfortable with seeing a doctor on a screen and working that way. Now, obviously, the penetration of that still remains to be seen, and there will be some sliding back in a post-COVID era when people will go back and want to see a doctor again. But I think if we can iron out some of the issues with telemedicine, one among them being the fact that people don't want to see a random person on that screen. They want to see the person that they trust, that they have confidence with in the screen. They would rather trust that person who they know rather than maybe just to use a word, maybe a Harvard trained doctor who's sitting on the other side. No offense to Professor Tambe. That qualification is not necessarily what matters to them. They really care about the person that they can trust, because a lot of healing is really in that trust. And so we need to marry both the ability to collect data, which we've not quite done yet, which the Prime Minister did announce in the Digital Health Mission, which I think is a great step forward, but also with the ability to provide a telemedicine experience, which then sets the pathway for what you just said, which is how do you then deliver the care that is needed for those who really need.
So, Dr. Jeremy, let me come to you now, and I think I know from our past discussions that you spent some time doing consulting work in India. I know as a former consultant myself, we've kind of tried to tee it up perfectly for you to give the big answer on how we kind of address these issues. We've got a whole bunch of challenges. We've got the potential of AI. Professor Ramanan talked about the fact that the National Digital Health Mission, the explosion of telemedicine because of the COVID pandemic. It kind of feels like we're at a tipping point in terms of the potential and maybe the readiness of society given the COVID pandemic. How do we now kind of stitch all these elements together and actually make this work for India, work in healthcare, and then work at scale so that we can actually say, yes, we really are doing some social good with artificial intelligence and with all this technology?
And I think, Pankaj, that is a great question. We're amongst practitioners, so let's talk about practice. And I think that Professor Ramanan has very nicely laid out the narrow versus the broad AI. And I think that there are two key considerations we need to think about. The first is really around individual physician, or more broadly, healthcare worker productivity. And he's absolutely right. No one wants to see a nameless, faceless person, even if he comes from Harvard Medical School. You want to have that therapeutic relationship. And incidentally, most of us doctors are really showmen, and it's been proven time and time again that the placebo effect is at least 25 to 30%. So that therapeutic relationship is important. So the question then is, how do you make the doctor much more productive? And here, I agree fully that China is leading the way here. And the Ping An Good Doctor program that has been in China for a number of years and has recently expanded into Indonesia, which is another populous country with 260 million people. And I would say that Ping An has used AI in the right way. There is a triage layer which essentially primes the patient, gets the right information, and hence makes the physician consultation so much more productive. And if we look at the data, the Ping An doctor sees on average 2 to 3 times more patients in one session than many of his peers because of this AI triage layer. The other area where we should be thinking about is really around load balancing. And let me take an example from very narrow AI, which is in digital, really retinal photos. And the recommendation, whether in the US or in India, is that all diabetics should have their retinal image captured annually to look for any damage due to poorly controlled diabetes. And around the world, we know that 80% of these images are normal. So if the machine can read, and you don't even need to determine what is abnormal. If the machine can simply sift out what is normal from abnormal, and the physician or the medical reader only looks at the abnormal ones, that's a productivity jump of 4 to 5x. And we can then shift the load from those images that were very comfortable for the machine to see, and allow the healthcare professional, the human being, to then on the cases that are most needed. And I think this is the right way to think about using AI for social good. But we have to move slowly. There are very real concerns around bias in the data sets, privacy, and these are perhaps some of the issues that we can talk about as we move along this panel. Back to you, Pankaj.
Thank you, Dr. Jeremy. And that tees up actually the question that I was going to ask. Both of you mentioned China. Both of you mentioned, both you and Professor Ramanan mentioned around how they have possibly been successful in terms of getting the pandemic under control using the data, but done it a little bit more from the authoritarian mindset, people maybe not having so much choice about whether they would be comfortable with what the government was doing. Professor Tambe, you lead the Google research program in India for social good. I would guess that the one company that has more data on us as individuals than anybody else is Google. Google has somehow managed to stay to some extent under the radar vis-a-vis some of the controversy with the ethics around having so much data, at least not being as badly bashed in the media as some of the other big technology players. But when you look at Google, I mean, you have access to all of this information. You don't really see Google jumping in and saying, look, I have this information. I can actually tell you from their smartphone, from Google Maps, who's moved where, how the pandemic will spread, how we think about TB. How do you see the ethics playing out? Is this a conversation happening at places like Google Research? What are the challenges? What should we be saying? Look, for the greater good, individual concerns may be overruled. How do you balance this out within your organization, and how do you think we should balance this out as a society?
These are, again, really excellent points. I should point out that whether here at Harvard or in our work at Google, our focus has been on working with governmental or non-governmental organizations who are working on the ground. So our focus has been to to immerse ourselves to understand the problems that are being faced by these NGOs, and then provide solutions that amplify the impact. You mentioned previously that the computer is not really going to deliver care. It's actually the person on the ground, the ASHA worker. Those are the ones who are actually delivering care. And so the question for us then becomes, how do we improve the effectiveness of these interventions with limited resources? So at Google Research India, where I lead the AI for social good, the way we work is we've worked with NGOs in the after joining Google. One of the first things we did was launch a workshop whereby we brought in non-governmental organizations and teamed them up with academics and ourselves in order to launch several projects, particularly in the areas of public health and conservation. The idea being that we are there to assist the NGOs in doing their work more effectively. And our goal ultimately would be to let the NGOs be able to handle these AI tools by themselves and not necessarily require our intervention in every single. And so that's the way we imagine healthcare, AI for social good being scaled up. I'll give a concrete example of work that we've been doing with an NGO called Arman, which is focused on maternal and child care. And so their goal is to deliver care via phone calls that are given expecting mothers and after the child is born. They launch about 150 phone calls for each mother and after the baby is born. issue that they face is that some of the mothers will stop listening to the phone calls. They're low listeners. And they've shown in randomized control trials that listening to these calls and about information allows the mother and the child to be more healthy. So could we predict in advance before people turn into non-listeners or drop off from the program as to who's going to drop off by looking at the pattern of their phone call listening? And that's what we've done, being able to predict who's going to turn into a lone listener and then deliver the software to them so that they can use that in order to predict who's a low listener ahead of time and then deliver, bring them in to make sure they don't drop off from the program before they drop off. So these are the kinds of things that we are doing. And this allows us to essentially work with the NGOs. I wanted to make one key point here with respect to data. In all of the work, in a lot of the work that we've done with AI for social good, we have to live with the fact that data is limited, data is scarce. And in fact, when people talk about, large data, and when we were continuing our work, whether it's with the homeless youth or with, protecting wildlife and so on and so forth, we have to struggle with the fact that data is limited. And so the research in AI for social good is often a struggle for how to do AI with limited data. And that's where a lot of the innovation needs to happen. And that's sort of opposite of what often gets done in other parts, other areas of AI. So, in AI for social good, when we talk about large amounts of data, that's not necessarily what we are struggling with, is essentially my answer. Back to you.
Okay. Mr. Wadhwani, Mr. Tambe has left open the invitation of saying Google partners with NGOs. Let me ask you this, in the context of the NGOs that you're running, whether in AI or more broadly looking at health, what's the kind of help that you would actually say, look, if Google or an organization like that with immense potentials, resources in terms of financial, technical capabilities, just talent at that organization, and of course scale, what would be the kind of intervention support that you would actually look for to say, look, if we were able to get these one or two things into play, that would really take the efforts that we're doing and either magnify them or bring huge amounts of success and impact. What would be those things that you would be looking for?
Well, the good news, Pankaj, is that we are already partners with Google, with the Gates Foundation, with several agencies in the Indian government. And when I say we, that's the Wadhwani Institute for Artificial Intelligence. So we work very closely with Google Research and, as I said, with these other entities. But what really gives scale, I think, if to your point, Pankaj, that you mentioned earlier about how does all this get implemented? How does all this actually translate into better care at the front lines? It's really working with government that makes all the difference. So I'll give you one example of that. My healthcare foundation, Wish Foundation, 6 years old, we run over 650 primary care clinics in some of the lowest income communities in India, in states like Rajasthan, Madhya Pradesh, UP, Assam, and so on. Since we got started 6 years back, we've provided over 10 million patients in India with free healthcare. And we do all of this in very close partnership with government, both the state governments as well as the central government. In these 650 clinics that we're running, and that number is going up dramatically each year, we bring in a whole range of application of digital health to all aspects of the care continuum. So whether it's from patient intake and setting up of an electronic medical record, moving into diagnostics where we use smart diagnostic devices to collect data on the patient, then we use teleconsultation with AI assistants for health workers and physicians to provide healthcare to the patients. Then we have e-prescriptions, how to get medicines to patients, supply chain management systems. And now with all of the data that's being collected, we're applying data analytics and AI to the issue of how to provide better individual patient care, but also how to do better population healthcare management, right? How to do better disease surveillance, better disease prediction. Now we're doing this in our 650 clinics. Now here's what's interesting. 3 years ago, the government of India announced a new national health policy in 2017. And there are two basic strategic pillars to this new national health policy. One is the actual provision of care, of primary care, which is going to be through over 1.5 lakh primary care centers, which are now called health and wellness centers, with a broad range of services. So just imagine 150,000 of these health and wellness centers around India, and we already have 30 or 48% of them operating. Just think of all of the data that is starting to be collected from these centers. This is data at scale. It's going to be relatively clean data because this is a new system that's being set up. Think of the power of that data in terms of A, how we can provide healthcare at the front lines, but then secondly, how we can do large scale disease surveillance, disease prediction, et cetera. I mean, this could be transformative. So that's one side of it. The other side, the other strategic pillar of what the government did was to set up the world's largest government-funded health insurance program, Ayushman Bharat, which covers 100 million families, about 500 million people. Again, there's a huge amount of data flowing through that system. This is managed, of course, by the National Health Authority, and we are working closely, both of my foundations are working closely with the National Health Authority and with the Health Ministry as to how do we extract the maximum benefit from this data to provide better public care. So again, the good news is that the government of India, through both the Health Ministry as well as the National Health Authority, recognizes the power of data analytics and AI to transform healthcare. They're moving quickly. As Lakshman said, we've developed in India the National Digital Health Blueprint to provide a framework on how to use data and AI as we move forward. And the National Digital Health Mission under the National Health Authority will be rolling all of this out. And the good news is, as Milind was saying, organizations like Google, organizations like Gates Foundation, and multiple other foundations are playing a key role in helping this happen quickly. So I'm very hopeful that in the next 10 years, by the year 2030, that AI and data science will play a key role, a very key role in moving us forward and providing better healthcare to every Indian citizen.
Thank you. I'm going to try to weave in a few questions here as we continue to chat. Professor Ramanan, come in for you. You have been critical in the past on some of the data and the results that have been shown with respect to some of the COVID statistics, whether it is testing and or whether it is the actual number of cases, etc. If we can't trust the data that is being projected out by the various authorities, and let me just add to that, if this data is really going to be critical for AI and these algorithms to actually make decisions, if we have wrong data, incomplete data, or fake data going into these systems, and you are asking AI to make what you could argue, adding my own words here, you could argue are life or death decisions. How comfortable are we to be with this model where we have questionable life or death decisions being made? Should we be excited about this or very scared of this?
That's an interesting question. I would distinguish between surveillance data, where there is an actual incentive for governments, whether state or other governments, to understate the number of COVID cases or the number of COVID deaths. There's an actual incentive for them to do that, and we're seeing that played out in a number of ways. And of course, the fact that it's incomplete because the testing is not really adequate to be able to identify all the COVID cases that there are. But that's very different, I think, from the kind of data that we can get from repeated interactions with patients. And I think this is where India has an opportunity here. If you take, just for example, what IBM Watson tried to do with its sort of platform to provide diagnosis, it failed because it was good at doing narrow stuff which they could get from existing electronic health records. But if you put it out in a village in UP and said, tell me what's wrong with this person in front of me, it's just never seen people in that particular place before. Now, for that sort of thing, I think the repeated interactions that could come from PMJ, the Ayushman Bharat that Sunil was just speaking about, or that sort of primary care information, which others are also trying to do, by the way. There's Babel that's trying to do some of this in the UK. But I think we have a huge opportunity here, because if you take a close look, the the piece that costs people the most money for accessing healthcare is primary care. And if we can make primary care AI enabled, not AI delivered, but AI enabled for nurse practitioners to deliver that care, I think that's data that we can actually trust because there's really no incentive to underplay numbers there.
So I'm going to try to link your reactions, Professor Ramanan, with another question that's come in around making AI enabled versus AI delivered. Dr. Jeremy, as a practitioner, you mentioned making doctors more productive, and we talk about AI. There's this fear amongst the some of the members of the clinical community or the people who are actually delivering care that they will become redundant, that the computer will, so to speak, come and take their job. Maybe it's an exaggerated fear, but the fact is that if we don't get this community on board, we can do all the artificial intelligence that we want. Eventually, the care gets delivered by a human being. How do we bring these people into the ecosystem? How do we address these fears and challenges that they may have?
Oh, Pankaj, that's such a difficult question. Let me borrow something that I learned from the Harvard T.H. Chan School of Public Health, where a former dean, I won't mention which one, came to Singapore and then shared the health policies are changed one tombstone at a time. I certainly hope we don't need to wait so long, but I would say that the change is going to be difficult. This is a rice bowl or an existential issue. Clearly, AI is really far from ready. There are enough doctors who are concerned about this really slippery slope. But I think the optimism comes, frankly, not in the doctors who are of my vintage, but the younger ones who are really born digital. They have grown up as digital natives. They're very comfortable. They understand that it's not man or machine, it's man and machine. And the doctors, I would say, in the next 5 to 10 years, who really really achieve those quantum leaps in productivity and clinical as well as commercial success will be the ones who use machines and AI very, very well. Let's just take a really radiologist, right? And the radiologist using a relatively simple AI system that can identify which are the abnormal areas. Immediately, it doesn't have to plow through thousands of images. The AI system allows to identify where the abnormal ones that the human skill and the experience will then need to come into play. And you see the same thing playing on in radiology, in really endoscopy, and more specialties will start to embrace AI first in smaller ways and then in much larger ways. But I think that COVID has really accelerated all of this. And I think that Mr. Watwani's optimism around 10 years, I think it can be faster.
Okay, thank you. A question which has come in, which I think everybody may have a perspective on. So I'm going to lay out the question and then leave it to you to jump on it. The question is around the disconnect that we often see between the scientific or the technical communities and what is being referenced as the social sector, which is the person describes as charities, civil society, public services, etc. And we often find that a lot of the conversations around things like this are happening in the scientific and the technical community, but that the other community, the social sector, is actually being left out of the conversation. Do you feel that that is true? One question. And if so, what can be done to bridge those gaps?
Let me jump in with, I know we have limited time. I'll just give a short answer. It is certainly true that in the AI communities or scientific community, there's a temptation for technologists to dream of a solution to healthcare challenges by themselves without necessarily involving domain experts. The answer from my perspective is really to take a problem-centered or use-centered approach to technology and scientific research. So we start from the problem rather than having a solution in hand. Because often as AI researchers, we have a solution, and then we are trying to go look for a problem, and then can we replace all the nurses with robots, for example? I mean, these are the kinds of mindless solutions that can be proposed because we aren't starting from the actual problems at hand and trying to deliver those solutions to the actual workers that are working on problems. So my approach has always been, and this is the approach I would advocate very much, is to really, for AI for social good in particular, that we start with the problem in hand, go to the actual NGO who's working on the ground, so-called boots on the ground, and try to understand from them what is the actual problem that they're trying to solve. In what way can AI assist in improving the solution or delivery, rather than necessarily just coming up with a solution and then chasing a problem. But I mean, there's a lot more to say, but in the interest of time, let me hand this back to you, Pankaj.
To reinforce what Professor Tambe just said, through my two foundations, we are actual social sector practitioners. As I said, we treat millions of patients a year with free healthcare through the several hundred primary care clinics that we run. We introduce technology. And what we do, Pankaj, as we develop AI-based solutions at our AI Institute, exactly as Milind just mentioned, we have not just AI experts and researchers, but we have domain experts from public health who in fact understand areas like tuberculosis or maternal and child health, etc., where we work. Because you have to build that in right from the beginning. And not only do we bring in these experts, but we try and think through right from the beginning, how would this solution be scaled up? So even before we select problems to actually work on, we have intense discussions with ministries, with the health ministry, for example, at the center, as well as at the state government level. What are the biggest challenges that you're dealing with on the front lines, yet where we can have some data can come in so AI can be applied. So we build that into our thinking right from the beginning. And that's the only way it can be successful. To your point about the potential technology gap, Pankaj, between researchers and what they're doing and the social sector on the other hand, there is a gap, to be candid. But I think, again, as government drives these initiatives, for example, in the area of public health, social sector organizations will really have no choice but to align with these programs, meaning to get technologically, educated themselves, to understand how AI and data sciences can be applied at the frontline level through the work that they're doing, because I think the government is making that more and more critical. And through initiatives like the National Digital Health Mission, the National Digital Health Blueprint, anyone that wants to have impact at scale in the healthcare sector, and by the way, this will be happening in other sectors also, like education and agriculture and so on, but anyone that wants to have large-scale impact in healthcare will see themselves. They need to get educated on the potential of AI and data, and so that they can work closely with government in making this happen.
Yeah. Really, Pankaj, I am optimistic about the future. In addition to that structured, very disciplined problem-solving approach that Milind spoke about, and as Sunil emphasized the need for multidisciplinary teams, the degree of cross-training that is happening now is really nothing short of phenomenal. Here in Singapore, every primary school child has to learn coding. So they are really going to grow up right from young age, understanding the power of AI and how it can be applied as a force as really a force for good. And I think that around the world, many medical schools are starting to introduce short courses at the current time in bioinformatics. But with this cross-disciplinary knowledge, I think that the multidisciplinary teaming can be so much more effective.
Professor Ramanan, we are almost out of time, so I'm going to leave the last word to you. Just again, picking off from some of the comments that were mentioned, as well as another question that has come in. This concept that this perception that a lot of the coding, a lot of the intelligence, a lot of this is actually developed in the so-called Western world. We don't really have a lot of this being locally created in India, for India, by Indians. Is this the solution? Like Dr. Jeremy said, we have every kid in school learning coding. I mean, can we wait this long? How do we make sure that the kind of implementations and the solutions that are coming out are really things which are relevant for India, that we need today, not 10 or 20 years from now? Is this something we can really expect to see hitting the ground, making substantial impact in the lives of Indians in the health space within the next year or two, or are we talking about a 5 to 10 to 20-year journey?
So, Pankaj, I think that it can be either, and it really depends on what really happens. If you look at the pharma sector, if you look at the IT sector, these were spaces that were not highly regulated before businesses or private enterprise was able to come in and create an entire space there, which has built value for India. And I think such an opportunity exists at this point as well for AI and health and actually organizing of primary health. World over, there's not a business sustainable model for primary care. There just is not. It's possible to operate a tertiary care facility and profit from it, but not at the primary care. That's the reason why people don't do it. But AI can enable primary care to be a profitable enterprise. But in order to do that, there needs to be the space and the vision to allow that to happen from startups. I think you and I have discussed, HealthCube, which is a way of doing this in the primary care level. And I think we need to allow these exercises to go forward and make the primary care possible. In the context of that, we'll be able to provide the data, which then allows the space to grow. But it would suffer if it was either choked by government regulation too early, or for lack of vision into what this can really progress into. So I'm hopeful that India will pick a pathway of saying, let a thousand flowers bloom here. I think we have lots of young people who are ready to code, but we don't have the systems that gives them the raw material to then build that into the insights that then become saleable, not just within India, but for the world. I think the next big AI in health company really should come out of India because we have all the ingredients for it.
Gentlemen, thank you very much. We are completely out of time. We'll end on that note. Possibly in India, we as a society, as an industry, actually have a choice which path to take. It is seeming like the COVID pandemic is increasingly making us question which path we want to take as we move forward. Thank you very much for your insights, for your questions, and for your frank comments. And hopefully we will select the right path. I'm not very sure what exactly that is, but hopefully it will be the right one. Thank you very much to the team at CII. Handing back over to you.
Thank you.
Thanks.
Thank you very much for an excellent panel.
Thank you so much, Pankaj. Thank you to all the panelists, and we hope to see you for our next session as well, which is beginning in another 10 minutes. Thank you. Thank you so much.
Thank you. Thank you.
Great session. Thank you. Thanks, Pankaj.
Hi, just testing if I am audible.
Yes, ma'am, you are audible, please.
I can hear you. Can you hear me? This is Glorian.
Hi, Dr. Glorian. Good evening. Yes, we
Good
can hear you, Dr. Glorian.
Good. Just checking the same. Thank you. I'll be ready.
Thank you.
Thanks. Thank you,
Is
everyone.
my video working okay? There you go. I'm on. Yep.
Yes, it's working fine.
Okay, great. Great. Thank you for the follow-up information you sent. That was very helpful.
Thank you so much, ma'am. We'll begin in another 10 minutes. Thank you.
Thank you so much.
Hi, am I audible? Dr. Yadav here.
Yes, Dr. Yadav, we can hear you.
Okay.
So there are lots of echo at your end. Have you connected from both device?
Hi, Anurag.
Hi, Sonalini.
Hi, Nirja. How are you? Is this
Anugrah.
Okay, okay. So, do I thought we was expected to join early. Is it too early?
No, we'll begin shortly in say 7 minutes.
So the session is from 6:30, right?
Yes, please.
Okay. Are we expected to turn our videos on, or is it okay because my internet is very choppy today? So turning the video on puts a lot of stress on it.
A very good evening to all the panelists. Ma'am, we are about to begin the session. Give us a minute, please. Thank you. Ma'am, may I also kindly request you to keep the videos on? It will help the viewers to see you. Thank you.
Am I audible? Yeah, thank you.
Good evening, Dr. Vipul. Good evening to all the panelists. We're just experiencing a slight snag on the moderator's end. So just give us 1-2 minutes and I think he should be in.
Yeah.
Good evening, everybody. This is Neerja from CII. We're very sorry for the slight delay. We're just waiting for Dr. Anupam Sehgal to join in. There's some technical glitch at his end. He should be joining any moment.
No issues. क्या करूं?
Dr. Agarwal, would you like to start with your presentation, please?
Yeah, madam, I think I would request you to kindly allow me to start because I have to leave for some place in next 10 minutes.
No problem. Just give us a moment. So, good evening, ladies and gentlemen. We have Dr. Vipul Agarwal, Deputy CEO of the National Health Authority, who will make a presentation. We just give us a moment. We're uploading it. Thank you.
Yeah.
Dr. Agarwal, the presentation is loaded. Over to you, please.
Yeah, thank you. So, good evening to all. I'm Dr. Vipul Agarwal. I'm an IPS officer from Gujarat cadre and presently serving as Deputy CEO in National Health Authority. National Health Authority is the implementing agency for world's biggest health insurance scheme, that is the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. And recently it has been given the responsibility of implementing the National Digital Health Mission, which was launched by Honorable Prime Minister on 15th of August. Now, the subject for discussion which has been given to me is the role of public-private partnership in ensuring a viable and sustainable public health infrastructure. Slide is not moving. Can we come to the next slide? Yeah, so if we see the current scenario, we have a physician density of 0.7 per thousand population, nurse and midwifery 2 per thousand, and the public expenditure on healthcare is dismal, around 1.28%, which is much below the international standards, and 70% as per 2014 data, 70% approximate of the expenditure on health is through the private sector. We are, if we see the health infrastructure to build a secondary care hospital, per bed expense comes out to be 25 lakh rupees, and for a tertiary care around 40 lakh rupees. So to reach to 1 bed per 1,000, we need around 3 lakh beds. And if we see the average cost of 25 lakh rupees, approximately 75,000 crore rupees is what we need. And in establishing a healthcare unit, we need land would cost around 15% of our total expenses, whereas the building development would involve 50% of the expenditure. Now, why do we need a public-private partnership in healthcare? So, as we can see in the slide, we through a partnership between public and private sector, we intend to improve the efficiency and innovation which happens in the private sector. That advantage can come on to us. We intend to achieve increase effectiveness, better quality. We intend, as we had recently in the last budget, we announced the viability gap funding for tier 2, tier 3 cities. So we wish to reduce rural-urban disparity in the accessibility and availability of healthcare. So we need to make healthcare more proactive and reduce OOPE, out-of-pocket expenditure on healthcare is another objective because every year approximately 60% of the expenses on healthcare is out of pocket, and around 6% of Indian population goes below poverty line, which was one of the objectives to be fulfilled in the national health policy to reduce this. An increased depth of public health scheme is another motive of a public-private partnership. So we have various models for PPPs existing in the country: operations and management related, BOT, design, build, finance, operate. We can give concessions to the private sector. We can provide land on lease. and they can be joint ventures. Next. So if we go to some examples of how public-private collaboration has worked in the COVID times that we are facing now, from a zero PPE kit manufacturer, India has become second largest manufacturer of PPE kits, and we manufacture around 4.5 lakh PPE kits per day. This has become possible only because of the collaboration between the government and the private sector. Hotels have been turned into quarantine centers. Private hotels have been onboarded. The mygov.in platform has been launched for innovative ideas to flow. ICMR and Bharat Biotech have gone for a collaboration to develop vaccine for COVID. Private labs are coming more and more forward to assist in COVID-19 testing. Then for awareness and capacity building, the NGOs are performing a wonderful role in the present times. And nutritional support to the needy has been also provided by the NGOs. So in terms of collaboration, philanthropic organizations and CSR finances are pouring in, and PM Cares Fund, as we all know, has become a channel for pulling in funds and providing to the needy. So what do we expect out of PPP? We intend to have an optimal utilization of resources and public money. We wish to create opportunities for the private sector to grow and for economic development, and to serve the best interests of the public sector and the community at large. Few examples of PPP in healthcare, as we see, mobile health units and voucher schemes have the intention of providing access for affordability. We have community-based health insurance schemes in place, providing autonomy to hospitals. Also, healthcare services establishment has increased efficiency. BOT models are financing models for outreach. We have social marketing and grassroots organization partnerships in place. Capacity building and involving corporate sector for providing technical strength, and traditionally public contracting has helped in risk transfer. So as I was mentioning that VGF has been introduced in the latest budget for setting up hospitals in PPP mode. And the government has also attempted in the latest budget to attach a medical college with existing district hospitals on PPP mode. So these are the few initiatives which have been recently adopted by the government. Plus, good example, as I mentioned, Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which I'll be covering in brief, also is a glaring example of PPP, and it is doing wonderfully well. PM National Dialysis Program, radiology diagnostic centers, and this example of ICMR Bharat Biotech collaboration that I mentioned. So what all areas can we go for PPPs in the healthcare? Include telemedicine. Recently, we all know that Arogya Setu has a link to Arogya Setu Mitra, through which we can access telemedicine. We can go to telemedicine platform, and many private players have launched their services on this platform. Pathology labs have been opened, can be opened in rural areas. We can run healthcare facilities. Maternity hospitals can come up in the urban, suburban, rural areas. We can provide ambulance services. Plus, private sector can also enter into supply chain management for drugs and consumables. And big data, artificial intelligence, and machine learning tools can also be deployed, and where private sector experience can be used. Now coming to the scheme that I am working in, Pradhan Mantri Jan Arogya Yojana. This was launched on 23rd of September 2018, and as I mentioned, it is the largest healthcare assurance scheme in the public sector in the world, with 54 crore beneficiaries, and we are providing a health cover of up to 5 lakh rupees per family per year. In this scheme, we have around 23,000 plus hospitals empaneled with us, of which approximately 11,000 hospitals, that is 45% odd, are private hospitals. So we are providing secondary and tertiary care hospitalization, and it is an entitlement-based scheme. As I mentioned, all the beneficiaries are priorly listed, and no beneficiary can be added. It is based on 2011 socioeconomic caste census data. So next, please. So as I stated, 45% of the hospitals are in the private sector. More than 1.2 crore hospital admissions have been made. In fact, had we not had faced this COVID time, we would have reached 1 crore hospitalization in February itself. So now we are targeting that next year we should have 2 crore hospitalizations at least coming in 2021. And we are also coming up with partnerships with private sector. For example, we are launching insurance pilots to improve the capacities of private healthcare insurance schemes, insurance service providers, and companies like Uber and Aitva have approached us, and we are providing a platform to them for operating the healthcare scheme for their beneficiaries. So key considerations while we run a PPP model is we should have a standard operation guidelines. We should have sustainable quality services, and the model should be scalable and replicable. We should monitor the performance on a continuous basis, and the private player should also have a opportunity and provisioning for smooth exit while sustaining the best practices that we learn out of this arrangement. Looking forward, what we can restructure and reorganize the existing health infrastructure at all levels through public-private partnership, and this can enable us to reduce inequalities and regional imbalances in the health sector. I think that's it. Thank you very much. Thanks for giving me a chance to talk to you. Thank you very much.
Thank you very much, Dr. Vipul. My apologies, there was a glitch in the system, and so I could just join a few minutes ago, but I joined just as your presentation was starting. Thanks ever so much for an excellent overview. And it's really nice to have a doctor who's also an IPS officer and has such an impressive track record as an administrator. And it's great to have you in the National Health Authority. Thank you so much for setting the stage really for our discussion. Now, if any country needs a public-private partnership, it's India, because, you know, we spend very little in terms of public spending. It's just 1% of the GDP. And as a nation, we just about spend 5.2% of our GDP on healthcare, and contrast that with Europe. Most of the European countries at 9%, 11%, was at 17%. So when these Western countries struggled with COVID, you can just imagine the challenges that we had to face. But fortunately, you know, to go from 560 to 2.7 million cases, and that's when the lockdown started. We took 146 days as against the US taking 115 days. And those 31 days, I think, allowed us to ramp up. And Vipul just mentioned the vibrancy of the public-private partnership that we've seen in the last few months. Just to give you an example, if you look at the ICU beds in the country, 94,000, of which 35,000 are public, rest private. If you look at the number of ventilators out of 47,000, 17,000 public, rest private. And then different state governments started to ramp up, and when we looked at the number of COVID beds, we finally got a situation where the public beds increased. But the government recognized the importance of bringing the private sector, whether it was testing, whether it was for ICU, whether it was for, you know, building capacity in terms of training and so on and so forth. And I think what COVID-19 has really taught us is that if we are to progress, then we have to work hand in hand, because we cannot ignore the fact that 70% of healthcare delivery in our country is through the private sector, whether it's organized or unorganized. And that really is the point that we are trying to discuss today is what can we learn from different countries? What can we look at different examples to see how we might be able to further this relationship? And we really have a very stellar panel. And it's a great privilege for me to introduce Professor Sorensen, who's a professor of social and behavioral science at the Howard T. Chan School of Public Health and director of the Howard Chan Center for Work, Health and Wellbeing. A very impressive credential from Professor Sorensen. She also directs the Center for Community-Based Research at the Dana-Farber Cancer Institute. And there's a very strong India connect. As I was reviewing that, her work in India started way back in 2003 with tobacco control, and that has grown across the different states of the country. And Dr. Sorensen and her research team were among the first to demonstrate the integration of occupational health and safety with worksite health promotion can significantly enhance health behavior among blue-collar workers. So a privilege to have you, Professor Sorensen. You also have Professor Yadav, who's a professor of community medicine at the Marsha University, Malaysia, with more than 40 years of experience in the field of public health, both in Malaysia and internationally, having worked for UNICEF, WHO, the Swedish government in primary healthcare, maternal child healthcare. He brings a lot of knowledge with him. Thank you, Dr. Yadav. We have Professor Rusli bin Nordin, again from Malaysia, head of School of Medicine, Faculty of Medicine, Taylor's University. He's previously been at the Monash University. He's on the editorial board of several international journals, has publications. Ms. Nidhi Pundir, who is the global head of CSR for HCL. HCL is a very respected IT company with revenues of close to $10 billion. She leads the HCL Foundation, HCL Uday, and the Power of One, and has in the past been a global advisor on child protection in development with Plan International's international headquarters in the United Kingdom, and has had a leadership position with the SOS Children's Villages Asia. We have Ms. Sangeeta Patel. She's the Health Office Director of USAID, and USAID is an organization that has received recognition globally for the amazing work they do. Numerous projects in India, and Ms. Patel, who's a US Senior Foreign Service Officer, assumed her duties in India in July 2019. She served in Pakistan, Zambia, Armenia, Namibia, and Washington, D.C., and has been with USAID for 20 years. So a huge amounts of experience. Delighted to welcome you, Ms. Patel. And we have Ms. Sonalini Khetrapal, who's a health specialist at the Asian Development Bank, with experience of health economics and an MPH. She again brings a lot of experience and knowledge, having worked in public-private partnerships, health financing, and international development. So what we are hoping from this eminent panel is to try and get answers to some key questions. Can a PPP model be effective? Is it viable in the long term? And while the government ensures it protects the interests of the public at large, when you actually set up a PPP, does it really work like that? And, are the interests of the private sector also addressed when you create this? So I'm going to request the panelists to give their remarks, and then if we have some time, then perhaps a question or two. We'd like to start with Professor Sorensen. Over to you, Professor Sorensen.
Thank you so much. I'm delighted to be a part of this very stellar panel and to participate in this very important conversation. I would like to make my rather brief remarks on a slightly different part of this relationship in the private-public partnerships. I believe that we start our effort in our collaborative efforts like this where we have shared interests and shared goals. And I believe that the COVID pandemic has raised a particular, highlighted particularly one goal that public and private institutions share very clearly, and that is the health, safety, and well-being of our workforce. We have seen, particularly during this pandemic, that essential workers are at particular risk and are absolutely pivotal, not only to providing care to those people who are ill, but also for those of us who need to be sheltered in place, how to bring services such as delivery services, groceries, whatever is needed to make sure that we have an operating society. So our Center for Work Health and Wellbeing focuses particularly on what can we actually do to ensure that that organizations are providing the infrastructure for workers to actually remain safe and healthy during this critical time. And it begins by creating an infrastructure within the workplace that focuses very heavily on working conditions. The question being, how can employers, whether they're in the private or public sector, or even coming together around this, how can employers create a working environment that supports worker safety, health, and well-being? And we look at that in a couple of ways. Part of it is certainly the physical work environment, and we've seen that during COVID with the focus on PPEs, on new kinds of barriers to protect workers during their work times, and other approaches to really create that safe, healthy environment. But we also see on the organizational level that factors like work hours and schedules really matter, that it can play a role not only during COVID, but at other times when we know that the organizational infrastructure really influences worker health outcomes. There's also a component around the psychosocial pieces. How can we ensure that we're providing workers with a healthy environment that feels supportive by their employers, whether it's supervisor support that addresses the fears that come to bear during time of COVID, or other times when people are actually working on a day-to-day basis and really value that sense of support and camaraderie from coworkers. Employers can play a huge role in this process, and this public-private partnership approach can really bring new resources to this kind of a dialogue. I think that there are important value added for businesses overall in considering this that may include increasing the effectiveness of the approaches that they're using to actually support worker safety, health, and well-being, managing costs and actually even increasing revenues, and certainly in the long run promoting brand reputation. So I think there is an enormous opportunity right now to really look at these kinds of issues as we focus particularly on the essential workforce. Thank you very much.
Thank you so much, Professor Sorensen. I'm going to now request Ms. Nidhi Pundir to give her remarks, please.
Thank you so much for that intervention, and thanks, Anupam, for inviting. I think we've already kind of discussed in terms of the out-of-pocket expense, and I think that's very critical when it comes to the communities where we are working, be it rural communities or urban communities. And since, from the CSR work that we do, we try to reach the last mile. And of course, COVID pandemic is one situation, but I'm going to address the public health scenario in general, because we do have so many other issues which we had been already working on. So I think in terms of strengthening the public health care system and taking it from the system's perspective, a lot has happened in the corporate sector, especially through CSR. They have invested a lot. Even otherwise, I would say, in terms of extending the reach, and as you said in the beginning, Anupam, that very significantly high percentage of healthcare delivery happens through the private sector. Having said that, I think there's still a very large population, and if we talk about countries like ours, India, where there is a significant, I would say, take any data and it's huge. It's big. If I threw figures, it would be like, unfair, because every time these figures, and some of the issues, for example, we've been working on maternal and child health, reproductive healthcare services, the issue of nutrition, the issue of first 1,000 days of care, the psychosocial support, the geriatric healthcare, the communicable diseases. Yes, there has been a lot of movement, but what about the non-communicable diseases? So while we do see that the the public-private partnership model, has been quite successful, and there have been significant investments, I think, and that has led to a very good outreach. And we have seen during COVID also, I think everybody came together and worked, and convergence has been the key. But then in general, if you took the larger healthcare scenario, we have, I think, a very long road to travel still. A couple of challenges that one faces while implementing the PPP models in good taste is the distribution of responsibilities. That's something which is never clear. Perhaps from the CSR perspective, we would approach the government. At times, government will approach us from an agenda if there's a gap exercise. But there are very few models available in the country where one comes on a common table and plans it in favor of the communities who need the services from the demand supply gap perspective when I'm mentioning this. And that's where I think there is a big need for us to actually co-create models which are essentially addressing, think about the tribal communities, think about migrant communities, think about urban slums, think about, unreached areas in Northeast. Some of the work that we are doing, we would travel 18 hours on road to reach one PHC. Just imagine for an institutional delivery, could a mother ever reach that PHC, and hence the rate of institutional delivery, so poor. Some of the corporates like us, we have taken some very challenging, I would say, projects where we've not hesitated to cross our, the local, I would say, boundaries of our districts or states, and we have reached the unreached areas. But there is a need, perhaps, to work very closely with the government and attract private funding to these areas. I fully understand that. From the profit making perspective, it may not be very viable to begin with, and one would need to invest both from government resources as well as from the point of view of CSR investments or private investments. But there is a vast population out there which does remain, I would say, where excess is an issue. If excess is there, I mean, Arunachal Pradesh, classic example. We've walked with the communities where and the the ANMs and ASHA workers who have to travel miles together or cross rivers just to maintain and with the cold chain to maintain the immunization chain going. So we still have those territories, those geographies. That is due to geographic difficulty, but also what about urban slums? I mean, a recent study that we've been doing, we discovered that more than 24% of young men and women are getting married before legal age, and before 20 they have the woman has the first child. So this whole issue of the couple protection rate that we are talking about, or let's say unwanted pregnancies that we are talking about, which is leading to a big population outburst, these are the areas where we would really need to create effective private partnerships, effective models where responsibilities are clearly divided. Civil societies and NGOs do a phenomenally good job in terms of awareness creation, getting inside the communities, working with them. And government, of course, brings in the right kind of governance and right kind of, I would say, structure. They would essentially need help to reach some of these communities. I mean, that has been our experience, that we've been quite instrumental through our CSR work in increasing the reach. And that's where I think we would really need to scale that up. So while I've brought in some of these challenges, um, you know, uh, and that's mainly from the experience of working on ground. The some of the parts where I would see the PPP models really getting more and more effective is the equity, and that's where we still I think need a lot of work. District-wide approaches are working. I would say community-based approaches are working, but a larger movement as to strategic movement, if we were to say, I think we are yet to see. COVID, I would urge to be treated differently. That has been a different example altogether, and that the good news is that yes, we got together and we've actually worked quite well, irrespective from where the investment came. It did come because it was a global pandemic, and I think as a country we've stood quite strong, and we still have a long way to go. We really don't know. So I would stop here, and then maybe as and when there are more questions, take them up. Thank you.
Thank you so much, Nidhi. Very interesting perspective from the ground. May I now invite Ms. Sangeeta Patel from USAID for her remarks, please.
Thank you. So thank you very much, first off, Anupam, for just having me speak with this esteemed panel. I'd really like to just share a few thoughts and perspectives from perhaps the donor, or USAID, the U.S. Agency for International Development. So for us, private sector engagement is a must. It's critical, and it's really embodied in everything that we do, from the agency at a headquarters level in Washington, D.C., on down to every mission. We have a private sector engagement policy writ large, but even as a mission here in India, pretty much we have a document called a Country Development Cooperation Strategy. It's accessible to all, even externally. And it really outlines all of our development work here in India. And what you'll see throughout is one core theme, and that is in India in particular, because of our partnership, and really not one where we are providers of just technical assistance. We're partners. We really like to see true engagement with the private sector. I think, as was already alluded to earlier, there's so many reasons to partner with the private sector, including enhanced efficiencies, being able to really harness innovation, and truly bring a certain amount, I would say, of discipline. I think that the private sector brings a certain amount of discipline in investing funds together and bringing on a new level of accountability and really maximizing, I would say, impact, really looking at positive returns and shared values and interests. For us, one of the first things I think that we realized was that India's always been a leader writ large, but particularly since April of 2014, with being one of the first countries in the world really to legally mandate corporate social responsibility. It brings a whole new spin on thinking from the paradigm of either or. For us, it's no longer either or, but really about being able to consider how we can work with the public sector, the private sector, as well as development partners together for shared objectives. Now, a lot of times we need to find that area of consensus, right? It's not always possible. Always people think in terms of the private sector as one that's looking for a profit. And people think in terms of government or development partners perhaps is more on the social end. But there is an area in between where we should be able to and can find shared values and interests. For USAID, it's always been first and foremost to find that area of shared interest, but also to be able to lead from the perspective of inclusive development. So what you'll find in our partnering with the private sector is a need to really co-create, co-design, and also include beneficiaries as part of that process so that we're not left creating something in the end that's really of no interest or even of no impact ultimately for beneficiaries. We've done a lot of research into this and have good examples where we have partnered with the private sector successfully. It's been a part, of course, of the unique role that USAID has played. After spending about 70 years in India on development, we found a lot of areas where we've had shared interests and values with the government of India, especially in the health sector, in areas like eliminating TB or preventing, of course, maternal and child deaths, even eradicating polio. These are specific areas, but what I would say is with the advent of especially the fourth industrial revolution and really looking at the blurring of lines, as we just got out of an AI session between physical, digital, and biological spheres. What we realize now is that this kind of innovation and the speed with which it's occurring, it's not only caused us to be in a tailspin in terms of how technology is used in the health sector, but it's also requiring us to think and adapt and work in completely new and different ways. COVID-19 right now has created a new normal. So we're adapting, right? We heard August 15th, going digital, national health mission and really embracing that concept. I think with that, we have to consider new and creative ways in which we work with the private sector. For USAID, we've already, in many ways, done this. We've worked already in Rajasthan with the Development Impact Bond to be able to improve the quality of maternal and child health, particularly in private facilities. We've been able to find a gap in the public system, work with the private sector, bring in different partners such as Merck and the others such as USB, and be able to, UBS Optimus Foundation, and really be able to look at how can we, with different inputs and even with an external third party, verify that results are being obtained, that we can upgrade private facilities, and that in the end that there's a certain amount of quality of care that is really accessible even now to the most marginalized. In addition to this, we've also work with the Wadhwani Institute of Sustainable Health Foundation. And really, I think this has been a tremendous venture, particularly in the area of primary health care. For us, it's been amazing in certain states like Madhya Pradesh, Rajasthan, even Assam, to really be able to have such an innovator, be able to think creatively, and be given that space, even by the government of India, to say, okay, try new things, be able to introduce new products, push the envelope when it comes to diagnostics and screening and care. And let's figure out how we can innovate, try new models, and really be able to improve really the quality in what were perceived to be defunct health and wellness centers. So for me, this is a practical example, particularly in primary healthcare. I say you could take any development challenge, even COVID-19. Right now with the National Health Authority, we're considering ways that USAID could work, in particular with our partners, to create a blended financing facility. For what purpose? To crowd in resources and really be able to ultimately support the government of India in its goals to be more resilient and responsive right now for COVID-19, but even for in the future for secondary and tertiary facilities. I think at the end of the day, if we can't find a way to work creatively with the private sector and we don't also merge that with our intentions in the public sector, especially with the technological revolution right now, we'll be left behind. Thank you.
Thank you so much, Sangeeta. And we now move on to Sonalini Khetrapal from the Asian Development Bank. Over to you, Sonalini.
Thank you, Anupam. Thank you so much for having me on this esteemed panel. I will start by pointing to the National Health Policy, which really laid the foundation of encouraging private sector engagement within public sector delivery. And Ayushman Bharat further gave us a framework to operationalize that by building continuum of care through health and wellness center and thereafter secondary and tertiary care delivery through PMJ, which we heard of earlier, and how that is being mobilized through increased private sector engagement. ADB has been involved in the National Health Mission, and within that, the National Urban Health Mission since 2015. And National Urban Health Mission has had the luxury of a slightly more flexible implementation framework, which allows for more engagement with the private sector. And in fact, we have seen that increasingly happen over the last 4 to 5 years, but more so in the last year or two, where there have been able to develop capacity to be able to build these kinds of relationships and contractual arrangements to be able to thereafter deliver services which are slightly more sophisticated in their craft, as opposed to just allocating task-based services for private sector engagement, for example, contracting in specialty services or contracting out certain elements of service delivery, which we've been seeing happening in the Indian healthcare delivery for an extended period of time now. So it's not something that is unique to the advent of Ayushman Bharat or increased focus on public-private partnerships we are beginning to see now. That is something that's been happening. But what we do see now happening more is an increased focus. And with our support in NUHM, ADB has specifically, we had a $300 million loan specific to the National Urban Health Mission, and we are extending that support for the urban health delivery for our upcoming loan, which is amounting to 500 million. And within this whole framework of implementation across these both loans, private sector engagement continued to be a very important element that we continue to support. And there are a couple of reasons why it's essential for establishing, widening, and strengthening PPPs in the urban healthcare delivery. First, the government recognizes this very well, that there is an availability of providers in the urban healthcare scenario, which makes the market competitive enough to effectively design these contractual arrangements. Second, there are resource constraints that need to explore innovative financing mechanisms and a pooling of resources across
both public and private sectors to bring about an overall improvement and probably transformative change leading from that. And third, given that there's a huge, rapidly urbanizing population, and with that, there's an increasing need for health services, the government has faced constraints in expanding the delivery, the public sector delivery in tandem to that increased urbanization, and to be able to keep pace with that. And I think we've seen that in the COVID sort of response in the urban areas, because the focus of the National Health Vision or the public health sector delivery in India had largely been on the rural sector, except COVID was largely focused as an urban challenge, when it's initially started. So we saw a clear gap in public sector delivery there, and we also saw how private sector effectively stepped in for service delivery sort of elements to be able to fill in the gaps in testing, to be able to do effective contact tracing, to be able to do effective community engagement through NGOs or other partners or CSO sort of functions that we saw stepping in to fill that existing gap. And this has been a challenge because getting the private sector to engage in the urban health context is something that the government is starting to look at very closely, and we, along with the government as partners who've been very active in this space, are starting to now realign our priorities, catering around the specific agenda. Um, Also, human resources is a huge challenge in public sector delivery, and the government recruitment is usually complex and time consuming, and in many cases is hampered by restrictions on remuneration and availability of specialists, especially in certain geographical locations. So the private sector kind of circumvents those challenges, which probably relate to human resources or to availability of land, to be able to acquire that, to build services, to be able to, set in processes, to be able to maybe deliver care more effectively. And I think we've heard the word innovation mentioned by every other panelist today in engaging with the private sector. So apart from all these push factors that I just mentioned, the other pull factors, obviously, with the private sector engagement would include adaptation or easier adaptation of technological transformation. Processes are sometimes much, much better adapted because we've seen that in some of these examples in national urban healthcare delivery, for example, in Nagpur, how private sector is engaging to set better governance models, not just financing, but better governance to be able to bring those practices in public sector delivery, which is a missing link, because it's not just about money. Sometimes it's also about setting in processes that can be adapted better from the private sector delivery. Now, given that in the urban health, PPPs are something that have continued to be a very, very attractive option. What are the things that we need to consider as we start to engage? One of the main key elements is that we need to understanding where PPPs can, or what can and they cannot do, where they do work and where they don't work. I think that's something that all partners and stakeholders need to recognize as we start engaging more with public-private partnerships. There has to be a realistic assessment and allocation of required resources and remuneration and incentives need to be very well crafted to make the partnership sustainable over time and attractive for all parties involved. Also, there should be a very clear demarcation of rules, responsibilities, and a factor of trust. I think this was brought up earlier as well. The level of trust that we should not necessarily think that the private sector is out there to make a profit. It's very important to recognize them as an equal partner in being able to deliver services and care, and also to be able to adapt to or change course midway, which would probably mean that probably experimenting with shorter term contracts initially and then expanding the scope of those arrangements depending on how the transactional contractual relationship is panning out over the association. Now, we have been supporting with some elements of that within the urban health sector delivery. In addition to that, we've also been supporting the National Health Agency, NHA, in implementing PMJ, and within that, we've been looking at, PMJ, the whole largely it's built heavily on private sector engagement. So we've been looking at how we can incentivize the private sector in tier 2 and tier 3 cities to be able to act as providers where, there is a clear gap in provision, because you see a lot of concentration of private sector facilities in tier 1 cities, but there's a gap in tier 2 and tier 3 cities. So we are working closely with NHA on how that can be incentivized. So largely, I think we're working across all elements of Ayushman Bharat, primary, secondary, and tertiary, in increased private sector engagement. Thank you, Anupam.
Thanks so much. Thanks so much, Nalini. Thank you very much. Very interesting perspective. I'm going to invite Professor Yadav now for his remarks. Professor Yadav. Professor Yadav, could you come in, please? Please go ahead. Right here.
Can you hear me?
Yes, we can.
I think I'm having a major Wi-Fi internet problems here. I don't know.
We can hear you. Please go ahead.
Whether you can hear me.
I can hear you.
Yeah, okay. I basically, I think most of the speakers, first of all, thank you. Speakers have covered most of the topics, what I'm thinking. I'm having a bad echo. I think I'm going to be difficult to. Anyway, I'll try my best. I think one of the problems of PPP, actually, the reason why we are having PPP actually is the inefficient healthcare systems, which we notice all over the world, inefficient healthcare systems in terms of how the resources are actually distributed. The World Health Report reports that estimated 20 to 40% of the health sector resources are wasted, and the way inefficiencies in the medical care system, both in the hospital as well as in the healthcare sector. The second is the financial hardship in terms of application of PPP. Financial hardship of the amount of money spent on relative to the income, the amount of income that households retain after health spending or some other criteria. And basically getting PPP done is the commitment from the Ministry of Health. I think one of the most difficult components is the commitment from the Ministry of Health. Lack of commitment from the government to deliver the health for all, low per capita health expenditure, lack of a comprehensive delivery of services, and equity of health services throughout the country. So in terms of leadership, commitment from the Ministry of Health in terms of doing the PPP is one of the most important issues. Secondly is the financial coverage. Who is going to cover the finances aspect of this PPP? If you're going to have the Ministry of Health cover, which is already being loaded with the money in terms of cost of care, that's going to be very difficult. So the private public partnership in terms of financial coverage. So the poor and the vulnerable should be covered in the PPP, especially in the primary healthcare system, because we have the government sector providing the primary, secondary, and tertiary healthcare system, whereas the public sector mainly provides the the secondary and the tertiary healthcare system. So the major component where the majority of the people are in the rural areas, the primary healthcare component is not covered fully, and that aspect where the public sector can come in and help out in terms of that. The second is the coverage in terms of PPP, health insurance coverage. Right now we have health insurance coverage to those people who are eligible, but how are we going to get involved the health insurance for the formal sector as well as the civil sector? And we have to start covering all the sector in terms of the financial coverage. And of course, the availability of services, basic healthcare services to provide through health centers, increase coverage to rural areas. And when I talk about rural areas in terms of health centers, etc., how can the government sector or the public sector help in terms of the delivery of care to the rural areas through the private public sector? Expanded, the second is the secondary healthcare through the district hospitals. We have secondary healthcare being provided in the district hospitals, improve infrastructure and quality of services being provided. And finally, financial coverage, financial accessibility. Accessibility of care is one of the biggest problems in the PPP because increase of percentage of GDP on health, increase per capita on health, reduce inequity of financial health sector and availability of medicines for the public, and reduce financial burden by reducing out-of-pocket expenditure. So one of the biggest problems is out-of-pocket expenditure. Majority of the developing countries have out-of-pocket expenditure. So if we were to have the PPP system, how can we overcome this, either through the general insurance or otherwise? So basically, biggest problem in terms of having this PPP is inequity and inequality. Are we really delivering the inequity and inequality? And the cost of care is going up in the world as a percentage of GDP. And private sector mainly provides secondary care and profit-oriented, whereas the public sector is actually provides health for all. Although there are several benefits in terms of the PPP, improving equity, better access to healthcare, efficiency of cost, better quality of care, continuity of care, etc. But one of the problems of this PPP is actually, even if we have any form of delivery of care through what they call better access in terms of mutual commitment or shared decision making or better coverage, I think one of the biggest problems will be the legal issues. Some of these legal issues will come in the picture. Who is going to be responsible for these legal issues? Who is going to take the responsibility of any problems in this PPP? And trust of the public and private sector, whether the trust can be delivered or not. And third is the issue of misuse of funds. There's a high possibility, although the public and private sector may be involving certain funds in terms of delivery of care, where there will be possibility of misuse of funds and getting the best out of the limited amount of resources available. So public funding, in terms of public funding in PPP, we can do is contract out services from the public to private sector, PHC services, for instance, or joint venture of the public and private sector, or telemedicine, private care. We have an experience with the telemedicine in the private sector, but we had a lot of legal issues in terms of telemedicine being delivered by the Ministry of Health to the private sector. But when it came to the diagnosis and treatment, the issue of legality came in the picture, is who is responsible for what, and that became a problem in terms of PPP delivery of care to the private sector. Of course, the other is franchising. Franchising can be done by both the public and private in terms of private financing, franchising services to the public sector as well, or to the private sector. And when you franchise services, for instance, in terms of taking care of preventive diseases, then again the issue or responsibility comes in the picture. And of course, we can use the public sector in terms of mobile services to rural areas and deliver. So working together is not an issue, but getting the leadership issues and the commitment from Ministry of Health, and mainly the finance aspect of this, is going to be a problem. I think one of the benefits in terms, we actually started in terms of continuity of care both in the private and public sector, and we introduced what is known as the AI system, artificial intelligence, in terms of the patient care, to make sure that the patient going in the private sector or the public sector is able to get the same treatment through a record system, which is actually shared by both the private and public sector. But when it came to the costing, it became a problem as well. And secondly, the confidentiality of the patient became an issue as well. So that's one of the things which is... But some of the examples: contracting management of primary healthcare to private sector, free diagnosis, consultation, treatment of basic care. I had personal experience of specialists giving care in hospitals from the private to the public hospitals where there are, what do you call, the specialist comes and takes care of special services in the hospital, which free of cost, although there was not much, I think, but became an issue in terms of finance again by the Ministry of Health. So there are several ways of getting PPP being this thing, but my biggest concern is actually what I mentioned earlier is the legality issues, the trust of the public and private sector, the issue of misuse of funds in this type of thing, and getting the sector right. I don't think that PPP can be a major, go as a one shot, but I think we need to take in steps, in slow stages in terms of what needs to be covered and what needs not to be covered. So with that, thank you for again, and I'm ready for any question and answers. Thank you so much. Sorry for the connection. I think I have a bad connection today.
Dr. Sibul, you'll have to.
Thanks, Dr. Yadav. I was saying, yeah, we did manage to hear you. And, given the fact that we are running, behind time, I don't think we'll have an opportunity to ask you any questions. So a big thank you on behalf of CII to Dr. Yadav, to Professor Sorensen, to Sangeeta, to Nalini and Nidhi for joining us, and Dr. Agarwal. Thanks ever so much. And I think with this, we bring this to a close. Thank you.
Thank you.
Thank you.
Thank you so much, Dr. Sibul. We'll be in touch, and I will request all our panelists to please join us for the remaining days of the Healthcare Week. Thank you. Have a good day.
Thank you.